Okay, good morning, ladies and gentlemen. We are going to begin. Welcome back, and welcome back to everyone who's watching from wherever you are on the webcast. Today, our plan is CBT integration. Today we take what we described yesterday, the foundation that we described yesterday, and we apply it to individual psychopathologies in a more direct way. So our plan for today is we're going to deal with sleep and insomnia, and we'll see why that's an important component of work across psychopathologies. That's number one. We're going to move on to depression and suicide. We're going to contextualize some of the modifiable risk factors of suicide within the treatment of depression. So it'll be like a two-step process, our discussion about depression. We'll deal with anger, although anger is not a diagnosable condition, even though it should be sometimes. It used to be, right? There was that DSM-3, I believe, classification of passive-aggressive personality, but they took pieces of it and they spread it out throughout other access to disorders. But we'll deal with anger briefly and an interesting cognitive model of anger and how we could help clients overcome or intervene. We'll deal with anxiety. All right, we'll deal with multiple types of anxiety, from generalized anxiety disorder, specific phobias, OCD, social anxiety, and in each we'll see again how the cognitive model conceptualizes it and what kind of interventions both on the cognitive and on the behavioral front that we will suggest. We'll deal with family and family turmoil. And this is going to be not just about people working with families, but even working with individuals. Family-related issues often come up, utilizing family for support. All right, so when we talk about the behavioral part of work across psychopathologies, if we are able to create a supportive environment, that's part of the work that we'll do, and we'll do some assessments of family dynamics and things like that. In the afternoon, we'll hit memory and trauma. We're going to contextualize work on trauma within the way memory works. So what we're going to learn is that beyond the classical conditioning features that we described yesterday, things are happening on a memory front that are crucial to the process, and we're going to deal with that as well. And then we're going to wrap up the day and our seminar with personality disorders. We are particularly going to focus on borderline personality disorder. That's the one that we're most likely to see, inpatient and outpatient. So we'll end with borderline. I think it's appropriate to end on borderline because they have tough times ending things. All right, so that is our plan for today. Any thoughts or questions before we begin? Yes?
Well, most of the techniques and things that we work on with borderlines, would they also work with narcissism?
Is that a question or a statement?
It's a question. Would these same things be?
Could be, right? There's definitely some overlap, right, within those categories of personality disorders. So we'll see if we could link them. You'll remind us to make that link for sure. All right? Very good. So now let's get into the specifics. Let's get to sleep and insomnia. Why do we talk about sleep and insomnia? And there's a lot of great developments now about CBTI. CBTI is a relatively new, at least area of research. There's a lot of good work now about using cognitive behavior therapy for insomnia. There's a whole program known as CBTI. Let's talk about why it's important. Why is this a crucial part of intervention, not just for people with insomnia? Because what we know is that sleep interferences are mediators and or moderators of most psychopathologies. Let me explain these two words over here. They're mediators or moderators of most psychopathologies. Let's explain what that is, all right? Just very briefly in terms of mediator, moderator, a mediator is when if you find a relationship between A and C, let's say, all right? So there's some kind of condition and then there's some kind of outcome. When you have a mediator there, what we're basically saying is that the entire outcome is ultimately really dependent on the mediator. Meaning the relationship between A and C exclusively goes through B. That's a mediator. When we go back to, if you remember, from a graduate course in research methods, I'm sure you've dealt with mediator, moderator, how you do it statistically, right? But mediators mean that the entire way in which A influences C goes through B. Without B, there would be no relationship there. So that is one thing that we find when it comes to sleep and psychopathology, that sometimes clients coming in with problems, ultimately the real issue is the sleep-related issue. And if we're able to deal with the sleep-related issue, it all goes away. Now, that's not always the case, obviously, but it's definitely a piece of the puzzle, that it is exclusively what we need to focus on. Once you get sleep, because when people are chronically underslept, they have insomnia, all these other issues come up. Depression, anxiety, you're just not sleeping, you just can't handle it. And you work on that, and somehow all these other pieces go away. Why? Because in these cases, sleep disturbances were the mediators. It was all about the sleep. Now, that's not the only thing that you're going to find. Most of the time, probably it's more of a moderator. What does it mean, a moderator? Moderator means that, yes, there's a relationship between A and C. What does B, the moderator, do? It moderates it. What does that mean? It's like a dial tone. It can make it higher. It can make it lower. It impacts the strength of the relationship between A and C. How strong is A going to impact C? How strong is the depression going to impact all these negative outcomes? How strong is the anxiety going to impact all these negative? How strong is it going to be? Well, sleep is like a dial tone, right? It's like a volume. It could be high, it could be low. Based on the sleep problem, the original problem, the depression, the psychopathology, right, with anxiety, that is going to impact these negative outcomes in different levels, which is why in either one of these models, if sleep in your client is a mediator, meaning that's exclusively what we need to be focusing on, or if it's a moderator, with most of the time it's going to be more of a moderator. But even if it's a moderator, we want to be able to minimize, not get rid of completely, we want to minimize the impact that the anxiety, the depression is having. And we do that by focusing also on the sleep-related issue, because that'll tone things down. Things obviously will still exist, but they're toned down. And now I'm able to work on the other components in a clearer, better way, because I've focused on minimizing as much as we can by also working on the sleep-related issues, all right? Which is why issues with sleep and insomnia is not just for people who come in exclusively for insomnia. Other psychopathologies across the board are going to be impacted in some way, either as a mediator or as a moderator on the outcome. So focusing on it is very, very important for us. Most of my clients who come in, regardless of the issue, one of the first things that I cover for them at intake is tell me about your sleep. How are you sleeping? Describe for me, are you sleeping well? When you wake up in the morning, do you feel refreshed? Did you wake up before you wanted to go to sleep, right? So we're going to talk about the details, but it's very important to include that in the intake and to focus on that also in helping clients develop better sleep routines so they sleep better. Now, how does that done? So let's get into the measurement of it. And then we'll move on to the intervention of it, to the components of CBTI. We're going to talk, there's several components of CBTI. I chose here 3 of the main 6 components of CBTI to describe here, okay? You start off with a sleep assessment. Start off by measuring your client's sleep. Now, how's that done? Let's first describe it, and then we'll give you an actual measure. You want to have a comprehensive assessment which informs what and in what order CBTI treatment components are delivered. Right? You're going to see that CBTI has several components. You can deliver them in various orders. You can deliver some and not others. The way you determine this is by, first of all, getting a very clear baseline, a measure of sleep, and then based on the results of the measure, you now are able to tailor the intervention according to your individual client's needs. Daily monitoring of sleep for baseline and treatment progress, right? It's not just for baseline, to know what and in what order, but it's also treatment progress. What you do is, after you've intervened with these CBTI components, and after the client is slowly integrating these things, now they're only going to integrate it, as we're going to see, they're going to integrate it incrementally. It goes back to shaping towards the target, right? It goes back to B.F. Skinner. It goes back to the pigeons in the Skinnerian box, right? The way we're going to do this is we have to shape towards a target, because some of these things are targets that they can hit overnight. So you shape towards the target, and we'll talk about that. But as you're infusing the CBTI components and they shape towards the target, and then 6 weeks later, 8 weeks later, you want to be able to see that these components are actually impacting your client. And then you give them, once again, this measure, and then you're able to have a baseline and a comparison. All right? Keep in mind that there's a great app, and we've highlighted this yesterday, the CBTI Coach app. And what we're going to talk about now in terms of the measurement of it, the assessment of it, and also the intervention components, the app links very, very nicely with the components and with the measurement of it. The measurement could be done on the app. The tracking of progress could be done on the app. So keep that in mind, that this is a very, very good app that links very, very tightly with the actual intervention. But before we get into the intervention, let's begin with the assessment information. All right, let's jump to the back of the book. Let's go to our measurements in the back of the book, to the sleep consensus, the consensus sleep diary. And you'll find it in the back of the book on page 55. Page 55, the fourth of the measures, page 55. And let's describe what we have here. All right, so you see here you have a table. I give you here only 4 days of data. What you would want to do is you could print it out in landscape and have it, or give them several pages. You want to get about a week or 2 weeks of a baseline. Usually a week is all you need to see trends. And what does the client have to do? You give them this table, and you basically have them in each column report about this previous day. So when they wake up in the morning, they have to answer what just happened overnight and the day before, right? So they fill this out in the morning, and they have to answer a series of questions about their sleep, and each column represents a day. So you see over here, I filled out already one day as an example. So you fill out, so you see them on Tuesday, so you fill out the next day, Wednesday, Thursday, you put the date, and then they have 7 columns, and they need to fill out every morning. What questions do you ask them? What time did you get into bed? What time did you try to go to sleep, right? What we're going to notice is that sometimes you go to bed, but you don't try to go to sleep yet. Why are you going to bed? You're watching TV, you're on the phone, you're on your laptop, whatever you're doing in bed for about an hour or 2 hours. And this is going to be an important piece of data to see if there's a pattern of going to bed before you're ready to go to sleep, because that's no good. Why? Because we want to try to create an association between bed and sleep. Goes back to classical conditioning, right? We want to create an association between the two. But if you're going to bed and doing all these other things in bed, so your association is not bed-sleep, but we want to tighten that association. So the answer 1 and 2 is going to give us an idea about, do we maybe need to start with one of the 6 components? We'll share with you here 3 of them, 3 of the big ones, because this is an issue over here, all right? Question number 3, how long did it take you to fall asleep? So once you've determined, okay, it's time to go to sleep, how long did that take you to actually fall asleep? And again, it's not exact, obviously, right? No one's standing there with a stopwatch, but more or less you want to get an idea, okay? How many times did you wake up during the night? Right, not counting your final awakening. That also is an issue. If you're waking up 4 or 5 times during the night, what are you doing during those breaks, all right? How long were you up, right? In total, how long did these awakenings last, right? How long were you awake total during the night during these awakenings? What time was your final awakening? After your final awakening, how long did you spend in bed trying to sleep? So sometimes you wake up and you see, wait a minute, it's too early to actually get up. So you just stay in bed and just like chill and just like force yourself to try to get back to bed, and you're doing that for about an hour. And then you just give up. All right, forget it. I'm not falling back asleep, right? That's also important for us because this is another problem with that link between sleep and bed. If you can't fall asleep, get out of bed. All right, and we'll talk about the interventions in a moment. How long did you spend starting in bed, right? Did you wake up earlier than you expected? How long earlier? What time did you get out of bed for the day? Right, what time? How long did you sleep overall? They have to answer 2 questions about quality of sleep, all right? How many times did you nap or doze off during the day. How many drinks containing alcohol did you have? I have clients who drink alcohol to try to fall asleep, right? So I couldn't fall asleep, so I took 3 vodkas, and that did the trick. Or they wake up in the middle of the night, 3 o'clock in the morning, they have to get back to sleep, 2 alcohols, right? 2 vodkas, and it's going to knock them out, right? We obviously want to try to pull back on that, right? Taking vodka to try to fall asleep is not the best idea. We need to find better ways of doing sleep than drinking vodka. All right? How many caffeinated drinks did you have the night before, right? What time was your last drink? Did you take over-the-counter prescription medication? That's also very common. Taking medication to try to fall asleep. How much? We want to try to pull back on that as well. All right? So these are the questions that you ask, and your client basically answers 7 days in a row. If they forget a day, it's okay. We don't make them feel bad. All right, if you forgot a day, if you remembered at noontime that you didn't do your measurement in the morning, sit down and try to do as much as you can remember. If they totally forgot a day, that's fine, so you'll only have 6 days of data. But they come back the following week, and now you have this measurement from them, and now you start identifying patterns. And then these patterns are going to help us understand which and what order do we want to be doing the following components. All right, so let's look at the components. Let's look at the components of CBTI. Number 1, stimulus control. Let's describe each one and get some examples. Strengthening the association between the sleep environment and sleeping. All right? As we described, you want your bed to be a place of sleeping. So we want to make that association. All right? Not going to bed unless sleepy, right? Go to bed when you're tired, right? When you're about to go to sleep, when you're tired now, go to bed. So if beforehand you read a book, read it in a couch. And then when you're sleepy, don't fall asleep on the couch. Right? I have a client that takes a nap at 9 p.m. on the couch, then gets up and then tries to fall asleep. Okay, no wonder you're not going to fall asleep now. You took a nap at 9 p.m., right? You definitely don't want to be doing that, okay? Waking up at the same time every day, it's hard to go to sleep. It's difficult to create a schedule where every night you're going to sleep at the same time, right? Our life fluctuates, but it's important to at least wake up at the same time every day. Getting out of bed if you're unable to sleep. If you go to bed, you're not able to sleep, and you're tossing and turning, once again, get out of bed. Do something relaxing out of bed, and then try again. Minimizing non-sleep activities in bed, as we're saying, right? TV, computers, phones, you definitely want to minimize that, all right? You want to limit napping the day before, right? You want to try to make that tight association between I'm going to bed, I'm going to sleep, all right? Reducing arousal in bed. The relaxation techniques that we described yesterday, this is a very good place to do relaxation techniques. So clients who have difficulties with sleeping, with falling asleep, have them do mindfulness in bed, right? I'm sleepy, it's time to go to sleep. I go to bed, and I'm going to do now a mindfulness exercise. The worst thing you could do is go to bed and have your phone, which is what most of the world does by now. You're in bed, you're checking your phone until you're like, I'm going to go to sleep now, you put your phone down. Then you can't sleep for 10 minutes, pick it up again just in case something else happened in the world that you need to know about, right? That's the worst thing, not to have your phone on your night table. If you needed to wake up, get an alarm clock, right? Your phone should be as far away from you for ideally quite a while before you go to sleep. Right now, it's very difficult nowadays. Nowadays, we are intimately associated and we have a close relationship with our phone. People are more scared about losing their phone than losing their spouse. So we have to try to start working on that a little bit. Right, so definitely not a good idea. Seeing your phone right before you go to sleep is bad for us. Even there's all these techniques now where there's like an app that minimizes the blue light. There's all these tricks that you think that you're doing good for yourself. These things barely work, right? Oh no, it's on minimizing. You're better off, don't touch your phone for quite a while before you go to sleep. I know we may have to shape towards this target, and it may be a target that we reach in 10 years from now, but we definitely want to try to shape towards that target. So relaxation techniques, progressive muscle relaxation, breathing, meditation, positive imagery, all these things that we discussed yesterday in terms of meditation, have your clients do it in bed before they go to sleep, okay? Creating a pre-sleep buffer, unwinding before going to bed, right? I ask my clients to describe for me what is their pre-bed routine. What do you do every night from 7 p.m. onward? Or 8 p.m. onward. Describe for me your pre-bed routine. So I want to get a picture of what's happening 2 to 3 hours before you go to sleep, right? And there are going to be things there that your client is going to tell you, and it's going to be big red flags where that's not the best thing to do. And let's try to identify what are the problems, and let's shape towards the target. Shape towards. So for example, a client recently said to me that they have dinner an hour before he goes to sleep. An hour before he goes to sleep, they sit down for dinner, finishes dinner about a half hour before he goes to sleep, he goes, brushes his teeth, goes into bed. That's not a good idea, right? That's just not a good idea, right? So we need to play around with that. So you get a picture of what's happening pre-bed. I watch TV, I turn off the TV, and I put my head to go to sleep. Not a good idea, right? Especially a client recently said that she has nightmares, part of her problem going to sleep. Why? They watch TV right before, and her husband chooses what shows they're going to watch. And he always chooses these violent, scary things. So right before she goes to sleep, and she has anxieties already, and she has insomnia, she's watching scary TV. And now, go to sleep peacefully. Right? We want to try to shape towards the target. Again, she's not going to be able to go from doing that to none of these negative behaviors, but you want to try to identify what's doable, what's observable and measurable, and what could shape towards the target. Okay? That's also part of creating that pre-bed routine. Sleep hygiene. Recommendations about consumption of disruptive substances. What are they eating and drinking in the lead up to going to sleep that's no good for them? When is the last time they had a cup of coffee? All right? Think, when is the last time you drank a cup of coffee? So maybe 5 p.m. for you, a cup of coffee is too late in the day. Maybe you should cut coffee, and by 2 p.m., no more coffee, right? You have to tailor it to your client, right? What are they consuming that's disturbing? Obviously, a big dinner. A client that says that they have dinner several hours before, but then right before they go to sleep, they get the munchies, and they're hungry because they had dinner at 5, and they're going to sleep at 11, so they raid the kitchen, and they have a whole box of cookies. Yeah, no wonder you're not going to be able to sleep so well. So how do we pull back on that? Okay, so that's right. Diet and exercise. We know if we're able to diet during the day, exercise, eating well, exercise also contributes to being able to sleep well. Also, changing the sleep environment. We have to help our clients, have them explain to you what is their sleep environment about. What does it look like, right? So for example, things like comfortable, cool room temperature, right? That's going to help us if it's very, very hot, or if it's too cold, no good. So we need to talk with our clients. Describe the temperature in your bedroom, right? Is it too cold, too hot? How do you play around with that? How do you minimize? Minimizing noise and light, right? You ask your client, describe what coverings do you have on the window. Is there light coming from outside, from a lamppost outside, right? What do we do to get better window shades or get curtains? Something that's going to minimize the light. We know that that's going to help our sleeping, all right? Noise also, right? Help our clients think, okay, where is noise coming from? How do we minimize that, right? What do we do to try to work on that? There was a client that I had recently that described this crashing noise at night that was getting him, but he got used to it, but he didn't really get used to it, and it would disturb him and wake him up in the middle of the night. Turns out that there was this antenna on the roof that was right above their room, and it was getting loose a little bit. This old antenna that for some reason an old tenant still had, and the antenna was becoming loose a little bit, and when there would be winds, these antennas would be crashing against each other. But he just never got to it. So one of the things that we did was, okay, what do you need to do this week to get a move on that? All right, so I'm going to call this person, a roofer comes up, took it down, right? So we have to help our client really think about what's making noise during the night, what's disturbing you, how far are you from the kids' rooms, from your teenage room, whose teenagers are chronically underslept, right? So that's a whole other discussion about doing this with teenagers, very, very important as well. But minimizing noise and light, turning the clock around to prevent clock watching. If you have anxiety about sleep and you're worried I'm not getting enough sleep, and your head's on the pillow and you're seeing the clock, and every minute that ticks you're thinking, oh my goodness, I'm still not sleeping, and then another I'm still not sleeping, it's already 11:15, I can't believe, right? That clock watching just makes you more anxious and more anxious. You're not going to be able to sleep. So turn around the clock, right? Cover the clock. Also, just the light of the clock may be disruptive. So these small little things helps our clients create a healthier sleep environment, okay? Closing the door to minimize distraction, right? So we have to think about these small things that we could help our clients in creating an environment that's conducive for sleep. Yeah?
You talk about turning the clock around so they can't see it. Well, when they're doing the sleep,
The measurement. How are they going to know?
They do that if they don't.
Good question. You don't do this at baseline, meaning when they come in to see you and you're going to give them the measure, don't give them the punchline yet, right? You want to be able to get in a measurement of what they're doing that's unhealthy. So during the first week, do what you do. I'm not going to tell you anything to change it because I want to get an idea of how these things are impacting you, which ones to do. So for that first week, they'll continue doing what they're doing. And then you start infusing these kinds of interventions. And then 6 weeks later, when you do this again, they'll have to find a way that they could assess this in some way without it being disruptive, or they look, right? So that these are things that, but you're right, at baseline, you want them to just continue doing what they're doing, and then you infuse it. And it's not an exact science, right? So more or less, how long, when did you go to bed, and more or less, when do you think you fell asleep, right? So you want to get an idea to see some kind of minimization. You're not going to get to the minute accuracy because it's based on a recollection the next morning, but it definitely gives us some kind of baseline. All right? These are the therapy components of CBTI. And once again, just to wrap this up, the importance over here is to identify the list of things that we want to change, because from these 3 components, we could already have a list of 15 things that your client is doing wrong. Right? There are 15 things that your client is not doing correctly when it comes to this entire thing when it comes to sleep, from what they're eating, what they're drinking, exercise, pre-bed routine, phone, TV, waking up in the middle of the night, getting all these things, a whole long list of these are all the things you're doing wrong. Don't overwhelm your client with, okay, let me tell you a list of 15 things you're doing wrong. That's it, you're done. They're not going to, but you identify 1 or 2 each session, and you create some kind of hierarchy, and you shape towards the target. And then over time, you infuse 1 or 2 of these components. Can these changes be made? They come back next week. How was it? You give them positive reinforcement. Nice job. I know how difficult it was for you. And you keep on shifting until you have as many of these components done with your clients in ways that are more conducive for sleep. Thoughts or questions about sleep and insomnia? Yes?
Maybe I missed it. You said that people should go to bed, wake up at the same time.
Ideally, if you could go to sleep and wake up at the same time, that's ideal. It's difficult sometimes to do at nighttime because things come up, but as much as you can to have a consistent sleep routine is very, very important.
So like sleeping in on the weekends, it's like,
A big no-no. That's one of the first things that we say. What do you do over the weekend? And it's natural for us. We change our sleeping drastically, especially with children. You're doing this with children. Think about their routine during the week in terms of when they wake up and go to sleep and during the weekend. And no wonder it takes them until Tuesday to recuperate. And then the weekend comes around. So yeah, if we could somehow now, it's not exactly possible to have an exact kind of continuity during the weekend, but as close as we can, during the week and during the weekend, we have the same kind of routine. It's very, very healthy. It sounds unattainable and difficult. It's very healthy, especially if it's someone that has insomnia, especially someone with mental health issues, and this is problematic for them. So this is something to work on, right? It's nice for everyone, but particularly for people who this is a problem for them. So let's try to find these solutions. But yeah, absolutely, as you're saying. All right, let's move on to depression and suicide. And the way we're going to do this is, and we'll do this with all the other psychopathologies throughout the days, I'm going to share with you quickly the cognitive model of X, and then we're going to look at some of the interventions, some of them cognitive, some behavioral, some in overlap. We're going to get more specific. Okay, so as you remember from yesterday, the cognitive model of depression is a certain core belief, like, for example, I am unlovable. I'm unlovable is a common core belief with depression. Now, what does that produce for us? If people knew the real me, they would reject me. I'm unlovable. If you knew the real me, you would reject me because I'm unlovable. No one could love me. So what does that do for me? So as we described yesterday, it does 2 things. It does reaction, and it does coping. What does that mean? In terms of a reaction, I'm depressed, I'm detached, right? I'm unlovable, no one loves me, I'm not going to, right? And that's in terms of the reaction or situational reaction. It also creates a unhealthy coping strategy. How do I cope with this horrific core belief? How do I cope with the knowledge that if you knew the real me, you're going to reject me? How do I cope with that? I found a great coping mechanism. I'm going to cope by not getting together with people. What a great coping mechanism. If I'm just not with people, then I'm not going to find myself in situations where you're rejecting me because you're rejecting me because I'm unlovable. I'm just not going to see people. That's not a healthy coping strategy, right? Now, it is a great coping strategy if this is what you think, right? If we understand that our clients think this, then it makes perfect sense. Don't talk to anybody. Don't get together with anybody. That's a great coping strategy. If you're thinking this, the problem is that this thought is not so good for you, and the coping strategy is not so good for you. All right? But it makes sense once we know what they're thinking, why they're coping in such and such a way. Our job is to help them work on this, and our job is to help them work on these pieces over here, right? This is more of the thought process, the emotional, and the behavioral, right? And that's, once again, we're back to that trifecta that we started with in terms of helping them rethink their thinking process, helping them on their emotional front, and then let's come up with a behavioral plan to start connecting with other people, right? That's the constant dance between the cognition, the emotion, and the behavioral, all right? Now, I'm unlovable is just one of the core beliefs that your clients with depression may have. What are some other core beliefs? Core beliefs could be failure, I'm helpless, I'm hopeless, right? There's no hope. I have no hope. One of the things that you could do in order to try to assess this, a quick little clinical question that you could throw out to your clients. You ask clients that you suspect have depression, can you describe for me life in 10 years from now? What does life look like in 10 years from now for you? Right? You're basically asking them to conjure up an image of their ideal self. What's 10 years from now for you? Clients with depression have a very difficult time describing 10 years from now. What is life in 10 years from now like? They have a very difficult time doing that. Why? Because they are hopeless. There is no 10 years from now, right? So they have a very difficult time. Studies actually have done this, asking individuals with depression and individuals who do not have depression about 10 years from now. Individuals without depression could very clearly tell me in 10 years from now, this is what I see for myself in terms of my family, my occupation, my health. Very clear vision of 10 years from now. If you have depression, it's very, very difficult to do that. Yeah, question.
That young lady in that clip yesterday.
Very good, right. That young lady in the clip yesterday was an example of that. Exactly, meaning there's no hope. That's a great example, exactly. Now, what's interesting is that you could follow up that question, right? When you ask your clients, what's 10 years from now? And then you could follow it up with, what do you fear is going to be in 10 years from now? That they'll tell you. That they have no problem telling you. I fear I'm going to turn into my mother. I fear I'm going to be dead. I fear nothing's going to change. Right? So when you ask your clients with depression to describe their ideal self versus their feared self, that's another indication of a clinical manifestation of depression, but also gives us a clue into some of their thinking patterns, right? You ask healthy people, they give you very, very different answers, right? This literature is coming from adolescent work, a lot of the Ericksonian identity stuff, self-esteem, right? The great work of Erik Erikson. So this has been applied to work on depression, and you also see these interesting kind of differences between what's 10 years from now, and that gives us a picture into their hopelessness, right? There's no hope for the future. So that is the cognitive model of depression. Let's hear Aaron Beck on depression, and then we'll talk about some interventions, and then we'll move to suicide, and then come back to depression as well.
When I was in psychiatry, I got into psychiatry.
Misbehaving. Let's do that again.
I just got into psychiatry by accident, but anyhow.
Let's try it again. It was opened up 10 of them at the same time.
When I was in psychiatry, when I got into psychiatry, actually I was a neurologist and got into psychiatry by accident, but anyhow. The dominant theory was psychoanalytic theory, and most of the, almost all of the psychotherapists in those days were doctors. So
let's start again so we can hear all of it. you kick up the sound a
When
tiny
I
bit?
was in
Oh, there
psychiatry,
we go. Perfect.
when I got into psychiatry, actually I was a neurologist and got into psychiatry by accident, but anyhow, the dominant theory was psychoanalytic theory, and almost all of the psychotherapists in those days were doctors. So after I did my psychoanalytic training, I wanted to do some research. I wanted to test out the hypothesis that depression is caused by inverted hostility. The individual is angry at somebody else and then turns the anger against the self. And this is then represented in a need to suffer. And it makes really good sense that you see the need to suffer in everything that the depressive feels and does. They don't have any pleasure. They're very self-critical themselves. They'll even commit suicide. They will do things that are counterproductive. And indeed, it seems that self-suffering, or the need to suffer. And so I tested that out in an experiment. I got the dreams of depressed patients. And indeed, the dreams showed that the patient was portrayed as a loser, things were bad happening. And again, it seemed to all have to do with the need to suffer. And so I actually wrote a paper that came out in Psychosomatic Medicine. It talked about masochistic dreams in depressed patients. Then I tested it out. And so we did a couple of experiments. One is, if these individuals have a need to suffer, then if you put them in an experimental paradigm where they're going to have a choice between choosing particular words that are being punished or approved of by the therapist as compared to normals. And it turned out that they would selectively extract words that were being approved of, so that they were not doing something that would make them suffer, but they were doing something that would make them feel better. Then I did a card sorting task, and we had normals and we had depressed patients. And the depressed patients, it was worked out the depressed patients would either succeed or fail on this particular task, as would the normals. Turned out that the depressed patients did very well after success. So they weren't punishing themselves. They were seeking positive outcomes if they could. And whereas, it's just interestingly, the normals did better after failure. And when I wrote the paper, my final line was for depressed patients, nothing succeeds like success. And for non-depressed patients, nothing succeeds like failure. Anyhow, so this was the experimental aspect that shifted my mind away from the original hypothesis. And then I went back and I was able to see for myself then that the themes in the dreams were exactly the same themes that the patient had in their waking life, and that they were distorting situations according to this belief that they had as being losers and inadequate and ineffective and unlovable. And so it was this belief in themselves, this belief that they carried on about themselves, that then led to misinterpretations of reality. And when we changed the misinterpretations by looking for the evidence, seeing whether it's logical, looking for alternative explanations and so on, then they got better. And as I've mentioned many times, Judy's heard me say this, after 10 or 12 visits after I was doing this, my practice shrunk, because the patients would say, Dr. Beck, you've helped me a lot, but it's time to say goodbye.
It's interesting how he describes this concept for people with depression. When they're successful once, they then attempt more success afterwards, right? So for depressed people, nothing succeeds like success, as he describes it in this experimental condition. And again, it speaks to the power or the reinforcer of success. So when we're shaping towards the goal, as we described yesterday, and there's that little success with an incremental step that they could do, that's observable, that's measurable, that's doable, that success breeds success, right? One little success could begin helping you shifting the way you think about yourself. And that's that dance between the cognitive and the behavioral. A success, one that I was able to manage, suddenly now reinforces for the future. Many years ago, I was coaching a Little League basketball team. And I did it primarily to observe children in terms of developmental psychology, interactions, right? It was just fascinating to me on that front. I also like basketball a little bit. There's this one of these games that I'm observing. And these kids were maybe, I don't know, 5th graders, 6th graders. And there's one game that I'm observing, and there's this one child on the team that could not play basketball for his life. What did he basically do the entire time? Ran up and ran down. Ran up, ran down. No one ever passed to him because he just could barely dribble. Nothing. But he was on the team. It was Little League. Everyone's got to be part of the game. And literally, he was just everything. When they were on offense, he would just run. He would be on the side. And then they would score, and he would cheer for his team. And he would come down, and he literally did not touch the ball almost the entire game. Right? He just couldn't. He could barely dribble. And then, towards the end of the game, somehow, he's running up on offense. And by mistake, somebody passes to him. By mistake. And he gets all flustered. He gets all nervous. Like, what? I have the ball. What am I going to do with it? And he just throws it. And somehow he scores. And he's like, everyone's like, oh my goodness. And he scores. And he's so excited. And I'm observing this kid. I want to see, what is this kid going to do with that success? He turns around to start running back down on defense. And then he pauses after a step or two. And then he turns around and he looks at the guy who's going to inbound the ball, and he says, okay, pass it to me. Meaning he now wants to bring the ball down. He's going to be the point guard. Why? Because he scored one basket. The guy can't dribble, can't play, but that little success, he somehow scored. Suddenly he thought about himself, I'm Michael Jordan. I'm going to bring the ball down, right? And the guy inbound looking, I'm going to see, like, how is this going to end? What a great kind of thing. And the inbounder looks at him like, oh, okay, and he turns around and he kept on going. Like, right, it was like a reality check. But for this kid, that momentary success shifted the way he's thinking. Look, I could be the point guard now. What happened to the rest of your 7 years of trying to play without, right? But a success shifts your thinking, right? Nothing succeeds like success. For people who have a certain thought process, it really contributes to a shift in thinking. Again, that's the balance between the behavioral and the cognitive. The cognitive is enhanced with the success. Even a minor success, shaped towards the target. There's a success, I start thinking differently, and that gives me now, I'm going to have more motivation to change more. Another success, it's got to be a tight link between the cognitive and the behavior, because one reinforces the other. All right, that's a very nice way in which Dr. Beck puts it. All right, let's talk about the measurement. Yes, question.
To end on the same issue that you just raised, you know, we have in my house we have a dog, Gingy. We call it Gingy, and that dog was afraid to go down the stairs, up or down, when I came to live there about 5 years ago. And you know, one time when several dogs with my daughter, she brought in French dogs, you know, they were in there, and the French were in there.
The battery's out.
And one day, she started learning how she was able to walk up and down the stairs. In one day. That's exactly what you just mentioned. You know, some kind of one experience to do it, even for a dog. But never the same dog. Always to go up and down now, no problem.
One little success breeds success. Right, exactly. The application of behavioral analysis and behaviorism is the way we train dogs, right? The way we do training is basically, well said, Jonas. Jonas, by the way, is 90 years old. Inspiring. He's working, he's inventing, he's creating. I think it's quite exceptional. All round for Jonas, right? Well done. All right, let's talk about Beck Depression Inventory. The Beck Depression Inventory, the measurement of depression, and then we'll talk about some interventions. All right? So jump to the back of the book to the next of our measures. It's the 5th measure, page 56 overall. And you have over here a very widely used measure of depression, the Great Beck Depression Inventory. All right, it's 21 items. It takes your client 3 to 4 minutes to fill out. It takes you about 2 minutes to complete. It's a very quick way of getting a baseline of depression. Highly, highly reliable, highly valid, used literally in thousands of studies. It's been translated to many, many different languages. And what you have here are sample items, right? I wasn't able to replicate the entire measure here because by now the Beck Depression Inventory is copyrighted. So I only replicated a few samples, which I'm not sure is legal either. So you have a couple just items to give you an idea of what they look like, and what, as we've described, it gives you an idea of a baseline measure of depression. So within 5 minutes, you could have a baseline measure of depression, and on the bottom of the page, you have the various categories of scores versus levels of depression from normal to extreme depression. And then, as we said, it also could offer you a post-test. So you give it to them 2 months later, 8 sessions, 10 sessions into it, and it gives you a very, very nice difference between before treatment and post-treatment. If you want all of it, I provide for you on the bottom of this page a link to the Beck Institute website, okay? I have nothing to do with the Beck Institute, right? I don't work for them. I don't get any benefit from them. I did my training through the Beck Institute, but beyond that, I have no financial gain whatsoever. I share this with you because it's a very, very useful tool. They have exceptional articles, great tips. I'm on the Beck Institute website probably on a weekly basis, seeing a lot of, beyond the just informational stuff, they have an entire link of various measures that they've developed. There's anxiety measures, depression measures at various ages. As you could imagine, the way you measure depression for an 80-year-old is not the way you measure depression for a 15-year-old, right? It looks very, very different. So they have age-appropriate measures, anxiety, depression, suicide, right? It's definitely a very, very good, useful tool to get other measures as well. All right, so that's the Beck Depression. There was a question right there.
I was going to suggest an open source one. It's called the Geriatric Depression Rating Scale.
The Geriatric Depression Rating Scale.
And it was initially designed for older adults, but now they've
It's used right.
down the norms and they're good for
Well said. It's true. It's true. You find a lot of research studies using that measure, not only for the geriatric community, also younger. Very good. It's an open source one. So tell us the name of it again. The Geriatric Depression Rating Scale. If you want another one, open source, also very, very useful. Right. A lot of studies I've seen that. So that's also very highly reliable and valid. All right. So this is the measurement of depression. And even if you do pay, it's a very, very minimal charge. It's not like the MMPI that you have to remortgage your house to tap into. Right, so there's some great measures out there that are open source, not this one, other ones as well, that you could measure. Okay, let's talk about one intervention on the depression level, and then we're going to talk about suicide, and then we'll offer more of an extensive, comprehensive intervention. One of the things, and this is more of a behavioral intervention to begin with, is helping our clients generate a gratitude list. All right? It's something small, but it's quite grand once you implement it and you actually have your clients apply it. And right? What you want your clients to do is generate a list of things that they are grateful for. Right? What are you grateful for? A gratitude list. Now, ideally, if your clients can come up themselves with a list, let's think about all the different things that you could be grateful for. What are you grateful for? Let's write it down. Or let's create a folder in your phone that could remind you of these things you're grateful for. It's pictures or videos, right? Having some list, some files, some pictures that you could reach out towards when you are vulnerable. As an intervention, but also as a prevention, several times a day, make sure that you are pausing and meditating over this list, observing this list. Now, if clients can't come up with their own list, so this is what you have over here, suggestions. You could suggest various things for your clients as potential items on their gratitude list. So for example, family, friends, housing, senses, health, right? You go down the list, you pause at each one, see if that generates or triggers your client in thinking about a gratitude that they have. Teachers, I recently did this with a fellow, and when we got to teachers, and I paused after each one to let them think through it. Is there anything in this category that they could draw from? So I paused at teachers, and my client pauses and and he says, you know, there was this high school basketball coach that I had that believed in me. And just saying the word teachers triggered that for him. There was a high school basketball coach, and it was exceptional. He really changed my life. I grew up, no one believed in me, and this high school basketball coach believed in me, invested in me, and he started telling me different things that this high school basketball coach was telling him. And then turns out, as we're discussing, that this high school basketball coach recently passed away. So the client was able to speak about that, and then my client resolved that he's going to reach out to a lot of his friends from his years in high school, and they're each going to write some kind of tribute to this great high school basketball coach. And he reaches out to them, and they send him back emails, and he creates a little booklet of little interesting kind of notes and letters that all these different old friends write and to commemorate this thing, this high school basketball. And then he sends it to his school, and he sends it to them. And this turns out into an entire project that just boosted my client's mood and gave this client purpose and enhanced his gratitude. Several weeks of our sessions were devoted to this project that he was on and what this was doing to him. And it was reconnecting him to old friends, which was growing his social network, and he reconnected to the school. This little project here, this little task that I went down these lists and I said the word teachers, really just completely took the direction of our treatment in a very, very different direction, one that I didn't expect. I thought, okay, teachers, I'll make a note, but this really turned out into something quite grand by reminding or triggering different potential gratitudes that we have, all right? So very, very powerful to be able to do this. Happiness, God or higher power, nature, the sun and the moon, internet, smartphones for some people, right? Pets, movies, right? Some great movie that you enjoy, that when you watch that, it just puts you in a great place, and you love such and such movie, right? That's also something that you're grateful for, right? How do we do more of that, right? That's part of the behavioral activation, which we'll talk about soon. Some volunteer work, right? Shoes, for some people it could be shoes, your bed, husband, wife, laughter, kind strangers, right? Living in the USA, whatever that's going to be. And when your client highlights various things that they're grateful for, you also want to ask them, how and why did this come about? I mean, you want them to expand. It's not just checking off, okay, make a list and let's move on. You want to build on that discussion. Build on the discussion about, so how did this happen? How did this develop, right? How did it come about that you had a relationship with this high school coach, right? Let's expand on what makes this a special component in your life, right? So highlighting gratitude and discussing, expanding on it. And then this could also feed into, when we talk about behavioral activation in a little while, some things that you could have begin in terms of prescribing for our clients. Like if they mention, for example, job or volunteer work, we'll talk about behavioral activation and have them start working on that even further. But this is a very, very powerful way in which clients could be brought back to a place of gratitude, right? What do they have? Now, one of the things that we're going to find is that based on your client base, some clients are going to have a difficult time with this based on their circumstance, right? If you're working with various interesting kind of populations where their situation is really, really, really difficult, we have to be a bit creative in figuring out what would be that gratitude list, which is why I want to spend a couple minutes on thinking about some of your clients and what would theoretically be on the gratitude list of these clients. And some of you work in very interesting contexts. Everyone works with various kinds of contexts. Think about clients that you have and what would go into that? How would you suggest it? What could theoretically be, particularly with difficult clients who really, really are in a very, very bad place, and it would be very, very helpful to try to point to something. All right, so what I'm going to ask you to do is I want you to look around to say hello to someone that you have not said hello to yet. All right, so look around, and even if you said hello to everyone because you're very extroverted, it's wonderful, so you could say hello, and have a seat with them, introduce yourself, and spend a couple of minutes thinking about clients that you have and a gratitude list that you would develop.
כמה עמודים יספיק לטיוטה. All right, we're back in business, right? Yeah, somehow it just like... So was it a battery? You need to charge it? So we're in business now. Oh, good. We'll need it soon. Paper cups by any chance for the coffee? No, thank you so much. So the food, for me and for other people also. Yeah, there's only the... Oh yeah, just one or two, and it would be perfect. Yeah, yeah.
Okay, 2 minutes, 2 minutes.
At various times during school, so like it was just very surprising.
כן, בוא ננסה דרך וואטסאפ קודם כל, ואם לא, נסגר הפגישה.
Okay. Thank you for engaging. Okay. Thank you for engaging in energy. Let me just remind our crowd at home watching from wherever you are that if you have any questions, any comments, you could send it through the information that you received from PESI. I get the questions in real time, and I'd be delighted to answer your questions as well. So let's get some information from what you came up with. Describe a difficult client if you want, and what are some things that you came up with in your discussion? Any volunteers? There we go. Yeah, I forgot to tell you, there's a mic involved.
Loud.
All right, that's we're even better.
So I'm a school therapist, and I have this one young lady who does suffer from clinical depression, and it's really hard to get her out of it or to get her to see some of the good that's around her and what's going on. So I was sharing with Karen that there's only one thing that brings her happiness or makes her feel grateful, and that's the peers in her class. So I'm at a private school, and they've been together since they were 3 years old, and she's now in 7th grade. So that's who she identifies as her family, because I've asked her, like, when I see you in the hallways or I observe your class, I see that you're happy, you're engaging, you present differently than when you come to my office or whenever your parents are here for family therapy. And she's like, yes, because they make me laugh, they make me happy, they make me enjoy life. Then I get in the car with my parents and everything just goes downhill. So I make it a conscious effort to always ask her about her peers, what they're involved in, what they're doing, how they made her laugh today. And that's one of the only things that works with her that gets her out of her depression or her sadness.
That's great. Well said. Thanks for sharing.
Thank you.
Other brave volunteers. There we go. Thank you.
I work with geriatrics, and I was sharing with Walida that, for instance, I have working with an 80-year-old suicide survivor, and using this gratitude list has been very successful with her because she had a lot of negatives in her life, and she and I created, we talked about needing to build the positives in her life, and she so gravitated toward that. And then, like you said, expanding on it, and including when to pull this out and when to use it, and for a lot of folks with geriatrics, sometimes the most positive thing that they can find is also life review and reminiscence and putting positive memories on that gratitude list. And that's been very helpful.
That's a great example, meaning having on the list memories. Mm-hmm. Now that's great. It's true. We know there's some very nice literature about the importance of doing a life review. That's a great example. Thanks for sharing. Well said. Memories, right? Also, that's a gift that we have. Let's go with another example, another deliberation. Yes.
I have a client that was sexually assaulted twice. When she was younger, she was around 5 years old, and it was ongoing. And then she got sexually assaulted later on as a college student. And she came in very depressed, and she couldn't think of anything positive. But one of the positive things that we were able to put on her gratitude list was she's in an intimate relationship with a young man, and she's happy about having this relationship, and the fact that he loves her and he supports her and he's, encouraging and so forth. She is also grateful that he's in college, so he has a lot of potential, and he's working, and he's very thoughtful and loving towards her. So these are the types of things that we try to focus on, as opposed to her focusing on the negatives from the relationships that she's had in the past, where she was violated or betrayed.
That's great. So, focusing on what you have currently. That's very good. Well said. Thank you for sharing. Okay. Let's move on to suicide. We'll describe some suicide signs. And then what we're going to see is that there are two avenues that you would take when we're dealing with suicide. And one of the avenues takes us back to depression. So just the sequence and the frame of how we're going to do this. We started with depression. We discussed gratitude list. We're going to now expand it a little bit further and talk about suicide. We'll talk about two avenues of treatment when it comes to suicide. And we'll see that one of those avenues, and we'll come back to depression and really offer a more expanded intervention on depression as well. But let's start off with a clip, a very, very powerful clip that has interviews with three individuals who survived a suicide attempt. One of them, Kevin, is very, very well known. He has international speeches about it. He visits high schools, right? Very, very well known. CNN had a whole feature about one of the three, the male amongst the three that we're going to see now, Kevin. There was a whole feature on CNN. Dr. Sanjay Gupta of CNN had a whole feature with him, a very, very inspiring fellow, and using a very, very dark time in his life to really inspire and create some change. All right, so let's have an idea of a little bit of what are the suicide signs, and then we'll offer avenues of intervention, and then coming back to depression as well.
What can we learn about preventing suicide from these people who miraculously survived their own suicide attempt? How can we recognize when someone we know is thinking this way, hearing these kinds of voices? One way is to identify specific self-destructive behaviors that the person is engaging in that we now know are being dictated by the voice.
My real purpose in wanting to make this film about suicide for the public is to educate all people about what to look for in their friends, their family members, their loved ones, their coworkers, their fellow students, that could alert them to the fact that this person's in trouble, that they need help. And then to give them the tools so that they could reach out to that person. They would know what to do. They'd feel comfortable to make contact with that person, to connect with them, to show them that they care. They often have disruptions in their sleep patterns. They're either not being able to go to bed, or they're waking up in the middle of the night and not being able to go back to sleep. Often, people who actually commit suicide have not slept for weeks at a time.
So finally my dad's just exhausted. I said, Dad, look, let's talk tomorrow morning, okay? I'm really, really super tired. I have to go to sleep. I had no intention of going to sleep. I hadn't slept in 2 weeks. He didn't know that. I stayed in my room, wrote, drew.
You hadn't been sleeping at all?
Not at all. 2 weeks.
One important sign is isolation. For example, someone who is pushing away their friends and wanting to be alone.
I tried to get alone because this process occurred when I was alone. I couldn't do it. I couldn't carry it off if there were other people around. The voice was weak when I was around other people. So the voice got me to be alone. Get alone. Look, why don't you need some time for yourself? Get alone. Get alone just so you can think. And then once I would get alone, either driving around somewhere or just walking around by myself, then these other voices, the more destructive ones, would start.
I remember that Christmas drinking a case of beer, sitting by myself, crying and thinking, Merry effing Christmas. I know the drinking made me feel more isolated. I remember a lot of thoughts about you know, your own family doesn't love you. Nobody's ever going to love you.
Another warning sign is where someone seems to lose interest in things that once mattered to them.
I also had quit going to a couple of classes because I was so depressed. And there was one class that I wasn't doing well in. It was an economics class, and I'd never not done well in a class. And so I felt like even my intellect or my ability to succeed in school was failing me, and I couldn't bear to, I mean, I'd always gotten straight A's. That would have meant I wasn't going to get an A.
When people become involved in a downward spiral of self-destruction, their thoughts become intensely self-hating and vicious, and cause them much psychological pain and agitation. A friend or family member who is expressing such thoughts out loud may be approaching a suicidal crisis, and it is appropriate to be concerned.
Like it takes a form of like, you're so ugly. You're so ugly. Of course you can't stand to look at yourself. Who would choose you? I didn't. I didn't.
I would yell at myself. It was as if the mirror was a person and I was a person. I'm going to kill you. You're going to die. I hate you. Go to hell. You're a bastard child. Things like that. I mean, really get mad.
A further sign is where a person feels that they don't fit in anywhere, that they don't belong, and that they are different from other people in a negative way.
Why couldn't my own family love me? And, you know, I see families stand by murderers and rapists and drug addicts, and, you know, I'm a straight A student and, you know, really responsible, and nothing was ever enough.
As people progressively give up the activities and friendships that once mattered to them, they lose the ability to find any pleasure in life.
You don't matter. You don't matter to anybody. Nobody would miss you. Nobody. You don't even matter yourself. How do you think you matter to somebody else? You don't matter. You don't matter.
When they're feeling like giving up on themselves, they're disconnecting from themselves. Nothing matters to them anymore. Things that they used to enjoy, that they love to do, they don't care about anymore. That disconnection from self allows the person to feel very negatively toward their body and do things to actually hurt their body.
Another serious sign is where a person feels they are a burden to others. Kevin was diagnosed by a psychiatrist as having bipolar disorder, which is associated with suicide risk in both the depressive and manic states. Here he describes an unusual form of rapid cycling he experienced.
Every Thursday or Friday, I would succumb into a deep depression. Every Thursday or Friday. It was clockwork. That's rapid cycling, I guess. So I'd go from Monday, being way up here, way manic, Tuesday, Thursday, Friday. I missed Wednesday, or whatever. So, bam, down on Friday, and I'm gone. And I'm so depressed. I'm crying my eyes out. I'm having heart palpitations. I mean, just all this physical pain and all this mental pain. Then I became depressed and more manic and more paranoid. Then I'd go up and down, and this exhausted my family. Not just my parents, not just my sister and brother, but my aunt, my uncles, my friends. They didn't want to go out with me anymore. They didn't want to hang out with me.
In this very painful time in my life, I remember calling home and my stepmother answered the phone. My father wasn't available. And so I began telling her how much pain I was in and that I was thinking of ending it. I think I was fairly vague about it. But she said, you know, no matter what, don't you tell your father about this because it would break his heart. And why are you calling me?
Very close to the time of the attempt, the suicidal person might actually appear to feel better, happier, and less agitated.
Sometimes just before the suicide attempt, where they've made this decision to kill themselves, they look much calmer, much happier, much more relaxed, because they're no longer in this turmoil about, you know, and all this pain. They've come up with what they think is the perfect solution. Now, I don't think it's a perfect solution, but in their mind at that moment, suicide seems like the perfect solution.
Put the notebook in my bag where the letter was. Got in the car. Elated, very happy. I'm going to end the pain. I'm going to end the pain.
Do you think you were disconnected from yourself at that point?
Absolutely. I was ready to go. I was just gone. It was over. I knew what was going to happen. I'm going to go to the bridge. I'm going to jump. It's just that simple. That's it. There's no ifs, ands, or buts. It's done.
And when you
Today
came
I'm
to
going
that
to die.
decision, you felt elated.
Elated. I was just like happy, ruined, running. And it's going to, and this is common.
Suicidal people may even talk about wanting to kill themselves or allude to it. However, when someone shows concern, they may quickly deny that they are in distress. They are clearly ambivalent about wanting to be stopped.
September 24th, I'm in my room, just had a little argument with my father. I don't know if this is the day before or the day before that, but I said, I don't want to be here anymore. I said, Kevin, you have an obligation to your family, to your friends, to the people that love you and raised you to be here. Do you want me to take you to the hospital? No. Are you sure? No. Kevin, I think we should go. No, Dad, look. No, I didn't mean it like that, all right? I just bullshitted him. I said, Dad, I'll be fine. Look, Dad, I'm sorry. I'm really sorry, okay? I need you to just go to sleep, okay?
So it culminated in me obtaining a gun, had it in the back seat with sort of clothes half covering it. And I remember one of my friends saying it, and sort of accidentally on purpose. And she's like, Trish, what the hell is this? And I told her the same little shenanigan that I had told the guy who sold me the gun. And she said, you know what, let me hold on to this just for a while, this doesn't sound right. And I said, really, I'm fine, don't worry about it.
I went out to the Golden Gate Bridge. On the bus, I began to cry softly in the back. The bus was packed. On the bus, I began to think, if one person comes up to me and says, are you okay? I'll turn around. If one person comes up to me and tells me, asks me if anything's wrong, I'll tell them everything.
It's interesting how Kevin ends over here, where he says, if just one person would ask me, I would turn around, right? Just that someone reaching out speaks a little bit in terms of that thought process that we see when it comes to depression. All right, let's now move on to a treatment plan, particularly for suicide, and then we'll see how this brings us back to depression. When we talk about a treatment plan for depression, there are two avenues that we take. Number one, it's the avenue of working to decrease modifiable risk factors, right? Modifiable risk factors. Let's talk about those two words, modifiable and risk factors. There are two things that we take into account. We take into account risk factors here and protective factors over here, meaning there are certain factors, risk factors, that make it more likely that someone is going to commit suicide. Risk factors, all right? So there's a whole list of risk factors that if a person has suicidal thoughts, if they also have these risk factors, it makes it more likely that they're going to attempt. It's a list of risk factors. There are also things that protect, meaning if they have suicidal thoughts, if they have these protective factors, it makes it less likely that they're going to commit. Now, so we have risk factors on one end and protective factors on another end. All right? Now, obviously, our goal is going to be in treatment to try to decrease the risk factors. Let's identify the risk factors that this client has, and let's decrease the risk factors. And let's identify protective factors that could assist this client, and let's increase the protective factors, right? So it's a two-part intervention, decreasing risk and increasing protection. Now, before we get into the protective part, there's one more part that we need to discuss as it relates to the risk. There are certain risk factors that are not modifiable. What does that mean? There's nothing you can do about it. So, for example, being male versus being female is a risk factor for suicide. What does that mean? We do know that women attempt suicide more, whereas males commit suicide more, right? Various theories why that is. Chances are it's biological aggression. There are many theories about why that is. But males commit suicide. You can't do anything about it. That's an unmodifiable risk factor, right? There are other unmodifiable risk factors. Things that you can't do anything about it, okay? If they're veterans, that's a risk factor. It's part of their past. You can't do anything about it. That's an unmodifiable. Now, we need to know about the risk factors for, where I'm saying red lights or red flags or how much attention, right? So it's not like we don't need to know about these unmodifiable risk factors, right? We describe these things. We want to be aware of them. But the bottom line is they're unmodifiable. In terms of my intervention, they're unmodifiable, all right? Being a member of the LGBTQ plus community, also a risk factor. That's an unmodifiable risk factor. Having a family member who committed suicide, that's an unmodifiable risk factor. There's nothing you can do about it. Again, we want to be aware of it. We want to assess for it. So what do we focus on in intervention? We want to focus on modifiable risk factors. What are things that we could work with? And that would be the depression and the insomnia. And that's going to bring us back to depression and insomnia. We're going to come back to this in a moment, the depression part primarily, right? The first part that you saw, the first component of the video that we saw, that Dr. Firestone was talking about in the video, was the sleep-related issues, right? So that's an example of sleep being a moderator, right? We described sleep as being a mediator or a moderator. What she described here in terms of sleep and suicide, that's clearly a moderator. That's impacting the intensity of it, right? So, which is why we want to deal with sleep-related issues. The depression component as a modifiable risk factors, we're going to come back in a moment and describe how do we come back to the depression using suicidal automatic thoughts. We're going to get to that in a moment. In terms of the protective factors, again, our objective is to try to increase those. So what could be protective factors for suicide? So we know that family support is very, very important. Bringing family members into the picture, right? Who can be a support for them? We know that that is very, very helpful. Therapeutic relationship, you as a therapist and the relationship they have with you is a protective factor, right? So having that therapeutic alliance could be a protective factor. Faith has been shown to also be a protective factor, right? If it's a client who is a believer, allowing a discussion about that belief, right? And seeing how we could work that into the protective component, right? So again, if this is meaningful for a client, we allow ourselves to go there. If it's not meaningful for a client, unethical to bring it there, but it's also unethical if the client is religious, is spiritual, not to go there, also unethical, right? We have to be careful. We have to be aware of the cultural sensitivity of the client and be where the client is, not where we think the client should be, right? So if faith is important for a client, by now even the American Psychological Association has an entire division. Division 36 is the scientific study of religion, and the understanding that, yes, most Americans are a believer in some force and power, and if it's meaningful for your client, we allow ourselves to go there on the terms of the client. So this could be a protective factor, right? Not just faith broadly, particularly if there's a transgression in your faith tradition to commit suicide, right? There are some faith traditions that it's a transgression, whatever that word means, right? So that's also an interesting component to bringing that piece into the puzzle. But faith is a protective factor, and we need to be working with our clients in increasing these protective factors. But I want to come back now to depression, all right? Focusing on depression and offering more of a comprehensive intervention on depression in general, but it also is very much clearly linked with suicide as well. Suicidal automatic thoughts deeply reflect values, principles, needs, and desires. Let me present to you an approach to dealing with suicide, and we'll see how it connects to behavioral activation and depression, all right? One of the things that we want to get from our clients is to listen to their suicidal automatic thoughts, right? Suicide makes sense if you understand the thought process of your client. If you would have the voices that a client has in their head, it would make sense that they want to commit suicide, right? As we said yesterday, very, very powerful statement by Judy Beck. The way people act always makes sense when we know what they're thinking. When you know what the client is thinking, makes sense. kill yourself. It makes sense because that's what you're thinking. Again, it makes sense because of what you're thinking. But we could use what the client is thinking to craft from that a way forward. How? Again, the suicidal automatic thoughts reflect values, principle, needs, desires beyond the negativity of the suicidal thought. If you listen closely, the client is also giving you things that they believe in, needs that they have, desires, aspirations. Where do you get that from their suicidal thought? So let's listen to a common suicidal thought, right? Suicidal automatic thoughts. Let's listen to one of them, and let's see if we could discern from the suicidal thought, what are the positives that the client is offering us? And then we use those positives in terms of a treatment. Let's talk about this common automatic thought. Why am I committing suicide? I'm not able to be productive, to participate, to create. I'm a burden to my family. It's hard to see the purpose. With death, all this ends, all this pain and suffering ends. Right? These are common statements that you're going to hear as suicidal automatic thoughts. All right, now, this sounds very dark and disturbing, but if you listen closely, the client is also giving you needs, aspirations, futures. How? Let's take it a step further. What you would do is you would partial out these pieces of the suicidal automatic thought and engage the client with the following discussion. All right? Dr. M says, it sounds like not being productive is extremely painful for you, right? Because don't forget, that was the first thing that they say over here, right? I'm not being able to be productive. So it sounds like not being productive is extremely painful for you. And the depth of that pain really tells me how important it is for you to be productive, right? I can't be productive. That means that being productive is important for you, right? How important is that for you on a scale from 1 to 10? How important is it for you to be productive? James says it's a 10. If I'm not able to work, not able to support my wife, what use am I? Very good. So we've identified being productive as a value that the client holds. Let's do another one, all right? Doctor says, and you see yourself as useless, so participating is also important, right? Because let's not forget, over here he says, right? I'm a burden, hard to see the purpose, right? So how important is participating for you on a scale of 1 to 10, right? That's also a 10. And what you're basically doing is that from the reasons to die, you are able to craft or discern reasons to live or values of life. From what they're saying in terms of their depth of despair, you could listen to, okay, so then what will be the reason to live? And then you generate a list. You actually pull out this table, you draw out this table. What are the reasons to die? And what are the equivalents in terms of the reasons to live? So a value of life or a reason to live would be productivity, or I'm not able to participate, so participation with a family is important. I'm not able to be creative, right? That means creativity is important for you, right? I'm a burden to my family. The opposite would be, well, that means that being supportive is important for you, right? No purpose, that means having a purpose is important for you. So you've generated now, through the automatic thoughts of your client, the suicidal automatic thoughts, you've generated values of life and reasons to live. And then you ask your client, for each one of them, rate how important they are for you. So then give you a rating. So over here, 10, 10, 8, you give you a rating. How important is this thing for you? So again, from the suicidal automatic thoughts, what reasons to live can you hear? And then how important is that for you? Okay, let's add to that. So far we just have reasons to live, values that you possess in your life, values that you have, and how important are these values? All right? Now, let's bring it now to what do we do with that? We now want to use what we have, use these reasons to live, and generate from them behavioral activation. This comes back to our behavioral activation that we very briefly mentioned yesterday, and now we'll take it more expansively, right? How do we now create a schedule of behavioral activation driven by the reasons to live that we discerned from the suicidal automatic thoughts? Let's build on that, okay? What's happening basically with client is that withdrawal prevents chance of meaningful or pleasurable experiences, and hence psychopathology continues to intensify. Because they're not activating, because they're not doing anything, it just continues to intensify their difficulty. They're not doing anything. They're not moving. They're not active. To counter this, therapists can introduce behavioral activation. I want to try to now behaviorally activate. It entails getting clients more active in life by scheduling activities with potential to improve mood, right? The goal is for me to schedule for my client activities that is going to have potential of improving their mood. Now, what activities do I schedule? We want to focus on value of life and meaningful activities. We want to go to those value of life that your client gave you from their suicidal automatic thoughts. And now, how do we use these values to generate from these values actual behavioral activation? So you want to obtain the values, like I just showed you in the previous table. You obtain the reasons to live the values of life, and then you rate the strength of each category from 0 to 10, as I showed you in that third column. All right? Now, what are some categories? Categories could be, we saw a bunch of categories already, creativity, family, but categories could be endless. The suicidal automatic thoughts could generate various categories. Now, by the way, you could be doing this even without suicidal thoughts. Clients with depression also have these automatic thoughts, right? This is not only for clients who are experiencing depressive ideology. People with depression also say these negative statements. They also have this negative self-talk. You could listen to their negative self-talk, which are similar in some way to suicidal automatic thoughts, and from that, once again, we generate lists of things that are valuable for them. What is a reason to live? Categories could be, once again, work, self-education, volunteering, family, friendship, spirituality, recreation, health, unlimited. There could be many, many different categories of things that you are able to discern from your client's suicidal automatic thoughts, or from your depressed client's automatic thoughts, right? Negative automatic thoughts, right? Value ratings indicate the best place to begin with. So now we have a list, and the list has the category of life, and then how valuable that is. And now you want to go to the top. You want to start off with 10. Which things did your client say, this is a 10 in my value of life? Start with the highest value. Why is this value important to you? So you start off, first of all, as why is this important? Get them talking about this value, right? What makes this important? Why is participating with your family important? Why is supporting your family important? Why is creativity important, right? Why is your spirituality important? Why is your self-education important, right? Have them expand on that. Ask clients to list specific, concrete activities that make up the value. Now that we have the values, let's work collaboratively with our client. What are the activities that make up that category? What does it mean? When I'm being creative, what activity does that? Now, when we say activity, the crucial point are these two words here, specific and concrete, right? Yesterday we called that observable and measurable. It's got to be observable and measurable right now. If I say observable and measurable, my client may not know what that means. Observable and measurable, like what am I, in experimental psychology? What's observable and measurable? But you created a specific, let's talk about some specific things, concrete things, because the goal is we want observable and measurable. What are the activities that are observable and measurable that make up the category of creativity? Okay, we had a question there before we continue. Yeah.
As I'm going through this and I'm thinking about people I've seen and I'm seeing, it seems to me that I like this idea, but for example, productivity for a male, right? What about how do you separate or deal with the core belief that if I'm not productive, I'm not going to...
That's very good. Let me repeat the question. That's well said. Well, so let me repeat the question for our audience at home. First of all, he said that he likes what he's seeing here so far, which is nice, which is good, right? The question is, how do we parcel out this core belief about if I'm not creative, if I'm not productive, that means I'm no good, right? So that's very good. The core belief work also needs to be played out over here, meaning, and the fact that you're not productive, that's your own value at this point. That's a core belief. Who said you're not being productive, right? So again, that needs to also be worked on. Could be that there are areas in their life that they are productive, but as you're describing, as we described yesterday, there's a core belief of I'm not productive. So then, whenever they see something that maybe they are productive in, that's what we called yesterday a triangle, and they figure out a way of changing that. So you're very right. It's got to be a two-pronged approach. This piece, together with that work on the core belief. Maybe there are things that you're productive, and let's keep productive activities as they are. Well said. Well said.
The activity as a value to the person, not associated with other people and their emotions.
Right, for sure. Right, for sure. Right, you want to try to deal with what the client is actually doing, not relying on the reactions from others sometimes. For sure, that also requires work, and that also helps with that triangle square pause. Well said. All right, so let's bring this back. So we described the categories, and now we want our clients to rate the categories. And now we want our clients to deal with specific, concrete activities, right? Observable and measurable, that make up that category, supporting your family. What activities is that? What's the activity of supporting your family? Well, it would mean helping my daughter when she needs to pick up her young child from school, or whatever it's going to be, right? We have to work collaboratively. What are the activities of being creative? All right, it means that I'm going to go back and do that home project that I'm working on, or something that I could observe and something that I could measure. That means, yes, you did it for 10 minutes. You did it 5 times, right? So what are the activities that are specific and concrete, a.k.a. observable and measurable? Repeat steps for the remaining high-value categories, right? So there are other right? You have several of them are 10. So you go to number 1, which one was a 10? And you go through this observable and measurable on the first 10. And then what else do they rank as being high value for them? Are there other 10s there? Wonderful. Let's do other 10s. If they go down to the 9. So we go down through the categories from top to bottom and generate what are the observable and measurables. Collaboratively ask the client which activities to schedule. Now that we have your values of life, that I heard from your suicidal automatic thoughts, and now that we have concrete, specific behaviors that this category is, let's think on, okay, which things do we want to now schedule? So we have now a list of activities. We know that they're going to be valuable because they're linked with the value. And now let's collaboratively work with our clients. Which activities do we want to schedule? Okay? This is a piece, speaks to suicide, also depression, but there's one catch. There's one catch. What is a client going to tell you? So some clients, I do this with many, many clients. This is one of the primary interventions that I do with depression, one of the big ones when it comes to CBT intervention. Works very, very effectively. Clients start moving forward. They have a plan. You write it out for them, shape towards the goal, all the good stuff that we discussed. But there are going to be clients that say to you, okay, this is wonderful, but I'm not doing this stuff because I'm not motivated. That's the problem. I'm just not motivated. So what do you want from me? I'm just not motivated to do this stuff. That's part of what some clients are going to tell you, all right? So clients are going to tell you, right, I do not engage in activities because I'm not motivated. Some clients, there's a plan, there's a therapeutic alliance, they trust in you, they're going to move forward with now activating. But some clients are going to tell you, I'm not motivated. What do you want? I'm waiting for motivation. I'm going to sit in bed and wait for motivation. So this helps. What we need to do now is help our clients understand that they are thinking a bit in a flawed manner when it comes to the relationship between motivation and activity. See, what clients think is that I need to be motivated, and then when motivation is triggered, then I'm going to start acting. All right, so I'm waiting for an internal state of arousal, which is the definition of motivation. Once I have an internal state of arousal, then I'm going to start activating. However, activity leads to motivation as opposed to what clients often think. And there's a discussion I have with my clients. It's interesting, you think that you need to be motivated to act. It works the other way around. You're not getting motivation if you're not moving. You need to start moving a little bit, and that's going to bring on the motivation. It's not that the internal state of arousal impacts the external. The external is the behavior. It's the opposite. The external, the behavior, is what's going to trigger the internal state of arousal. It's classic behaviorism, right? You need to create some kind of movement to create. Now, the client looks at me puzzled and says, okay, what is that? Prove that. So what I do with my clients, I do a quick experiment with them in session, and then I talk to them about 2 other features or 2 other pieces of information to highlight this idea, okay? What do I do with clients as we're discussing this idea that you have to act, you have to move to trigger this internal state of arousal? First of all, I talk to them about the fact that laughter leads to happiness. What does that mean? We think that first I need to be happy inside. Happiness is an internal state of arousal. I'm happy inside, and now if I'm happy, then I'm going to engage in the behavior of happiness, which is laughter. I'm going to laugh. But first I need to be motivated. I need to have an internal state of arousal, happiness, and then I'm going to laugh. But it goes the other way around. Laughter often leads to happiness. An external, how do I do that with a client? So I do this quick little experiment. We're going to test it out over here. Okay, we're going to do a quick little role play. All right, I'm going to ask you all in here now, and those at home could also join if you want. I'm going to ask you now to look inward and think right now, what is your current state of happiness? Now, in scientific literature, we refer to it as subjective well-being. Happiness is this aloof kind of term that we don't really use, but subjective well-being. I want you to think about your subjective well-being right now. From 1 to 10. 1, you're in severe depression, you want out of here. And 10 is you're elated. Right now in here. I want you to look inside, think where you are. From 1 to 10, your sense of happiness, subjective well-being, and make a little note where you are right now. Right? Make a little note. Where are you right now in your subjective well-being? 1, horrific. 10, I'm elated. Beautiful. So now we got a pre-test, as we would call it. Quasi-experimental. Okay? Now, by the count of 3, we're going to do an intervention. I'm going to count to 3. When I get to 3, we are all going to start laughing for no reason. Okay, I'm going to count to 3, and we're going to just start laughing. Now, by the way, I've done this across the country. It's interesting what crowds go for it and not. I did it down in Arkansas. They loved it. I did it in New York. Silence. They didn't do it. Right, so that was just interesting. Right, so I'm going to count to 3, and then we are all going to start laughing for about 2-3 seconds for no reason. Okay? 1, 2, 3. All right, awesome. Wonderful. Now, I want you to look inward and ask yourself, where are you now in subjective well-being? Give yourself a number now. Raise your hand if your number went up. Very good. Most of you. Well done, right? What happened there basically? Laughter led to happiness. Acting it out, playing it out for no reason, created an internal state of arousal. So you're waiting for motivation to then get moving. It goes the other way around. Start moving, start doing, start acting. Fake it till you make it. Start doing from the outside. And I do this with clients. I actually, exactly as I did with you here, I do it with clients. First of all, that puts them in a little better mood immediately, right? That's like, oh, they already were, so they went from a 2 to a 3, all right? Because they have depression. They're in my office, right? But that itself is kind of interesting, of a bit of a boost. And they get, oh, so I see that. Just playing it out in some way. And then I talk to them about 2 other fascinating studies. I don't expand too much when I'm doing with clients, and you have to tailor your client's ability to understand it, comprehend it, their interest level. But there are 2 studies that I share with them that speak to this identical concept. Number 1, Botox and anger. Listen to this fascinating study. It's been replicated several times. They had 2 groups, an experiment group and a control group. Okay? Both groups, the experiment and the control, watched a video that produces anger. Short video, unpleasant things in the video that make you angry. An adult screaming at a child, various little clips of things that make you angry. Okay? Both groups watched the identical video. Makes you angry. One difference. The experiment group had Botox injected above their eyebrows. Botox were injected above your eyebrows. Now, what does that do for you? In order to get angry, the facial expression of anger has a lot of activity above your eyebrows. Think about what does your face look like when you're angry. It's a lot of movement right over here. If you have Botox over here, you can't make the face of anger. It's preventing you from being face. The facial expression of anger is prevented from this crowd over here. The other group, no Botox. All right, so they had Botox injected, can't make a face of anger, and both groups now watched the video. And what was found, quite fascinatingly, was that those who did not have Botox rated the video that made them more angry than this group that had Botox injected, made you less angry. Hang on, I thought you watched the same video. Anger is this internal thing. No, if you can't look angry, you're going to be less angry. If you can't make a face of anger, you're going to be less angry. This is exactly the same concept, right? If from the outside you're doing something, that's going to impact your inside. If you cannot make a face of anger, you're not going to be angry. So it's not this anger is leading to the facial expression, it's the other way around. If you're going your face like this for a couple seconds, you're going to feel a bit angry. Why? Because the external is influencing the internal. Same thing here. My client is waiting for this internal state of arousal, and then I'll start doing it on the outside. The other way around. You do it from the outside, and it starts impacting your inside. All right? It's very, very interesting. There's Botox, and not sure how much the participants need to get paid to be able to have Botox injected in top of their eyebrow for a study. Interesting question in and of itself. One more interesting study, which is the identical process, and clients respond to the meaning behind this. The other study was pen and lips and humor. Similar kind of study. Control group, experiment group. Both groups had watched a funny video. A video of laughter, something funny, some comedian, some funny video. What was the difference between the two teams, the two groups? Experiment group, they were all given pens. The experiment group was told, put the pen in your mouth like this, and your lips had to be around the entire pen. All right? It's impossible to smile with a pen in your mouth, and you have to keep your lips around the pen. And try. It's impossible, right? You can't smile. If you smile, it falls. It's smile, you're not putting it right. So they were told, keep your lips around like this. The other group, the control group, also were given a pen. They were told to hold the pen in their mouth like this. An emotion that mimics a smile. So they couldn't smile, and they were induced into smiling. They both watched the same video. This group reported the video to be much funnier than this group. Why? They watched the same video. If you can't smile, a video is less funny. Again, if the facial expression is there, it's going to trigger the internal state of arousal. If not, it's not going to. So again, my clients are waiting for motivation to start moving, start acting, start moving. It's going to create an internal state of arousal. Start the activity, start the motion, all right? Discuss predicted pleasure and mastery of activities versus actual pleasure. Because what's basically happening is that our clients are predicting. When I'm depressed, I'm not moving. I'm predicting that if I do that, I'm going to hate it. Because right now I'm not moving. I'm not motivated. I'm not moving. So my prediction is that doing blank, I'm going to hate it. Because right now you're not moving. What happens when you're actually doing blank? You're going to feel better about it. Right? Because there are predictions that our clients with depressions have about how things are going to be if I do some kind of activity. But yeah, right now you're sitting and not moving, so your predictions are going to be pretty bad because you're not moving, you're not motivated, nothing's happening for you. So I predict how horrible things are going to be. But what happens when you're actually doing these things and you're active? It's a boost. The movement, the activity is a boost. So talk with your clients about the predicted pleasure and mastery. Mastery means how good are you at doing this? And in a moment, I'm going to share with you a measure that speaks to these two facets. But when you have to take a shower, how much pleasure and how much mastery do you have? When I'm not moving right now, I predict that it's going to be horrible. From 1 to 10, how much are you going to enjoy taking a shower? Right now, when I'm not moving, oh, it's going to be a 1. I hate doing that. Right, because you're not moving. So there's nothing happening. There's no internal state of arousal. So you predict horrible. What happens when I'm actually taking the shower? My sense of it is going to be higher than what I predicted. Because now that I'm moving, it's boosting me. So our clients with depression predict how horrible things are going to be. Yeah, because right now you're not doing it. Once you get going, you get moving, hey, this is much better than I thought. That's because you're moving. You're triggering some kind of process, right? So discuss predicted versus actual. Because what's ultimately happening with depression is that clients have negative predictions. Because right now I'm not moving. So I'm flatlined in some way. Negative, it's going to be horrible. And therefore, I don't do these things. because I'm predicting it's going to, and if I don't do these things, it furthers my depression. And then I have even further negative predictions. It's that cycle. You have to break in by starting to move, starting to act. And the way I do this with clients is that I give them a measure of schedule of activities. Let's jump to the back of the book, and I'll show you how you implement all this that we've described using a very, very concrete measure that speaks to this prediction versus the actual. Page 57 in the back of the book. What I do with clients, I give them this table, and I have them fill out the top part in session with me, and the bottom part in vivo throughout the week. What does that mean? So you see over here I have, what is your predicted schedule for tomorrow? So obviously I filled in the activities column in the top part, but you have your client fill in, what activities do you need to do tomorrow? And the client makes a list. What time, what the activity. And now for each thing they have to tell me, what do you predict is going to be your level of pleasure when you do that activity? And what do you predict is going to be your level of mastery? Again, mastery is, how good are you at doing this? Right? Sense of mastery. What's your level of mastery as a prediction? And these numbers are going to be very low. Why they're going to be low? Because your clients are depressed and they're not mobile right now. So they're going to predict, it's going to be horrible, I'm going to hate it, I'm no good at it. It's going to be horrible, I hate it. Right? So you make a list, very low scores. And then what do they need to do? Tomorrow, when they're actually doing this, make a note of how do you feel now when you're doing it. Your score is going to be higher. Once you're active, once you're doing these things, your score on pleasure and your score on mastery will be higher. And then they come back next week and you discuss with them in session, what does that speak to in terms of that movement, that activity, that activation, and how it very much counters the prediction that they made. Question, yeah?
I was wondering if you keep the predicted one in your office and not let them have it to kind of...
Compare, that's a good question. The question is, do I keep the top part, the predicted part, in my office when the clients leave? That's good. So you're saying that that may influence. So I see you're an experimental psychologist. That's a research-based question. Meaning it's gonna right. That's a good question. I usually give them the entire sheet, but I see what you're saying. That's a good point that you're saying, that keep the top part, that it shouldn't influence the way they're answering the second part, and then they come back and say, okay, let me show you what you wrote last week. I like that. It's something that I don't do, but that's a good point. I should really do that. That's a very nice way of making it a bit more scientific here. Yeah, I usually give them the whole thing, and even with giving them the whole thing, they themselves are honest. We're like, yeah, you know what, I feel better. But something even tighter is what you're describing. Well said. All right, so that is schedule of activities. Let me share with you, before we break for our morning break, a humorous little report that speaks exactly to the experience of depression as it relates to the prediction of activities versus activities. All right, report. Getting out of bed in the morning sharply increases risk of things getting even worse. According to a report, the act of getting out of bed in the morning dramatically increases the risk of things becoming even worse. No matter how bad things were upon waking up, the very moment our trial subjects pulled off the covers and stepped out of bed, things spiraled even further downward for them in roughly 92% of all cases, said lead researcher Alison Chaudhary, who added that her research team observed no instances in which rising from one's bed and beginning to go about one's day improved things for any of the test participants. Chaudhary noted that the only guaranteed way to ensure everything doesn't fall apart right in front of your eyes is to stay in bed, pull a blanket up over your head, and remain there indefinitely without moving. This is exactly the way depressed people think. Someone sent this to me as like a humorous kind of thing. I read this, I said, this is depression. This is the prediction of how horrible things are going to be. If I get out of bed, it's all going to fall apart. Yes, because right now you're in bed, and there's no internal state of arousal, so your prediction is horrible. So yes, if I step out of bed, it's all going to fall apart. This really is a humorous but brilliant window into the way our clients with depression actually think. Let's move on with a brief discussion about anger, and then we move on to anxiety. Anxiety is going to be an expanded discussion. Let me start off with the cognitive model of anger, and then an intervention that has quite an overlap with anxiety as well, as we're going to see. The cognitive model of anger, often individuals with anger issues, experience some kind of external or internal event, and because they have strongly held core beliefs about social should or should not, they react in destructive ways. The core belief often of anger is strongly held beliefs about should and should not. The world should not. People should not. My spouse should not. My children, co-workers should, very strongly held should. If you have a very, very, very strongly held should, and then someone else comes and doesn't really follow your requirement, doesn't follow your should. The world should. People should line up in a row this way. People should drive this way. My father should respect X, Y, Z. My parents should do should. Very strongly held should. People are not going to always follow your should. And if you have that very strongly held sense of should and you don't get it, that's where you have that experience of anger. Should. Right? One of the great cognitive psychologists would call that we should stop shoulding ourselves. Right? That's a way in which you could present it to clients, and it's an interesting way of remembering that what does strongly held shoulds do for us? An event happen, goes against your should or should not, physiological and emotional anger. Let me share with you one intervention for anger, and we speak to this because we'll see that when it comes to anxiety, there's an overlap to this as well. Okay? One of the things that we need to help our clients do is identify the sensation, the body sensation of anger. What is anger physiologically? Where do you feel it when you're getting angry? What is it? Where do you feel it? When you have that first indication that you're going to be getting angry, is there somewhere you feel it? What's the location there? Now, the reason we want to help them identify the body sensation, and you can even sometimes trigger it in session. Sometimes you know that certain topics trigger your client. So you may even go there and get them a bit angry. Now, not too much if you know they have impulse control, right? And then as soon as it starts to hang on, where do you feel that right now? I notice that you're getting a bit angry. Where are you feeling that? Where are you seeing that right now, right? Where in your stomach do you feel that, right? And that's an important way for them to understand and appreciate what that physiologically feels like, right? What is the location? What is that body sensation of anger? Now, the reason we do that, the advantage of doing that, is that when we present to them this intervention of the mountain task, and let me describe what this intervention is. When we get angry, there is a range between that first point when I start getting angry, that first moment when anger kicks in, and we're going to call that the initiation phase. And then we start getting angry, right? We start getting all riled up and things grow for us and we start progressing up the mountain of anger. And then at some point we hit the point of no return. What's the point of no return? Once you cross that point, you're going to have an anger explosion. You're going to yell, you're going to scream, you're going to hit, you're going to get violent. You cross a point where that's it, it's going to happen. How long do we have from initiation? Initiation is a little bit I'm feeling, I think I'm going to get angry. Now, it also helps clients not just identify the body sensation, but what contexts get you angry? Who walks through that door and you know you're going to get angry? There's certain people who walk through the door, I'm getting angry. That person walked in, I'm getting angry. Or maybe there's certain times of day where you're more likely to get angry. At evening time, you're tired, you're hungry. We know when you're tired, you're hungry, you're more likely to get angry. So identify not just the body sensation, but the context. And then you know, okay, it's starting. Now, how long do we have from initiation to the point of no return? Various people have various zones of intervention. You cannot intervene over here. A second before you punch someone, you're not going to do mindfulness exercises. You're not going to be able to count till 10. You're not going to be able to express yourself in healthier ways. You can't. That's it. You're about to aggress. So we have to figure out with our clients to identify what is the intervention zone. Some people, that intervention zone could be 10 seconds. For teenagers have a short intervention zone. right? People with impulse control, short intervention zone. Other people may have a wider intervention zone. Some people have a 3-minute intervention zone. From when it starts and it goes up and it goes up. And whatever intervention we're going to be teaching our clients, you need to be doing these interventions only during that intervention zone, because once you cross the point of no return, it's not going to work. All right, so this is an important, I actually draw this out for clients. I draw a mountain, I draw the initiation line, we talk about it. Sometimes clients think that they don't have an intervention zone. I've done it with college students, specifically impulse control. I have nothing. I go from 0 to 60 in a second. So let's see if that's really true, because that's not true. That's just physiologically impossible, right? There's a buildup there. Mentally, right? There's a buildup there. So one of the works that we do with our clients is to help them identify, no, you really do have an intervention zone. Now, it may be a short intervention zone. So you send the adolescent out to their real world, they come back next week, and you give them some assignments to identify what is that first moment and when did you hit? And then they come back, yeah, you know what? It took me 15 seconds. It took me 10 seconds. Right? Again, sometimes it's going to be short. But everyone has an intervention zone, but we just are not aware of it. And talking to your clients about it and making them aware of it helps them be aware of it. And then in the moment, they're like, hey, yeah, you know what? It's true. It was a buildup. And once you've identified that and you've identified the intervention zone, now you could start prescribing interventions. What are some interventions you could prescribe? So doing the physiological opposite. Think about what's the physiology of anger. And during the intervention zone, do the physiological opposite. It speaks to the motivation behavior thing that we spoke about a little while ago, right? So can you get angry with your hands open? Right? Try yelling, I'm so angry at you. It doesn't have that impact. Whereas if your hands are like this, I'm so angry at you, it triggers more. Why? Because you're doing the physiology. So keep your hands open. If you know that you're triggered, and you're starting the initiation process, keep your hands open. Deep breathing, right? Deep breathing. Also, when you're angry, you're not engaged in deep breathing. So we want to try to do the physiological opposite, right? Have a relaxed face, right? We know what our face looks like when we're angry, right? A lot of activity in our eyebrow area. So keep that relaxed face. Smiling, right? That's the physiological opposite. That could be prescribed here. Or other kind of mindfulness things, counting and walking away, right? Count till 10, walk away. Do some mindfulness, right? The STOP acronym, that helps people remember the steps of mindfulness. So the mindfulness we discussed yesterday, that also can be done over here. STOP stands for stop, take a breath, observe, proceed. All right? Stop, take a breath, observe, proceed. Take a deep breath, see what's going on, observe some kind of sensation, again, similar to the mindfulness we did yesterday, and then you move on. Or expressing anger in a safe environment also, but it's only going to work during the intervention zone. Now, by the way, we're about to enter anxiety. This is quite identical to what you would prescribe for anxiety, right? If you have anxiety attacks, right, you climax, anxiety attack, and then you're only going to come back down once you have that climax. But even anxiety attacks have an initiation, have a point of no return, and have a climax. So identify what's anxiety for you. When is it starting? What's the escalation process of anxiety? What's your zone of intervention from initiation to the point of no return? And then whatever you're going to prescribe for your client for anxiety, often similar things, definitely the mindfulness part, that could be done in that intervention zone. So the awareness of, I don't become anxious in a second. That's also some of the core belief stuff that clients with anxiety have. I have no control over it, and it's going to hit me, and immediately I'm going to have a panic attack. That's a core belief that clients with anxiety have, that it's going to attack me, and it's going to overwhelm me, and I'm not going to know when it's coming from. And let's identify that. Is that really what happens, or is there an initiation process? You don't go from 0 to 60 panic attack in a second. Panic attack has a buildup. So let's identify the buildup, mindful of the buildup, developing the intervention zone, and intervening during that intervention zone. All right? That is anger. All right? Questions, thoughts in the meantime. All right, let's get right into anxiety. Let's talk about anxiety, and we're going to focus on generalized anxiety disorder. We'll call it worry also in some way. We're going to deal with obsessive compulsive disorder. We're going to deal with specific phobias, and we're going to deal with social anxiety and the interventions. All right? Let me share with you, number one, the cognitive model of anxiety. Because once we understand the cognitive model of anxiety, I think it speaks beautifully to the way we would intervene across anxieties. All right, let's talk about this cognitive model of anxiety. The model suggests that anxiety equals risk over resources. Let's describe what this means, and we'll see how the intervention across modalities, across types, is basically doing this. What is anxiety? Number one is that you believe the world is much more risky than it actually is. How risky is the world? How risky are things in the world? Activities, events. How risky is it going to a public bathroom? How risky is it having a headache? How risky is it, right? How risky? People with anxiety have an overblown view of risk. So what does that mean? That this number here is very, very high. But they also have another thing. They also have a low number of personal resources. Can you take care of your stuff? Do you have the ability of handling life? People with anxiety have a very low number in terms of, do I have the resources necessary to live life? Do I have the resources necessary to deal with adversity? Do I have the resources necessary to deal with stress? People with anxiety have a very low number. No, I can't do it. I don't have the abilities. So yeah, if you have a very, very large risk number and a very, very low resource number, guess what you're going to have? More anxiety. On the other hand, people with low levels of anxiety or no anxiety are people that are much more honest about how the world is risky, where the world is not as risky as you think, and it's a low number here. And in terms of resources, it's a much higher number. I could do stuff. I could take care of stuff. If this number is low and this number is high, then this number is low. Anxiety is lower, right? So our treatment with our clients with anxiety will have a very high number here and a very low number here. Our work with them is on two fronts. Number one, let's try to be more realistic about this number. How risky is it for real? And this is a lot of the cognitive work. The C of CBT, a lot of that's over here. Now, there's some behavior stuff over here also, because you are going to do some behavioral experimentation. So it's not that this is the C and this is the B. The CB and the CB works on both fronts. But the cognitive, the C of risk, let's be more honest about how risky the world actually is. And the B over here is, okay, let's test it out. Let's do a behavioral experimentation, right? You think that's so risky? Okay, let's do it. Let's see what happens, right? So there's a behavioral part also. And then the resources is also what we're working on in treatment, where we are trying to help them identify the resources at their disposal. What can they be doing? What can't, right? This is also a cognitive and a behavioral. Cognitively, they're thinking, I can't do anything. I don't have the resources necessary. Behaviorally, all right, let's activate. Try doing these things. Let's see how effective you are at it. So the objective overall is, once again, help clients challenge the distortion, right? This box right here goes to the risk, and this box right here goes to the resources. Challenging distortions, right? Why do you think the world is so risky? Because you have cognitive distortions. You see the world in distorted ways. You look at something and you only see the risk. That's a cognitive distortion. So we need to help our clients challenge these distortions and also develop more realistic view of how risky is that real, right? You really think that that's the amount of risk that such and such activity is? We have to be more realistic. That's one part of the intervention. The second part is recognition of resources. What resources do you have? What have you done in the past that has worked for you? And how do you now apply that for other challenges? So it's a two-front attack. Be more honest about the risk and be more honest about the resources. Minimizing the risk and increasing the resources, right? I'll give you one example. A realistic view of risk. I had a client who had a fear of flying. Fear of flying, okay? So fear of flying is clearly overblowing the risk. So I asked her, what do you think is the percentage? What is the likelihood, the probability of a plane crash? What's the probability of a plane crash? That's, I don't know, 30%. The 30% likelihood of getting it. Now, if it's 30%, I also would not get on a plane, right? 30%. So we looked into it, and I tried to help her develop more of a realistic view of the probability of a plane crash. I asked her, over the past 10 years, how many commercial airliners crashed? I asked her, give me names of commercial planes that came down, commercial airlines over the past 10 years. And together we were able to come up with a list of 2 or 3 maybe, 4 or 5 things if we would all together in here work on. Think about over the past 10 years, how many commercial airliners came down. So there was that one in Kenya, Ethiopia, that Max one or something. And when I was even more than 10 years ago, there was one in the Everglades. There was a JetBlue plane that went down in the Everglades more than 15 years ago, I think it was. And there was a TWA that was also a while back, right? But think together, how many can we come up with? 10 maybe, commercial airliners, 10. And if you take out the Russian airlines, it even goes down lower, right? How many are there out there? How many planes are currently in the sky right now as we're talking? How many airplanes are flying? So when the United States of America is daytime, when it's daytime in the USA, there are about 10,000 planes up in the sky at any given moment. 10,000. When the United States of America is sleeping, when it's dark here in the USA, there are about 6,000 planes at any given moment in the sky. Do the math throughout the day, throughout the week, throughout the month, throughout the year. Millions and millions and planes. How many passengers? Millions and millions. And we could maybe come up with 10 commercial airliners that came down. The probability of an air crash is practically nothing. It's a minuscule. It's practically, but yes, clients believe that it's much, much more. And part of our work with them is help them, let's reassess the risk. How risky is this for real? All right, but clients, or a client that recently had a father that was diagnosed with schizophrenia. Client comes in to see me, a young lady in her mid-20s, 2 young children. Panic attack. Why? Her father developed schizophrenia. And what my client says is that I know it's genetic, then I'm going to now have schizophrenia, and what's going to be with my children? Who is going to take care of my children now that I have schizophrenia? So I asked her, what's the likelihood of you getting schizophrenia? She said to me, it's genetic, right? Yes, it's genetic. So if it's genetic, I probably have a 50% chance of getting schizophrenia. If I thought I had a 50% chance of developing schizophrenia, I also would be concerned. So we went in, we did some research, and turns out, yes, she has a higher likelihood than a random person you pluck off the street. So there's statistically significant difference between someone whose father has schizophrenia and a random, and even that was a 1.7%. It was a minutia of a number. You're right, in comparison to an average person whose number is a 0.0 something. So, but the numbers was so minuscule in comparison to what she said to herself. She said to herself, I have a strong life, 50%. Yes, that's very, very risky, right? And also the reason, can you do anything about it? That was also very low for her. So part of our job was challenging the distortions, right? Magnifying the issue. How bad is this? That's a cognitive distortion. Fortune telling, right? I know what's going to be in the future. I know I'm going to develop schizophrenia. You're a fortune teller now. That's also a cognitive distortion. You know what's happening in the future. So minimizing the risk and recognition of resources, all right? Let me show you a quick clip that highlights exactly this concept of how clients with anxiety engage in fortune telling. I know what's going to be in the future, and they engage in magnification of how bad things actually are.
We're so excited to now offer our customers baby furniture from the most trusted brands in the industry.
There we go.
I don't get it, Brick. What are you so afraid of? What do you think is going to happen?
We drive onto the bridge, and suddenly there's a terrible cracking sound. The bridge collapses and the car is thrown into a lake. It fills with water and sinks like a big metal coffin. We struggle to get out, but underwater, no one can hear our screams. We all shake with convulsions as the life leaves our bodies. Our bloated corpses go undiscovered for months, but when they're finally dragged out of the lake, they're unrecognizable because fish have eaten out our eyeballs. Eyeballs.
Right, that's exactly what our clients do. Right? Our clients take a small little piece and build and build and build and build and build, and within 20 seconds, this horrific story. Right? So this is fortune telling. That's magnification. How bad, how grand is this? Part of what they're doing is that they take the risk and they magnify times a million, right? So that's part of our work. The cognitive work is to help them on that. So let me give you a couple pieces, and this is speaking towards more of a generalized anxiety disorder. We're going to apply this model with OCD and with specific phobias and with social anxiety. This model, more of the cognitive, but the resources also, right, in terms of the challenging. But let me start off with more of a generalized anxiety disorder model in terms of some risk resources techniques. So each of them speak to both the minimizing of risk and highlighting the resources. Number one is highlighting to our clients the difference between productive worry versus unproductive worry. I found this to be a very, very useful conversation to have with clients, and then them applying it during the week and coming back the following week. Productive worry versus unproductive worry. What does that mean? How do you determine if worry is productive or unproductive? Now, not all worry is bad. Some worry is good, and we want our clients to hear that. It makes sense. If you have some kind of big project tomorrow and you're worried about it, that could be a motivator, right? So the word worry is not a problem. What's a problem is unproductive worry. If you're worrying for things that are unproductive. Now, how do you determine if a worry is productive or unproductive? Well, you determine two facets of the worry. Number one, is it reasonable? And number two, is it actionable? Is it reasonable that this is going to happen? Okay, yes, it's reasonable. And is it actionable? Can you do something about it? If a worry, what you're worried about, is reasonable, yeah, it has a high likelihood of happening, and I could do something about it, so that's productive worry. It's productive. What does that mean? If it's going to happen, or a high likelihood of happening, and I could do something about it, so that's productive. Let's move on to problem solve. So how are you preparing for that thing? Let's work with our clients on helping them. Listen, I'm worried about a presentation I have next week. Great. Is it reasonable that's going to happen? Yes, it's scheduled for next week. Is it actionable? Yeah, who's doing the presentation? You. Can you improve? Yes, so it's reasonable. What can we do together in terms of behavioral activation, in terms of shaping towards the goal? What do you need to do to prepare for the presentation next week? Worrying about a presentation next week is a productive worry. I could do something about it. I'm going to apply resources, help your clients develop these resources, make a list. What's the plan for today? What's the plan for tomorrow? Break up the task into units, right? That's productive worry. On the other hand, you could have some worries that are not reasonable that they're going to happen, and there's nothing you can do about it. It's not, the likelihood of it happening is practically nothing. And even if yes, there's nothing you can do about it. There's zero you can do about this problem. There's nothing you can do about this problem, right? You're worried about something with your children, your married children are not going to do X, Y, Z, and there's nothing you can do about it. Zero. You just worry and you ruminate and you worry and you ruminate about it. There's nothing you can do. That's unproductive worry. You're wasting your energy on that unproductive worry. And even that discussion, I've done this with several clients, and then they take it with them during the week, and they have to come up with examples. They come back next week and say, I did this thing that you discussed. I'll give you examples during the weeks of things that I did that were productive worry and things that were unproductive worry. So even that distinction and that awareness of it is very, very powerful. I'll give you an example, okay? On the flight over here, there's the drink service. So the flight attendant gives this fellow next to me a ginger ale, and he's got a ginger ale sitting on that little tray table. And as this fellow is working with his drink, it's slowly making its way to the edge of the tray table. And it's for sure going to spill on my pants. So I'm looking at the corner of my eye at that cup of ginger ale as it's dangerously making its way towards the edge. And I'm starting to worry that cup is going to spill on my pants. And I'm worrying. Say, is it reasonable? Yes, it's going to spill on my pants. It's about 3 inches off the edge of the table. It's coming down. Is it actionable? I turned to the fellow. I said, excuse me, sir, do you mind you moving your cup a little bit back to the center of the table? It's about to spill. He said, oh, sure, not a problem. I'll actually finish it. Finishes it, done. Beautiful. So I had productive worry. It was reasonable. I did something about it. I problem solved. Done. Everything was fine. A couple minutes later, there's a massive jerk in the plane. Massive turbulence. The plane shakes violently. My first thought is, this plane is coming down. This plane is crashing. No CBT training. The plane's coming down. Massive, massive. Saying, hang on one second. I start worrying. The plane is coming down. Hang on. I know how to do this. Is it reasonable that this plane is going to come down? Well, I know the numbers of plane crashes. The likelihood of a plane crash is practically zero. Practically zero. Yes, every once in a while you hear it's practically zero, especially if it's a tier 1 airliner. It's even less. There's different tiers of airlines, right? So tier 1 airlines are more of the Western, right? So there's tier 1 airlines, a list of tier. I sat recently with a pilot, and he was describing for me all these pieces. I work as a psychologist, and I have people with fear of flying, and we discussed it. He explained to me some of the mechanisms so I could help our clients with it. So he describes that there's tier 1 airlines who fly a plane for, let's say, 30, 35 years. And then what do tier 1 airlines do with their planes once they retire the planes? They sell them to tier 2 airlines. So some of these airlines that come from like shady areas with not a very, very established or organized country or government, they're getting the leftover planes of American Airlines and United, right? And he says that if you really do see a difference in terms of when you look at mechanical problems and even safety violations of tier 1 versus tier 2. So I was flying a tier 1 airline. The likelihood was practically nothing of a plane crash. Now, was it actionable? So I'm sitting on the plane. It's shaking violently. I know the likelihood is almost, and I got my seatbelt on, so what may happen is you get injured if there's turbulence, but I'm sitting. Not reasonable that's going to crash. Is it actionable? What am I going to do? Bust into the cockpit and take over control of the plane? There's nothing I can do about it. It was not actionable. So it wasn't reasonable it was going to come down. It wasn't actionable. It's unproductive worry. I took a deep breath. Unproductive worry. It's a waste of time. So talking to your clients about the difference between the two, helping them identify in their life, what are you doing that's productive worry, and what are you doing that's unproductive worry? And how do we now work with productive worry? There are things that you worry about that you could do things about. So let's help our clients engage in problem solving. All right? Another technique of the risk resources discussion. Challenging worry. All right? There are a couple things that we could help our clients challenge the worry head on. And this is more of a cognitive feature, right? Number 1, setting worry time. This is actually more of a behavioral. This piece is more of a cognitive, right? Challenging worry by setting worry time. Throughout the day, we worry. Throughout the day, we have worries. So what if you tell the worry, tonight at 7 p.m., I'm going to worry. And you set a time. You actually schedule. Tonight at 7 o'clock, I'm going to sit down, and I'm going to let every crazy worry that I have attack my brain. But 7 o'clock tonight. So there's 2 things you're doing here. First of all, during the day, it's 3 p.m., you're in the middle of driving, and a worry pops into your head. Something that you worry about. Say, hold on, it's not worry time. I promise you, brain, I'll worry. But tonight at 7 o'clock, I'll worry. So we have a sense that we need to worry because that's going to help us deal with whatever it is. Okay, you'll deal with the worry, but do that at 7 o'clock tonight. So, and then 7 o'clock comes, and what do? Flood your mind with all the worries that you have. Let it all come down. How long do you get bored of your worries? If you're now sitting and you're concentrating, I'm going to worry right now. You start worrying, all these things start, but within a few minutes, it dissipates. You get bored from it. So the advantage here is, number 1, during the day, yes, I'll worry, but it'll be tonight at 7. And then 7 o'clock comes, it also sometimes becomes humorous when you try to force yourself into worry at 7. So this is actually a very, very interesting technique. I've suggested to many clients, setting worry time. It's very, very effective. Again, it's not my technique. None of this stuff is mine. Literature has even shown that this kind of technique is very, very powerful in helping us minimize worry. Another thing to do in terms of challenging is a pie chart of importance. What does that mean? Your client is worried about blank. You ask your client to visualize this pie chart of their life. This is your life. The entire pie is your life. All right? From this pie of life, how much of that pie is this worry? How much of it? So they say, okay, 90% is the worry. Okay, what about, you have children? Yeah, how important are they in your life? Oh, that's true. Hang on, let me redo that. Okay, let's do, my children are 25%, and now the worry is 75%. Good. What else? Do you have hobbies? Oh, yeah, that's also important for me. Yeah, okay. What about your job, your work, other things, family, past, whatever, all these, and you start allowing your client to consider all these other things in their life that are important to them. More important than this worry. And slowly, as you said, your wife, is she important to you? Yeah, I hope so. Okay, so let's now redo the number a little bit. And slowly the client begins to realize that this thing that was all-encompassing, this thing that you're worried about, right, some vacation you're going to take, and what's going to be with this and that, and how important is that in the grand scheme of life? So you actually draw it out, and slowly that number of the importance of what that worry is becomes smaller and smaller and smaller as you start taking into account everything else important in your life. All right? It's a very powerful way of just helping our clients conceptualize what is that worry. Thought, question, yeah?
The thing that's striking me as you're talking about this is that it's an interest to me. You tell suggest to the client to set a worry time. Well, suggesting that is telling them you're in charge of your worries. And I do this oftentimes with symptoms. I call them symptoms. And people will wait till they get to my office. They have the symptoms. I never thought, when do I start?
Do it yourself. That's interesting. Meaning what?
Tell them that, hey,
the
control you have over these.
That's very good. That's true.
Control, right?
It provides a sense of control where they can themselves.
Do you do it, or
Sir?
you see that I'm wondering if we're doing it, and implying that you do have this control about these symptoms. Not really saying it, but the things we.
Oh, absolutely. Meaning that this collaboration piece, and then giving it giving them an opportunity to now apply it. You're very right. It also provides that sense, and that's also a cognitive feature of it. Where like you have much more control over this than you think. That's a resources. That's a building of the resources part. Well said. All right. Let me share with you a quick clip of Dr. Beck describing this pie chart technique. Also, a very, very useful technique. You just draw it out. Let me show you how Dr. Beck presents this pie chart concept.
There was an economist who was up for a Nobel, or he thought he was up for a Nobel Award, and he didn't get it, and he got depressed. And so I drew a pie chart for him, and I said, okay, well, this is a disappointment, and how important is this career, your career, and getting recognition? And I said, on the pie chart, how much is it important? And he drew in, it was about 85%. And then I asked him, I said, do you have a family? And he says, yes, I have 3 children. And I said, how important are they to you? And at this point, I hit a nerve because he started to weep. And I said, what was going through your mind? And he says, it just came to me that when I was growing up, my father neglected me. And I resolved that when I grew up, I was going to have children, be a good father. And I let him talk about that for a while. And he talked about his children and things that he could do with them and so on and so forth. And so now we redo the chart. And it was now 60% was for the children. And the rest was 40% for the career. And then I asked him about his friends, and they took up a certain percentage, and then his hobbies, and then we covered about everything, and now he was up to 100%. So then I asked him, I said, what about your wife? I said, how are you going to squeeze her in? So he had to redo it. By now, his career had shrunk to 10%. So it's a question of trying to give the person perspective on what is really meaningful in life. We all have serious disappointments, and being bumped down, I'm sure, is a real serious thing. But it isn't life itself. It is just an event in life that's unpleasant, unfortunate, but it doesn't undo everything else. So, anyhow.
Right, the way he puts it, it isn't life itself. It's just an event in life, right? We often contemplate worry as this is life. It's not life. It's just an event in life. And that helps in rethinking cognitively. Let me share with you one more risk resources technique for generalized anxiety. Often clients who have anxiety issues across the board, anxiety often entails also this concept of time urgency. People with anxiety often have time urgency. Now, what is time urgency? This is a personality feature where you're constantly nervous about coming on time, being on time, having enough time, right? Obsession about being on time, right? This obsessionness relating to time, right? They always wish, oh, I need 5 more minutes. And they're always obsessed about you have to be on time. And whoever they're interacting with, make sure you're on time. And people with time urgency not only disturb themselves because they're constantly nervous about being on time and the obsession about being time, but often they drive their entire family crazy as well, right? Think about growing up with a parent with time urgency. The nervousness about you're not on time. Where were you? You're supposed to be on time. A spouse with time urgency. This urgency relating to time. Think about being married, having a long-term relationship with someone who has time urgency. How many family turmoils could be avoided by minimizing time? How many marital issues, long-term relationship issues, satisfaction, how many of these things are linked with a spouse, a parent, a child with time urgency? So part of our work with clients is to identify this feature, because often generalized anxiety disorder and time urgency come together. Now, why is that? Often they're driven by a core belief of perfectionism. I need to be perfect. If I'm not perfect, people are going to evaluate me negatively, and I can't handle that, because that means I'm no good. So how do I guarantee being perfect? I'm obsessive about everything that I do. I need to be perfect. And part of being perfect is I come on time. Because if I don't come on time, what are you going to think about me? If I came 2 minutes late, what are you going to think about me? I want to avoid that. You're going to think negatively about myself, and that's going to trigger that core belief of mine. So generalized anxiety disorder, time urgency are very much intimately connected. And again, people with time urgency do no good for themselves, and they do no good to their family members. I recently was working with a client, a fellow in his 40s. And the reason he was in session, he had some other issues as well, but one of the things that he described and discussed that were very, very painful for him was that he grew up with a mother who has severe time urgency. So generalized anxiety disorder also this mom had, who's a grandmother by now already, because my client had children. So this grandmother, the mother of my client, had generalized anxiety disorder, but a severe, severe case of time urgency. And he describes growing up as a child with a mother who was obsessive about time and how destructive it was for him. And then he describes that that level of discontent continues up to today. He describes to me that a few months ago, just to give you an idea of how impactful this thing is across the family, he describes that a few months ago, his younger sister got married. And the mother, the grandmother, made everyone make sure that everyone knows that they have to come on time to the wedding, because there's going to be family pictures before the wedding. You must get to the hotel at 3 p.m. She let all the children know, all the grandchildren, this obsession about coming on time. And my client is at home now getting prepared for the wedding. My client has a couple teenage daughters who take their time in getting ready for anything, right? And my client was so nervous. What is his mother going to say, and how is his mother going to react if they come late to the wedding? So my client lost it and started yelling at his family members, at his wife, at his children. We got to get ready. We got to leave. We got to leave. We have to go. We have to go. Why? Growing up with a mother with time urgency, so much anxiety was triggered in him. So they get into the car and they're driving to the hotel and he's yelling and he's freaking out about it. And they get to the wedding a couple minutes late. By the time they get to the wedding, to the pictures, 2 of his teenage daughters are crying and his wife looks like she's going to kill someone in terms of her level of anger. And then it was time for a family photo. So everyone gets in for the family photo. And they take this family photo. And in the photo, you see 2 girls crying in the corner, not even wanting to be part of the picture, but they were forced. So they're sitting there in the corner of the picture, crying. And his wife, my client's wife, looks like she wants to strangle someone in the picture. So the pictures come back, and it's so clear that there's something wrong with 3 people in this picture. So the photographer had to Photoshop pictures of these 3 faces from somewhere else, and they Photoshopped it onto this picture that you shouldn't see the disgruntled faces of the daughters and the mother. And this picture is hanging in this grandmother's house. And every time anyone walks through and looks at this picture, and whenever my client's wife passes by and sees it, and whenever my client's daughters pass by and they see it, they remember it's Photoshopped, it's fake, why did this happen? It created such family discontent coming from what? From grandma's time urgency. So helping our clients work on this is a big integral part of generalized anxiety disorder. It's a feature that we don't often talk about in generalized anxiety disorder. But we have to take into account, what is that urgency about time doing to our clients and to their family? So one of the things that we could be doing is, number 1, helping our clients with time management. If you're a perfectionist, you may need to be doing everything for everyone, right? Whatever anyone wants, I'll do it for you. Why? Because they want everyone to be okay with them and be pleasant towards them and have a positive comments towards them, right? They need to be perfect. So sometimes clients need us to help them manage their time more effectively, right? That's part of growing their resources, right? Knowing how to say no, right? Clients who have perfectionistic tendencies say yes to everything. They want to please everyone. They're people pleasers. So learning how to say no, right? Being able to say no. And again, each of these things, as we described yesterday, must be done shaping towards the target, right? Like I described yesterday, saying no. Shaping towards the target of saying no to your boss. Shaping step 1 would be saying no to me, right? So it's got to be, and delegating. How do we help our clients delegate? Think about everything that you do on a daily basis. Are there things that you're doing that someone else could be doing? Right? Think. People with perfectionistic tendencies need to do everything at home. Everything, dinner table, they set it up. Preparing, they do it because it's got to be done perfectly the way they know how to do it. Nobody knows how to set a table like I do, a client says to me. Nobody sets a dinner table like I do. This is a mom with a husband and older kids already. There's another thing that you need to be doing. There's so many things you're doing at home, at work, for your family. You really need to be doing all these things? Yes. Nobody does things as good as I do them. All right, so you're over scheduled, and you can't say no. And so yeah, this time urgency or anxiety, so let's make a list of everything that you do. What would be the easiest thing for you to cross off the list? Shaping towards a target once again. Make a list of everything that you do. You're a perfectionist. You do everything better than everyone else. I agree with you. No one does it as good as you. Now, there's also cognitive work in terms of what would happen if the dinner table is not set to your level, to your standard. So there's a cognitive piece. But on the behavioral front, make a list of everything. Which of these things on this list are you willing to give up? Which one giving up would produce the least amount of discomfort? And that's step number 1 in this shaping towards a target. And then what's number 2 for you? Look at all this list. What would be a second thing on this list that you would be a little bit uncomfortable giving up, but you could handle? Shaping towards the target. All right, so time urgency and helping our clients really build their resources is a big part of this picture, okay? Now, we all are in a profession of chronic worriers, right? I'm sure many of us in this room worry, right? Why is that? That's an interesting kind of discussion, the link between choosing profession and personality type. There's a whole literature about it, right? John Holland, the great John Holland, for his work that he was doing all the way in the 1920s. But John Holland created one of the greatest theories in terms of linking personality and occupation, up to today even. When you talk to occupational psychologists or people who counsel when it comes to occupation, we use the model of John Holland to link personality and occupation. There's something about the occupation of helping professionals that have some feature of worry in them. So what I want to try to do now is we're going to do a role play. All right? Some of you are going to play psychologists, and some of you are going to play worriers, or you're going to play clients. All right? So we're going to match you up in pairs. And then once you're in a pair, I want you to decide who's going to be the therapist and who's going to be the client. All right? Decide amongst yourself who's the therapist, who's the client. And I want the therapist to initiate, right, an intake, so to speak, okay? Develop a little rapport. And then the client, think about a worry that you currently have or a worry that you've had over the past few weeks. I'm sure everyone in here is worried about something, right? Some more, some less. Think about a worry that you have. Convey the worry to your therapist. And then, therapists, use some of these techniques that we've described yesterday and today in helping your client deal with the worry. All right? And then the real brave couples, hopefully, will share with us what you came up with in terms of what was the worry and what were the techniques. All right? So look around. Once again, find someone that you have not spoken to, because it's intake. You don't know them, right? You don't want to do a relationship if you know them already. Find someone, sit down, who's the therapist, who's the client, and role play the interaction. Right there. There's a single here and there's a single here. I'm a matchmaker, right? Or maybe after. Well, that's a great idea. Maybe right after the.
We'll do that right after. Great. That's very good. Do you do video editing also? You do all levels of production, basically. More or less. I see. But in terms of like using footage and creating like editing videos, things like that, you do that. Oh, that's very good. And all right, good. So what I'm going to ask Pesci, and I'll see my interaction with them. I've worked with them for several years already, so I have a relatively good relationship with them. In terms of, obviously there's a copyright that they're going to have over the video, but would they be comfortable using some of the footage to make little video clips and things like that? Is that something that you would be able to do? You think they have a team that does that? Right. I'm gonna speak to my coordinator there. But theoretically, if this is an option, is something that you would be able to do, to use this footage and. Well, that's good. If I'm gonna talk to them and see whatever they need to do to release, if they would, and then all right, do you have a card or something, a number? Your work. Oh, all right, good. I got you. No, that makes sense. That makes sense. Oh, I got you. Company that's working with that shit. Oh, I got you. Oh, that makes sense. That's a company. All right, good, good, good. That makes sense. All right, good. To be able to do that. All right, so you're saying they may have a team on their front. All right, I'll find out. Sounds good. Thank you. So during this time, the people at home are just basically seeing, and when this happens, that's good. That's so far so good. Oh, that's cool. Oh, that's great. And you basically what? You hit enter every time I hit enter? That's natural. Oh, that's great. Oh, that's pretty good. So they get to see both at the same time. It's pretty cool. Oh, that's great. So my maneuvering around is a couple times. That's good, that's good. I like to spread it out to like the crowd, so like, that's true, yeah. Have to spread the love.
Okay, 2 minutes, 2 minutes. Okay. Thank you all for engaging. Allow me to ask, let me ask the therapists amongst you, those who role play the therapist. First of all, ask your client for consent, if they're willing to give you consent, to reveal to all of us what the issue was and what the intervention was. So, all right, so therapist first, can you please ask your client, are you okay with me speaking out and describing the difficulty and the intervention? Do we have any therapists who received consent? Let's start with you. Yeah.
Okay, thank you. What I want to tell you is something
Let me
that
grab the
all
mic.
be aware of probably.
There we go.
Yeah. Oh, thank you, doctor. When I was studying for my PhD degree, this is really right on what has been discussed the last few minutes. When I was studying for my PhD, I thought I had it all, a lot of time people don't finish their PhDs, or they give up. What happened to me was that the head of the department, he liked me, and it was in Utah, and I was trying to do the right thing and everything, and when I finished my dissertation, I had somebody type it up, which is nothing unusual. They wanted to do it, and a person that was a lady that was usually doing the work for some of the PhD candidates, and when she did the papers that I had, she made a mistake, and a very important thing, amount of drug in the brain that they were able to find the percentage or whatever. And it was wrong. It was like too much, like it couldn't be. It was more than what I put in the injection. It was like so my head of the department called me in, and if I was inflexible, like what we've been discussing right now, and I could have got upset, got angry, or got anxious, and given it up altogether, and that would be the end of my career. But somehow I didn't think about it on my own, but I knew some man who was a student too, and he was going through different things, and we used to sit and talk. So you know what he told me? He said, "You know what you ought to do?" He says, "Why don't you take your papers and talk to the different professors and all that were involved, and maybe that's going to make a big difference." And I did just that, and you see, by doing that, I was able to change the mistakes that the typist made. One mistake, really, basically. And he told me I'd have to go and see a number of people, which a lot of people wouldn't have done. It's been unpleasant for them to do that. So they just give up and leave. I ended up getting my PhD in 2 years' time. And I tell you, this thing is very revealing to me. It's like unbelievable, this idea with the numbers. I really appreciate it. And I learn now a lot of things. And not only that, you cover so many areas, mindfulness, everything,
Thank you.
in your system, including the way you've got it set up. I really do.
Thank you very much. Much appreciated. Thank you.
Very good.
So you can learn new things even at 90. What an inspiration, right? What an inspiration. Yeah, we have a therapist. You're the therapist or the client? Oh, there we go. You have full consent?
I have full consent.
All right, there we go. Let's make it happen.
Explain the limits of confidentiality. Everybody in the room gets to know.
Well said, well said.
So this is Kim. And one of the things that we talked about that is really worrying her at the time is that she's about to go into retirement. She's been working for the federal government for the past 20 years. And her position is more seen as law enforcement. So she just needed 20 to meet that eligibility for retirement. And so she's starting to worry and think about multiple things. One is, what am I going to do, in retirement? It kind of has some positive and negative, because it's like, what am I going to do? But also, what do I get to do? So there's a couple of things going on there. And the other portion is the decrease in income, because it's going to go down to, a third of what she's used to making plus a supplement. And so a change in a persistent income that she's been used to for a while is also a worry. So it's kind of causing a little bit of frantic decisions. Okay, I need to go into private practice. I'm going to hurry up and start filling out these applications so I can get insurances to, approve me. You know what? They're taking too long, or this might be taking too long. Let me just start opening up to self-pay. Also, I've been interested for a while in doing daycare, and that might be something enjoyable. Maybe not for counseling, but I just want to really maybe enjoy some time with children. So I'm thinking about that. So I'm going to start doing the paperwork for that as well. And so it's kind of making a little bit of a internal kind of frantic, time urgent type of situation that's happening. So we recognize that it is, to me, it's productive worry in that it's reasonable. She is going to be retiring. And there is some actionable things that she can do. But we also just stepped back for a minute to try to do a little bit of reframing, because as we dug out, I said, will this change in income start to dig into meeting basic needs? Will you be unable to pay your mortgage? Will you be unable to pay your cars? What will happen as a result of this 1/3 decrease in income? And she said, no, my husband works as well. Even with this decrease in income, we will still be able to meet all of our basic needs. She said, the thing I'm really thinking about is I have some teenage daughters, and I don't want them to feel the impact at all of any decrease. I don't want them to not be able to do everything that they're normally used to being able to do. And so that's really kind of what's maybe driving that a little more. And then we started thinking, what about alternatives? And she said, the thing is too, even though I'm eligible, I could still work 2 years longer if I wanted. Additionally, I have this extra savings. So we started to kind of try to identify some things that could maybe put the brakes on needing to make frantic decisions, because the next decisions of her life for the next course of her life are going to maybe be some things that she wants to be able to maintain and do for this next season of life. So I said, before we start jumping in, because these are important decisions to make, we were talking about daycare, and she said that she wants to work with children, but maybe not in counseling, because that might be difficult. She doesn't necessarily want to do kind of a CPS type of thing. But I told her, a lot of the times in daycare is when daycare providers are the ones that kind of find out that children are being abused or different things. So it's something to think through. You don't want to just dive into it if that's not something that you're wanting to participate in. It's not the whole of daycare, but it certainly can be one aspect of it. So trying not to jump into these decisions frantically. We identified some things that could help to put on the brakes. What's the worst thing that could happen? Maybe for a couple of months, the girls won't be able to go to the movies all the time or things like that, but all the basic needs are going to be met. And so we just talked about how we can put brakes on just simply by reframing, understanding that resources are there and there are other alternatives.
That's great. Well said. Well said. Nice. Well, good overview, right? A mixture of both. The components of minimizing the risk or being more reframing, as you described, in terms of the risk component, but also the resources that are at her disposal. Well done. Well done. Very well done. Let's do another example. Another brave therapist who has consent, who's willing to share with us what was the concern and what was your intervention. Or even not a brave one. Even if you're not brave, you could raise your hand. Doesn't have to be brave. Oh, there we go. There we go.
I did really bad. She did good.
That's a automatic thought, we call that.
Yes. So my client is worried about both of her parents. Dad has dementia and mom is having surgery within the week of Christmas or right before Christmas. Client is worried that she's going to be missing a lot of the things that she was looking forward to, such as celebrating her anniversary, Christmas party, but also that her mom could possibly die in the procedure or thereafter, and the mom has had several health concerns, so this is just adding to it. We dug a little bit deeper of where all of this is coming from. Client shared the fact that it could be some resentment, that she's always had to show up, but that's also just the person she is and the daughter that she wants to be, someone who shows up for her parents. She also spoke about her brother and sister-in-law who also help a lot, and she doesn't want to underestimate how much help they give, but it also sounded like client also takes it upon herself to show up for her parents, like I've stated previously. She was the ideal client who solves all her stuff by herself, so that's why it really didn't do that well. But my client was able to come up with, I have to do this, I might miss these things, it's going to be okay, but at least I get to show up for my parents and I'll be there, and then I'll be able to come back. Some of the worries of her mom passing, there's really not much she can do about that. So whether it's reasonable or not, it's nothing actionable that she can do. She can't be in the surgery room with her. She can't undo death or any of that. Hopefully it doesn't happen. But also, she spoke about some of the things that help her when she's worried, like reading, spiritual things, and things that she can do. And she came up with her own interventions, and that whenever she hears the news, it's usually very worrisome in the beginning, but after she gives it some time and reads some books or does something, then she's able to put everything into perspective. So this was just a session right after she found out the news, and she just needs some time to process everything and to come to terms with it. So she did everything.
Well done, well done. But you seem like you're able to help her highlight resources, things that you're doing already. Well done. The client would like to say that the therapist did a good job. Yeah, well done, well done. Question is, how did the therapist take those things that you describe, which are probably triangles, and why did the therapist turn those triangles into squares? Right? That's part of, right? That's great. So the validation, that's great. Well done. Well done, therapist and client. Well done. Thank you for participating on this one. Much appreciated. All right. Let's move on now to OCD. All right. So we described generalized anxiety disorder, worry techniques. We move now to OCD. Let's describe it briefly. You've all seen it. You all know what it is. Brief description. I'll share with you a brief clip that speaks to some of the symptomology of OCD, and then we'll talk about the treatment of choice for OCD. So as you know, it involves both obsessions and compulsions, right? A variety of recurring thoughts, impulses, and images. And it involves also various compulsions in terms of repetitive behavior, right? Let's look at a description of OCD. It's both a reenactment, but also interviews individuals experiencing OCD. It'll give us a greater picture into the symptomology of it. And then we will talk about the intervention component.
In the morning when I wake up, I have to blink my eyes 3 times before getting out of bed. Always with the right leg. Every door has to be opened and closed 3 times before and after going through.
I feel that I have to wash my hands a lot. Especially when I go outside and I come back in, I think I have to wash my hands nearly straight away. And I also have like a feeling of the dirt on my hands, even though if I haven't touched anything, that I need to wash them to get rid of the feeling.
I shower twice, in case the first time I forgot to wash some parts of my body. I then check my throat in the mirror for exactly 15 minutes to make sure I don't have cancer.
I know people that have like traits of OCD, like certain things that would annoy them, like they'd have to have everything straight, like in front of them, like everything lined up perfectly, or else they could like say not let any of their food on their plate touch, like everything would have to be kind of separate. If it touched, then it would really annoy them and kind of make them panicky, and then they wouldn't eat it. I knew this guy that, like, if any of his plate, like say he had mash and like sausages and stuff like that, and if they touched each other while he was eating them, he like wouldn't eat it. He couldn't eat it any after that.
For breakfast I have 2 toasts. Toasted for 3 minutes 33 seconds, cut in 3 parts. I spread the butter 3 times on each piece of toast. The tea with 3 sugar spoons and stirred 3 times. Then 3 sips of tea. When I eat the toast, I have to mash 3 times on the right side of my mouth and 3 times on the left side.
I'd sympathise with people who have forms of OCD because their daily routine is affected by how they go about stuff, because if they don't do this a certain way, they can't continue with their day, and it'll slow them down, and in the long run I think it'll affect them for the worse.
I then spend 1 more hour making sure all the house is completely tidy and in order. Sometimes I try to stop. I try to control myself from doing these things, but it's impossible. I feel like something terrible will happen. I get all tense and I can't breathe. Going to work is an odyssey. I'm always late. Even though I get myself up really early, just like to try and give myself time, but I'll always find something to fix around the house. If there are patterned bricks or cracks on the ground, I can't walk on that line. And if I come to a street with small little bricks, I'd have to find another way around, no matter how long that would take me. And I count every step I make, and if I lose track of that, I'd have to go back and start again.
When I was younger, say if I was going to school and if I had a really good day in school and everything went really well, the next day I'd think like I have to do everything the same way that I did yesterday in order for me to have a good day again. So I'd have to do everything in the order I did it the day before, so the day would be good again.
I never go to the toilet outside home. If I must go, I never touch any handles with my skin. It has to be a case of extreme urgency. And of course, I can't forget about the lines on the floor of the toilet.
When I walk out of a room, say the kitchen, I go back to make sure I switched off the cooker. Maybe do that 2 or 3 times.
When I get up in the morning, kind of always having to listen to music before I start a day, or else it just won't be right.
If I was in England and I thought I'd left the cooker on at home, I'd probably get the next flight back, just to make sure that I hadn't.
I can't blink into people's eyes, no matter if it's a picture, television, or a person in front of me. If I blink, I have the feeling that I might fall terribly in love forever. Interaction with people is becoming more and more difficult. I avoid going out of home or watching TV unless it's completely necessary.
I think there should be help for people out there, and they should seek it out and get it, because I'm sure it can be addressed as a problem if you do look for help.
All right, now that we have the description, let's talk about intervention of choice. In addition to the core belief work, obviously OCD entails some severe core beliefs relating to the world is out of control, perfectionism. So a lot of the things that we discussed yesterday, the triangles and the square. In addition to that, in terms of more of the behavioral intervention, which supplements the cognitive, is the use of exposure and response prevention. This is the gold standard of treatment for obsessive compulsive disorder, exposure and response prevention. Let's describe the components of it, and I'll give you a couple examples. Number one, what we need to be doing is we need to develop a subjective units of distress scale, the SUDS. We briefly mentioned it yesterday. Let's expand on it today. Subjective units of distress scale. What you basically need to do is help your clients generate a list of elements of their OCD that's creating tension for them, anxiety for them, right? And we create this list and then generate some kind of hierarchy in terms of what is the most distressing for you as it relates to blank, and what's the least distressing, right? And again, we described that yesterday. We'll throw now more direct examples. And then you expose gradually. So you have at the upper end the worst fear ever experienced. If I do not check blank, it's going to be the worst for me. As opposed to the lower numbers, which is a complete state of calm, right? So it's that systematic desensitizing that we described yesterday by creating this subjective unit of distress scale. What's the most, what's the least? Sometimes it could be 10 components or 10 steps. It could be 50 steps based obviously on the level of severity. All right, let me give an example of how that plays out in a case study. So let's take exposure and response prevention and the cognitive work, and let's put it together in terms of how does it play out in practice. And we'll use that. You will use a client that I've had many, many years ago that came in with severe anxieties. She was a speech therapist in therapy after a panic attack, after a child ear procedure. So she had anxieties throughout adolescence and young adulthood, but for some reason, right after her two-year-old child, this is the client right over here, her 2-year-old child had an ear procedure, an outpatient ear procedure. The child was getting a lot of ear infections, and they put tubes in her ears, a very, very common technique. But for some reason, right after or during the procedure, she had this panic attack, heart palpitations. She went to her general practitioner. She thought it was a heart attack. He suggested to her that it's probably psychological, and she ends up coming to see me to deal with this panic attack and all these obsessions that were born from this. And her obsessions primarily, she had a few other features, but I'm going to narrow in on this one very powerful feature. Her obsessions were about harming her children and sexuality. A link of harming children sexually. So she was she had these reoccurring thoughts that she's going to harm her children. She was worried about driving over, we had, where this was, there were different bridges, and she was worried about driving over a bridge with her kids in the car because she was going to veer the car off the bridge and she was going to kill her children. So there was all these behaviors that she was avoiding because what if I kill my children? Furthermore, she was concerned that she was going to sexually abuse her children. She had these recurring thoughts and these obsessions about, I'm going to harm my children, I'm going to hurt my children, I'm going to sexually abuse my children. So she stopped bathing her children. Right? Her children were young. She stopped bathing them. She couldn't even help them change their pajamas because she's worried, what if she sees her children naked and she's going to sexually abuse them? So there were all these avoidance behavior that she was also engaged in. So these kids were neglected. They were sleeping in their clothes. They weren't bathed. Good question where the husband was, if you want to look at it more systemically. But these kids were slowly neglected, and she was avoiding many, many behaviors out of a fear of what happens if I harm my children, what happens if I abuse my children. That was her presenting issue, and some of them developed as our sessions continued. She clearly had early home environment, very, very harsh home environment. She described seeing the world as out of control, so she very much had a core belief of the world is out of control. And hence she had all these rigid rules about, right, what does she do, what does she not do, right? There was these obsessions that were reoccurring. So work with her involved multiple fronts. Number one, challenging automatic thoughts and core beliefs. So the concept of things being out of control, or that she's not going to have control. So some of the work in terms of the triangles, squares, places where she did have control, places where she was able to control her behavior. Also, a lot of the work was developing a SUDS for her, subjective unit of distress scale. So I created for her this list, 1 to 10, 10 being what is she most concerned about, specifically about this issue of harming children, sexuality. She says that she would pass out. Just the thought of giving a bath to her children, that is the worst for her. Meaning if she has to be there when her kids are naked in the bath and she's giving them a bath, she's bathing them, that would be something that is just too hard to bear. So that was number 10. That was a certain goal, the highest level of the subjective unit of distress scale. Number 1 for her was seeing her son change a shirt in the bedroom when her husband was in the room. Right? So it took us a while to develop each of the steps. But if her husband's in the room with her and her son, her oldest son, was changing his shirt, that created a little bit of tension, but one that she was able to bear. And then we created the steps along the way. So we've created the subjective unit of distress scale and exposure, which also involved awful behavior experimentation, because she was assuming if this and this happens, I'm going to respond this way. I'm not going to be able to control myself. But slowly, as we progressed together with working on the core belief of life is out of control, we started making our way up the ladder, right? So a comfort level with step number 1, and then a few steps later was her kids are going to put on pajamas. Her children could put on pajamas in front of her and she's in the room, right? And exposure to that, and she was able to control herself. Nothing happened. Deep breathing. So the development of the SUDS, and then moving up the ladder, all right? Also, there was thought-action fusion. One of the things that she was having was a common feature of OCD, which is thought-action fusion. What does that mean? If I think it, it's going to happen. It's a classic OCD concept. Thought-action fusion. I think it, it will happen. So if I think I'm going to kill my children, I will. If I think I'm going to abuse my children, I will. If I think I'm going to drive off a bridge, I will. Thought-action fusion. So we tested that as well. We challenged that as well. I had her in my office. Think harshly, strongly about an action, and then let's see if it actually happens. So let's test this thought-action fusion. In my office, I want you to think about something, and let's see if you're going to do it. So I had her think in my office. I want you to use all your mental energy to think that you're going to punch me. Close your eyes. Think I'm going to punch him. And then let's see if it happens. And it didn't happen, right? She thought, and even though she had the thought, it didn't lead to the action. I've done this with multiple clients in terms of the thought-action fusion is common in many of the anxieties. Let's test it out. Think in my office. You're sitting in front of me. Think hard, strong, with all your mental energy that you're going to hit me. I've done this with many clients over the years. I've never gotten hit, right? That's that awareness of the difficulty or the folly in the thought-action fusion. All right, so that was the steps that were involved. Let me now plug in one more piece to the puzzle. Identical process. Question, yes?
In this case, I might just be ignorant about it because her fear is that she's going to sexually assault her children. Would you have her do exposure, like give them baths or anything like that with the fear that it could possibly happen?
So the concern that maybe this is actually a reality, but it's not just these fears.
That would just come to me immediately. Like I don't want to put the children in any danger.
That's a good question. I mean, that's a good question. You're asking more of like a children's family services kind of question.
Yeah, maybe it's the social worker in me.
So right, that's very good for sure. The question is there any history? Has she done this with anyone? Meaning there's a history here in terms of is she a victim herself of child sexual abuse, which that sometimes is a risk factor. So one of the things that, and I value the question very much, but we have to take into account the context. Is there something behind it, right? If we're dealing with someone who actually abused in the past, and I'm worried I'm going to do this again, so exposing that person to kids may not be the right thing. For sure, it obviously is case by case. In this case, there was no history, there was no past. But a good question, for sure, right? Someone who killed in the past, and they're worried that they're going to kill again, all right, let me put you in front of people, right? So obviously that's going to take into account. Well said, well said. All right, let's add to this in terms of individual phobias. Same kind of pattern, all right? We'll do this relatively quickly because we're just juxtaposing what we've described. You create the SUDS. What's the most distressing in that specific phobia? What's the least distressing? What's somewhat distressing? And then relaxation and then progressing upwards. I want to add here one part. One part I want to add here that we have not discussed. When you develop the SUDS across the issue, specific phobias, OCD, social anxieties, when you develop the SUDS, you have to develop it in the following way. You have to first present the most, then present the least, then present the middle, and then fill it in. Meaning, what happens if you ask your client, tell me what's the least distressing, what's number 2, what's number 3? Very quickly, they're going to hit what? The most. And you want each step to be spread out. You want each step to be manageable. So you have to force your client to spread it out. Give me increments, minor increments, which is why you do 10. What's the most? You do 1, you do 5, and now you got to fill it in. And by doing that, you're helping your clients really, really spread it out by providing increments that are manageable. All right? Let me give you an example with this. This is a client that I had when I was working in Florida many years ago. A client came in with a specific phobia of iguanas. Phobia of iguanas now may not be an issue if you live in Fairfax, Virginia, if you have a phobia of iguanas. But she lived in Key Biscayne. Key Biscayne is a little island off the mainland of Miami, swarming with iguanas. Place is swarming. I've been there, swarming with iguanas. So she couldn't leave her house. She couldn't leave her house. This is a specific phobia. So what did I do with her? We created a SUDS. What was number 10 for her? An iguana jumping on my head. That's a number 10. We wrote it down. 10, iguana on my head. What's number 1? Number 1 for her was the word iguana. Even when I said the word iguana, she felt tension. Very good. And then we put a number 5. Number 5 was watching a realistic video of iguana, whatever it was. And then we filled it in. And then some relaxation techniques. Let's go to number 1. And let's make number 1 a 0. And then they all just come down a little bit. So in my office, do some deep breathing. Iguana, 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 until she was comfortable with that. We moved on to next one, a picture of an iguana. I printed out a picture, showed it to her, did that. Some of these things are done as a homework assignment. So take this picture with you, and several times a day, expose yourself to this picture as you're doing some deep breathing. And then we did some videos, right? So I found a specific video that she's going to watch. Expose yourself slowly, slowly. Now, did I need to make it that for this client, she could deal with the 10? Did I need to make the 10 a 0? No. Why? I also would be uncomfortable with an iguana jumping on my head. So the objective is not for her to be able to be comfortable with an iguana jumping on her head. What is the goal? The goal is to get her to a 7 or 8. 7 or 8 was the iguana's 10 feet away from me. And that's all she needed to be able to get into her car, go to school, go to work. All right, so the objective is not to get to the top. It's get to a point where the client is functional. All right? That's the process. Now, by the way, social anxiety is the same process. You could create the same SUDS for social anxiety. Right? So when we're dealing with social anxiety, there's obviously unlovable schema work. Someone who has social anxiety has an unlovable schema. And you have to do the triangles and square that we described yesterday, but you also do a SUDS, right? You also develop a social systematic desensitization process, which is the theoretical way of calling the subjective unit of distress scale. You begin by working on the least anxiety-provoking interaction and move from there, right? What is the most? What is the least? So a client that I had a couple years ago, the number 10 for her and for him in social anxiety was asking this young lady out on a date. It was a lady that he was working with. He was going to ask her on a date. That for him was he was going to pass out. He was going to just pass out. What was number 1 for him? Eye contact with me. Just looking at my eyes as we were talking, that was a little bit for him. And then we created the rest, right? A lot of the lower steps were with males, and the upper steps were the same things, just with females. So for him, it was very, very clear, very gender-based. So let's get through this with males, and then let's get it through females. And same kind of process. It's social anxiety, unlovable schema work, but also moving up the steps, all right? Mood and relationships are not going to change overnight, right? It's shaping towards the target. The goal is a realization that change is possible and that small steps can restore mood and connection. And every small step of success breeds success. It's a reinforcer, and they can move up the ladder. All right? Let me talk to you about a last final piece when it comes to social anxiety or social interactions. And it's dealing with helping our clients engage in observable and measurable when it comes to openness and communication. It's a very interesting concept known as the Abilene paradox. It's a concept not coming out of mental health and psychology. It's coming out of business management. And what this thing basically is when two people do things both don't want because they think the other one wants it. Two people are doing something together. They both don't want to do it. Why are they doing it? Because they think the other one wants to do it. Let me give you an example on how this is a breakdown in communication. I want on Sunday to have a quiet birthday party for my son. Quiet, my wife, my kids, nothing too big. We had a busy weekend, holiday season, want something peaceful. But I'm worried that my sister, who lives in town, is going to be offended if I don't invite her. So I call her not because I want her to come. I call her because I'm worried she's going to be offended. I call her and say, hi, listen, we're having this birthday party on Sunday. Would you like to come? Now, my sister is thinking, Sunday? I got so much to do. I don't want to go to your party. She says to me, I'd love to come. But she doesn't want to come. Why is she saying I'd love? Because I invited. She thinks I want her to come. She comes to the party. I'm unhappy because she's there. She's unhappy because she's there. We're both doing something together we both don't want. Why? Because we didn't talk openly. How would we have avoided this? I could have called her and said, hey, we're having this party on Sunday. I hope you're not offended if we don't invite you. We want something quiet. And she says, I'm so glad you didn't invite me. I have so much to do on Sunday. Thank you, love you, goodbye. But how many times do we do things in a group? No one wants to do this. The only reason we're doing it is because we think the other one, we could avoid it by just being more open as we communicate. All right? That is the Abilene paradox. It's something that is amazingly powerful in terms of how often we find this happening in social interactions. I was working with a family. The patriarch and the family. Patriarch and the matriarch decided that they're going to rent a bunch of houses down in Orlando for a holiday weekend. And all the kids and all the in-law kids and the grandkids are all going to go down there. No one wanted to go. The grandfather didn't want to spend the money. The grandmother didn't want to work all it. The children didn't want to go. The in-law kids definitely hated the idea. The grandkids but they all went because they thought the other one wanted. And they went down to Orlando for a horrific weekend. It was horrible. They hated it. Everyone hated it. I was like, so why are we doing this? Why do we do this? Nobody wanted it. Nobody. But they all did it because they thought the other one wanted it, and they all ended up very, very unhappy. All right, so this is a breakdown, and often when it comes to social interactions, social anxieties, we have to think about how do we help clients also communicate openly? What is the observable and measurable of open communication, right? You want to have a match between what you're thinking, what you're saying, and what you're feeling. That's open communication. When you're talking to someone, is your mind, your heart, and your mouth saying the same thing? That's open communication, and we have to help our clients really encourage towards that. All right, our next topic is family-based issues, assessment of family, family support for clients with anxieties and depression. We'll get to this topic after lunch. All right, we'll pick up at 1 o'clock for family-based issues and support. Welcome back. We now deal with a few final topics. We have family turmoil, family support more broadly. We'll see how that plays out with overlap with other psychopathologies and the use of family support to help our clients in family turmoil as well. And then we have trauma to discuss, trauma and memory. And then we have borderline personality. That's the plan for the next few hours. So let's deal with family turmoil. How exactly do we use family? Or what does family have to do with this? And how do we draw support from family in an attempt to help our clients help our clients gain a sense of support? So let me begin with a measure. We're going to measure support using this tool known as the social convoy model. Let me describe what it is for you, and then we'll see the wide application of this very simple but quite brilliant tool in assessing the convoy. So in order for us to do this, the way we're going to do this is that we are going to role play on this one. I'm going to actually have you fill this out. You're going to play clients, and I'm going to play your therapist, and I'm going to actually have you fill this out. So I'm going to ask you to jump to the back of the book. The back of the book has the social convoy model. All right, you can find it on page 58. All right, page 58, the social convoy model. Now, the way we're going to go about describing this tool is by doing it. You'll do it, you'll see how this plays out in your own life, and then we'll talk about what does this mean, how is this used, cognitive behavior interventions, etc. So let's begin the role play. I'm going to ask you to be my client, and I'm going to ask you to write your name in this innermost circle right over here. All right, so please write your name in that innermost circle right over there. All right, very good. Now what I want you to do is, I want you to pay attention to this first circle right over here. And in this first circle, I would like you to write names of people who you love and they love you the most. People it would be difficult to imagine life without. You could have a lot of people in that inner circle. You could have very few people, whatever you want. Okay, is there anyone else that you would like to add in circle number 1? All right, very good. Now I want you to pay attention to the second circle right over here. The second circle right over here. In this second circle right over here, I want you to also write names of people who you love and they love you, but not as much as the people in the inner circle. You could have a lot of people in the second circle. You could have very few people, whatever you want. Okay, is there anyone else that you would like to add into circle 2? Very good. Now I want you to pay attention to the third and final circle. In this circle over here, I also want you to write names of people who you love and they love you, but not as much as the people in the inner circles. You could have a lot of people in that third circle. You could have very few people, whatever you want. Okay, is there anyone else that you would like to add into that third and final circle? All right, very good. Cut. All right, that was our role play. Now let's explain what this is. What do we gain by this, right? The richness of this. So first of all, note that I offer you this measure in a very open-ended nature, right? You could write a lot, whatever you want. And by analyzing what people write and what people report, you really get a richness of information that is quite impressive. And I'll just give you a few examples. And I'm constantly pleasantly surprised by when I give this to my clients, how much more I get from them than I even expect. There's constantly new things that this thing reveals that really gives us clinically relevant information throughout treatment. I'll just give you a few examples, okay? So, some people may put pets in their circles. Raise your hand if you put pets in any of your circles. All right, several pets, there we go. Is it important for me as a clinician to know that a client is putting a pet in their circles of support? For sure, 100%, right? We know the literature about pet therapy, what pets do to us in terms of our well-being, right? It's a very growing and developing area of work now, pet therapy. So if clients report pets, we need to be aware of that. That's one thing to be aware of. Another thing that you may get, and just several examples, and there's constant new examples by giving this out. By the way, this tool has originally been a research tool. It was generated at the University of Michigan. Syracuse used it. I was exposed to it when I was doing my doctoral work down in Florida. But it's been a growing research and clinical application, and other traditions have it. Obviously, family systems, the work of Bronfenbrenner uses this model as well. But in terms of a clinical assessment of the network and all these other pieces that you may get by doing this open-ended, it's quite limitless. So another example is that people may put deceased relatives in their circles. So now, the way you know it, by the way, is that once I'm done doing the phase that I did with you here, I would go now back to person 1 in circle 1, and I would ask you, who is this person? Because right now, if I just look at if you're at your circles, it's just a bunch of random names. So I would go back and find out, who is this person? Tell me a little bit, right? So I would have my client now expand on each one of them. Tell me gifts that you have received from them, issues that you have, right? Not gifts, physical things, just more broadly, right? So you want to get more information about each one, and you get to a person, and it turns out it's a deceased relative. It's my grandmother. She passed away, a few months ago. Is it clinically relevant for me to know that my client gains support and feels a sense of support from a deceased relative? Absolutely. All right? Another client, just another example. I'm going to give you a bunch of examples. An example of a client that, remember the instruction, their name is supposed to go here, and then the people in their life go here, here, and here. So I have a client puts his name over here, and then I give them the instructions exactly as I gave you the instructions. They put themselves in this circle, and they put their wife in this same circle. That's against the instruction, right? People close to you go here. But they put their wife in themselves in some way, in their own circle. Now, what is that? It's a red flag for borderline tendencies, right? Dependency, right? It's just a red flag. It shows us something. Or another client that had very few people in their entire circle, which is revealing in and of itself, right? If someone shows you a profile and there are 3 people in the entire network, that's also a red flag. It tells us something about core beliefs, loneliness, right? A client that I did this with puts himself over here as instructed, very few people. Person number 1 in circle number 1 was me. And this was intake. At intake, they put me in circle 1, right? Also, this is something. They're revealing something about core beliefs, right? Suddenly now, I've been sitting with them for a half hour. Now, I'm their best friend, right? That tells you something, all right? So, again, there's a richness of information that you get here that's quite impressive. You could also use it with multiple people, right? So if you're working with, let's say, a couple, you give this measure to both sides of the spouse, the husband, the wife, you give them to both, right? And then you sit and compare. Where did one place the other in the circles, right? So you're sitting with a husband and wife, and then the wife placed the husband in circle 1, and the husband didn't put the wife anywhere. And she's looking at the circles, wait, where'd you put me? Where am I? And who's Jessica, right? So that's a whole other kind of, right? So there's a lot of information that you're getting. I'll give you another example. People put religious figures in these circles, right? So you go around, you identify the name, you talk about it. Again, it's clinically relevant for me to know that individuals put religious figures in the circles. Yes?
What happens if someone put generic names like wife, cousin?
If they just put generic names. The question is, what happens if you put generic names? You ask them to do specifics, right? So as you start seeing them write, just family, you tell them, I want to get specific names. All right? So you have them actually give you direct because you want to see that spread of the network.
Has anyone ever studied the location inside the circle?
In which tier?
No, not the tier, but like put someone at the top of the circle versus the bottom of the circle.
That's interesting. That's interesting. The question is there a difference if someone puts, let's say, in circle 1, if it's over here? Different people start the circle in different places. So even amongst over here, if we look around, some people just wrote over here a few names. Some people actually circle number 1 and go from the top to bottom. There's variations about that component. But the bigger picture here is in terms of what circle are people in, right? So you can put religious figures, for example, right? That's also clinically relevant for me to know. If someone puts in circle 1 God or some higher power, and it's a source of support, I need to know that you're dealing with someone with anxiety. How do we use a belief system with anxiety? All right, there's a lot of growing literature now of the use of spirituality, particularly for anxiety, right? Particularly for the need for certainty, or one of the features of anxiety is a low threshold for uncertainty, or an uneasiness with uncertainty, right? Anxious people, uncertainty bothers them. So how do you throw spirituality in there? So again, if a client puts religious figures in there, also, so the point of it is there's a richness of information that you get by using this open-ended. It's a free, right? The Bullseye is not copyrighted. Print these out. I do this practically with every single one of my clients somewhere close to intake to get a rich picture of their network. When I was doing this as a grad student, my dissertation work utilized this piece as part of several other measures that we gave as part of my dissertation. So we were about 7-8 graduate students and a bunch of undergraduate students and 2 major professors, and it was this massive data collection, and we each wrote our dissertation based on parts of the data. So each of us had to do some interviewing of children. We did this with kids in elementary and middle school, and we had about a total of almost 800 children in the Miami-Dade County Public School system down in Florida. So each of us had to go pull out kids from school, sit with them in the library, and do this with them to gather the data. So I have one visit at some school in Miami. I pull a 5th grader or 6th grader out of class, and we sit down in a quiet corner in the library, and we're doing this. And again, this is the first part of a whole series of questions that I'm going to be asking them. So I'm doing this with them, and this kid that I'm sitting with, this 5th grader, has person 1 in circle 2. He says Jesus. So I write it down and I finish up, and then once it's done, I'm supposed to follow word for word the interview protocol. I turn the page and I'm supposed to point at each single person and say, okay, now let's turn to person 1 in circle. Well, who is blank? So I get to this one, and I turn to him and I say, okay, now let's turn to person 1 in circle 2. Who is Jesus? And he looks at me and says, what did you say? I say, okay, now let's turn to person 1 in circle 2. Who is Jesus? And he gets angry and says, what did you say? I say, okay, now let's turn to person 1 in circle 2. Who is Jesus? And he looks at me and he says, my Savior, you damn Jew. Right? He thought I was being disrespectful when all I was doing was following the interview protocol. So not only can this measure the social convoy, it could measure anti-Semitic tendencies. It's another thing that you could get from it. Okay? So the richness of information is quite impressive, and I'm always impressed by how much you get from clients by giving them this open slate, and they really give you a lot. Yeah, thought question. That's what you did.
I love my pets.
Interesting. Well said. So the question is, when I phrased it, I said people, and the question is, we have to be cautious about the way you present it, especially for people who follow the rules to the T, where they just put people. But even saying the word people, and this has been the way it's been done research-wise, you still have a lot of people putting religious figures or pets. But you're right, what's the phrase that you could use instead of people to, that's a good question. But the protocol primarily uses that word, and even with that word, people still place. You get the richness of information without it. So point over here is that you have an open-ended measure, free measure, do it with your clients. It takes 5 minutes, and there's so much you get that you could be using in your clinical work. All right, let me add a few more features. Yes, yes?
If the person just put God rather than like Jesus or whoever, do you still ask who is God?
Not necessarily. All right. The point over here is just that they're getting the sense of support. They feel a sense of support from some kind of higher power. That's the right. Let me add a couple other components to this that are very, very helpful. You could also measure change over time. Right. If you're working with a client with social anxiety, depression, loneliness, self-esteem issues, you give it to them at intake, and then you're working with them on shifting core beliefs and and shaping towards the target of social, and then you give it to them again 2 months later to see, is there a shift in terms of their network? Are they growing the network? And then you compare, you say, look, you came in here 2 months ago, and this is the way your network looked, and look what you've done over time, right? So also a very, very powerful tool, okay? Keep in mind that there are going to be cultural differences in filling this out. It's also very, very interesting. What does that mean? Us in Western societies have no problem creating a hierarchy of who do I love more than someone else, right? Most of you were able to, yes, I love you more than I love you. Tough luck, right? Why? Because we're American, right? We're individualistic. That's the way it is. We can have that hierarchy and we're perfectly fine with it, right? There are many cultures where they have a very, very difficult time with doing that. There's no hierarchies in terms of relationships. Something to us to be aware of. If you're working with people from various cultures, they may have a tough time with the hierarchy. Now, if a Westerner has a tough time with the hierarchy, that's also an interesting kind of question to ask them. I was doing this with a group of Ethiopians. There was a team of Ethiopian executives who came to our university in Israel. They came to Israel to learn about a lot of the developments in Israel in terms of water conservation and security cooperation, things like that. So they came to our university to study about various features of what's happening in Israel. So I gave them a lecture about management style, something that connected to their managerial work in Ethiopia, right? This country in Central Africa. So I do this with them as part of discussions about network. And so I do this with this group, and as I give them the instruction, as I gave to you, I can tell that they're having a very tough time with it. They're talking to each other. They're not doing it. And one of them raises their hand and says to me, excuse me, professor, yes, can I put my entire village in circle one? That was just fascinating. And then another fellow raised his hand and says to me, can I put the entire world in circle one? So it was very, very fascinating for me. I knew from the literature about the cultural variations, but here I had this clear example of what does this mean culturally? And again, even that is interesting in and of itself in terms of the assessment of it. And finally, keep developmental shifts into account as well. All right? What does that mean? Studies have done this network, this convoy model, with children all the way through the lifespan. So this has been done with elementary school kids, teenagers, college students, adults, older adults. So there's a developmental literature on this. And interesting trends show that children primarily put family members in inner circles and friends in outer circles. And then when they hit the teenage years, there's a shift. Teenagers put more friends in the inner circles and family in the outer circles. And then it shifts again. At some point in the mid-20s, there's a shift again. And people put more family on the inside and more friends on the outside, and that profile stays throughout life. So it's interesting for us when we're working with clients who defy developmental expectation. You may have clients who defy what we would expect developmentally. So if you're working with a 17-year-old and they only have family on the inside and friends are a few on the outside, that's a red flag. It's against developmental expectation. It tells us something. Or the other way around, if you have an older adult that has friends on the inside and family are more on the outside, also, it's revealing. It's something that is being told to us in terms of their network, their thought process. All these things are relevant for us. Question, yeah? That's interesting. So the comment over here is that various cultures may have a difficulty that if you do this with individuals in therapy and then they have to reveal what they reported to other family members, that may cause tension. That's interesting. That's a good point. That's a good example, meaning that in certain cultures it's difficult to create that hierarchy, right? It's all, especially in collectivistic societies, where no, we're all in this together, right? Even our names, in some cultures, you don't really have an individual name. Your name is based on who your father is, what village you come from, right? Ibn something, El Tikriti, whatever it is, right? So that very much is going to play out in the way they note these members. Well said.
And also the developmental piece, it still might be different culturally, because for us, even in teenage years, your family is still
Cool. That's interesting, right? So there's an overlap between the culture and the development. So in certain cultures, there are no developmental shifts. It's always about. That's interesting, right? So you have to take both the developmental. Right, for sure. Right? Like you have to take culture. So when you give this, before you have red flags all over, you must take culture into account. Absolutely, absolutely. All right. So this is the Convoy model in practice. Very, very powerful tool. I constantly refer back to it, even once I give it. And before I even give it back as a second time in follow-up, it's something that you constantly refer back to. And this is not necessarily about family turmoil issues. It's just a client coming in with depression, loneliness, disturbed eating patterns. Find out who's in the network, right? What are we working with? What is your client revealing to you by doing this network, okay? Let's add to now the family concept, all right? Let's talk about family-based core beliefs. The core belief process that we described yesterday, primarily yesterday, was about individual core beliefs and how the individual core belief plays out with others. The question is now, how do core beliefs also impact family dynamics and how that sometimes may impact my ability to engage in healthy ways members of families? So when we think about family-based core beliefs, we have to think that faulty thinking about spouse, parents, in-laws, siblings lead to continuous mental and emotional turmoil, negative engagement. I have a core belief about family member blank. And therefore, whatever they give me, I view through the prism of that core belief, right? The cognitive focus should be on challenging that core belief about self and relationship, right? What is my core belief? Is that impacting the way I engage them? And how do I challenge that? And behaviorally, I want to focus on positive engagement in observable and measurable ways. So there's core beliefs that we have about family members. Let me give you an example, okay? Let's use the visual illustration to highlight an example in the relational sphere. All right, so this is based on a client that I had several years ago whose core belief about a sibling was a specific sibling-based core belief. And it caused a lot of tension between him and his sibling and discord towards his sibling. And he came to treatment for several other things as well, but the sibling piece was very much an integral part of the difficulties that he was experiencing. And what did it turn out, based on our discussions, is that he had a core belief. My client had a core belief that his older brother was better than him. That was the core belief. He is better than me. Now, how did we get to here? Because this core belief played out in many, many other areas of his life as well. Meaning this concept that others are better than me didn't just stay in the sibling context. It played out in many other contexts, including his wife, children, work. He is better than me. Like we said yesterday, our core beliefs often are driven by early sibling dynamics. If you had parental favoritism growing up, guess what? You may grow up with a core belief of, I'm not getting enough. It's not fair. The world is not fair. The world is not fair. Why? You grew up in an unfair world where your siblings got everything and you got nothing, right? So here, this core belief of he is better than you, he is better than me, played out in many different areas of his life. But he wanted to work on this relationship with his sibling. So what did he do? He was describing for me his interactions with his sibling. And what I did was I created this model, and I write in the square, he is better than me. And then I give him examples. You remember your brother called you a loser? So that fits right in, right? If your brother says you're a loser, there we go, he thinks he's better than me. Okay, so that fits in nicely. No arguments about there. But what else was my client doing? He was taking triangles and converting them into squares, like we described yesterday. So the triangle was, the brother said, how is your job? The brother asked my client, how is your job? That's not he's better than me. That is a nice brother who's inquiring about my well-being. But that's not what my client heard. My client took, how is your job? And he heard it as, oh, you got fired again? How's that new job of yours? So you see that? He's commenting about the fact that I got fired. You see that he's better than me. And once my client changed that story, beautiful. Now it fits in. Another example. The client's brother says to him, I like your new car. I like your new car. And a new car, I like your new, wow, that's nice. That's a brother complimenting my client. No, that's not the way my client hears it. My client took that triangle and heard, you know what he's really saying to me? Oh, you got a pre-used Honda? You should see the new Lexus that I got. That's the way my client heard. All right, beautiful, and that's how it goes in. Very nice. Or one more example. They went out for coffee. And the older brother said, let me pay for that. What a nice brother. The big brother wants to pay for coffee. How did my client hear that? Right? You can't afford it. You don't have a good job like I do. You can't afford it. Exactly. That's how we heard it, and that's how it fit in. So number one was creating that core belief, having him understand it, going out in the world and interacting with his brother and trying to find places where that's not what's happening, right? As we described yesterday. But also over here, this client says to me, I get it, after several weeks of doing this and improving to some degree, but he still says to me every time my brother says anything that I feel very bad about it, right? I get it, but I don't feel it. So for him also, we did that cognitive and emotional link, like we described yesterday. Childhood incident, visualize a childhood incident, bring in adult you, and the adult you now comforts you, like we described yesterday. So for this client, he closes his eyes, he's in session, he's doing some deep breathing, and he says to me, I'm on a school bus. This is the vision that he conjures up. I'm on a school bus. And he describes for me, he's about 7, 8 years old, and he's sitting on this yellow school bus on a bench there, and there's a bunch of bullies standing around him, and the bullies are all making fun of him, mocking him, making fun of him. And my client is getting very emotional as he's describing this scene of all these kids making fun of him. And my client says to me, my brother is about to get on the bus. My brother's about to get on the bus. I'm sure he's going to defend me. He's my big brother. He's going to defend me. He describes the brother getting on the bus. The brother joins the bullies in making fun of the client even more. And my client is getting very emotional in my office and saying, can you believe it? He's my brother. He's supposed to defend me. Instead, he's making fun of me. And the brother brought examples of things going on at home that embarrassed him even further. So these bullies were rolling in laughter. My client is becoming smaller and smaller as he is describing. He says, when you see that, he is better than me. That was the moment for him. So I say to him, can you visualize yourself as adult? You get on that bus, sit yourself down, comfort yourself. Sure enough, he gets on, sits down, and he starts talking to himself. Don't listen to these guys. Don't listen to your brother. You're going to be exceptional. You're going to have such a great relation with your son. And he's comforting himself, and he's talking about how exceptional he is, and don't listen to these fellows and what it's going to be in the future for you. And then he quiets down my client. And I ask my client, are you ready to get off the bus? He says, not yet. And he keeps on going. Don't listen. You don't understand how amazing you're going to be. And then he quiets down again a few minutes later. And I say to my client, are you ready to get off the bus? And he says, yes, on one condition. I say, what? He says, can I take my child self off the bus with me? I said, I don't know, there's no rules here, dude. Go for it. I don't know, right? Yeah, that sounds like a great idea, right? And sure enough, he visualizes, gets off the bus, and he describes for me later on what a moving moment that was for him. He had this meeting that night that he canceled because he couldn't go. He was so riled up, and we discussed it the following week to really help him create that link between the emotional components of it and the thought process as well. All right? Any questions so far about family-based core beliefs? Thoughts or questions? All right, let me add 2 more pieces to the puzzle before we move on to trauma. All right? I want to talk about, yes, question. We're going to do a microphone question because I could see this is going to be a good one.
I'm just thinking about the clients that I work with who have almost no support system or a very poor support system. And then some of the family core beliefs with that. And I'm thinking what painful work for them, and can that, the social convoy tool, backfire? You know?
That's interesting. You're saying if you know that they have almost no one to put there, and then giving this to them is going to remind them, and it's going to get, things are going to be worse. That's a good question. So don't give it to them.
I know. Yeah, just...
Right, that's what I would guess. Now, the question is, if there's some movement, or if you know that they're able to use that possibly as part of their work in terms of, okay, what can we do to start filling these areas,
That's a good reframe.
Right?
Yeah, that's kind of what I was thinking.
Right.
I really, just when you're working with someone who's so alone, so isolated, and yet you build in what supports you can from the community.
Right.
Including like volunteer callers and things like that. That can, okay.
Right. But I think you're saying that you really have to think about case-by-case basis in terms of what's going to happen if I present this to them. Is it going to make things worse? Sometimes people say they have nobody, but once they have to start drawing it out, it's like, wait a minute, that's true. I do have a little bit of a network here.
Yeah.
But it's a good question, meaning when you have someone who has such a lack of a network, how do you play with that? How do you work with that? That's a good question. And maybe that tension of creating this creates that growth, right? Tension causes growth. So that showing them this, and, right? It could be. Again, you have to make that analysis, obviously, based on knowing your client, but tension causes growth. And this could be a growth opportunity in terms of an appreciation of who is there. I've had a client that had no one in circle 1 and 2, but only in circle 3. Meaning they had people, but keep them away from me. First of all, that reveals something about their core belief, but also, how do we start getting people closer? But that's a good question, good thought.
Thanks. It was
well said. Okay, let me add now another component. We'll have 2 more components to the family-based and core belief process. And this is a relatively recent development, which is attachment-based CBT. Attachment is not recent and CBT is not recent. But this overlap, and how do we use what we know about attachment within the CBT model, let me share with you an orientation here in terms of how do we use what we know about attachment to help our clients challenge their core belief in interacting with others. So allow me to give you a 30-second review of attachment, right? You've all studied attachment. You've all seen it in undergrad and grad school. I'm sure you've taken seminars on attachment. To refresh your memory, according to the theory of attachment, the one of the greatest theories in developmental psychology out there, all right? The great theory developed by John Bowlby and his student Mary Ainsworth. They came up with this idea that based on that first year of life and your interactions with your mother, you develop a certain attachment type. And whatever happened during that first year stays with you. That's the scary part of the theory. During that first year, the kind of relationship you had with your mother stays with you for the rest of your life. It creates what John Bowlby calls an internal working model. So now as an adult, you have a framework, a model of what are relationships. Every one of us in here has a model of what are relationships. And that model is driven by what? by what happened with you many, many years ago with your mother. Now you're thinking, that sounds very fatalistic, very deterministic. That can't be. Well, research is quite impressive in terms of the continuity of attachment patterns and how that, yes, it actually is quite ingrained. Now, life events could change things, but there's something very powerful about this. This is the original classification, and one of the great books by Mary Ainsworth was published in 1978. Now, John Bowlby did his work during World War II. His student came back to the U.S. Mary Ainsworth opened at the University of Virginia one of the great child research centers. It is quite impressive, the longitudinal work about, yes, based on what happened with you and your mother during the first year of your life, it ingrains into you this model of attachment. Now, what are the three types? So the three types, as you know, are the secure attached people, the insecure avoidant, and the insecure ambivalent. Those are the three types of attachment. So securely attached people had mothers during the first year of life who were open, giving, loving, hugging, right? They offered a secure base. These are mothers who were available psychologically for their babies. When the babies cried, mothers picked them up and hugged them, and they had that personal comfort from the mother. If you, during the first year of your life, had a loving, comforting, snuggly mom who was in tune to your psychological needs, over that year, you have now a secure attachment. And you believe now that all relationships for the rest of your life serve as security. So your relationship with everyone is going to be impacted like that. So you're going to have that security with all relationships. On the other hand, if you, during the first year of life, had an avoidant mother, an avoidant mother is a detached mother. Mothers that aren't into hugging their children so much. And they get irritated when their babies cry. And they're not in tune to the psychological needs and the emotional needs of their babies. If that's what you had during the first year of your life, congratulations. You have now an internal working model of insecure avoidant. And now you're an adult. And as an adult, you're an avoidant adult. In a moment, we'll describe what that looks like as adults, because that's going to start playing a role, psychotherapy and CBT. But you have an avoidant, that's it. And the third type, if during the first year of life, you had a mom who was inconsistent. Sometimes mom was hugging you and supporting you, and sometimes mom was detached. If that's what you had, congratulations. If that was consistent during the first year of your life, you now are an individual with an internal working model of insecure ambivalence. And ambivalence. Now, how did Mary Ainsworth assess this? So Mary Ainsworth had a great way of observing one-year-old babies and seeing the way one-year-old babies respond to their mom. And based on that, she was able to diagnose them, quote, diagnose, classify them. Okay? So if you remember this word, the strange situation, the famous observation protocol developed by Mary Ainsworth at the University of Virginia. She would observe babies in a strange situation. We won't do the details. Hopefully you remember it from some course in the past. And based on that, when mom would come back into the strange situation, securely attached babies would go to mom and give a hug and then go back to play because they're secure. Insecure avoidant babies would look at mom, continue to cry, and not seek a hug. Why? Because hugging mom doesn't do anything for me. And ambivalent babies would run up to mom, hold mom for dear life, and cry and cry and cry and cry. And they were not comforted. Why? Mom is inconsistent. So now, mom, you're with me. I'm going to hold down to you for dear life because I don't know if you leave that door, I don't know if you're coming back because you're inconsistent. That is your ambivalent. All right, so we described the early development of that. Now, attachment patterns impact relationships with others. Today, all of us in this room have one of these three types. Studies indicate that in Western samples, about 50% of people are category 1. So about 50% of you in here are securely attached. About 25% of you are insecure avoidant. Right now, right here in this room, and 25% are insecure ambivalent. Now, it's not exactly representative of what's happening in this room because this is a skewed sample. You're all mental health professionals to some degree. So it's a skewed sample. This is more when the broad population is surveyed. But more or less, in Western samples, the break is 50%, 25, and 25. All right? Some fluctuations may occur based on life events, but patterns are pretty consistent into adulthood. So yeah, there have been longitudinal studies And studies indicate, how did they do the longitudinal study? Very simple. They measured attachment at 1 year, and then they measure attachment when you're 25 or 30. So it was a longitudinal study. Literally, they came back to you 25 years later to do a study. And what did they find? Studies, several longitudinal studies, indicate that between 70 to 80% of the sample retained their attachment classification. So they gave them the strain situation at 1, and then they gave them an adult attachment measure, which you're going to take in a few moments. As adults, comparison between 70 to 80% of people retained their attachment classification. That's pretty powerful. That is pretty ingrained. That's the internal working model. Question? Well said. Good question. The question was, does the person pass it on to their children? The answer is 100%. Because what happens is that if my mom was insecure with me, then I'm going to be insecure with my children. And then my children are going to be insecure now because of that pattern. And then, yes, there's an intergenerational transmission of attachment patterns. Absolutely. All right? And we're going to build on that piece in a moment. Yeah?
One question, yeah, two questions. One, could it be anyone besides mother?
The question is, can it be anyone besides mother? So the original theoretical model was all about mom. But starting in the mid-60s, there have been several studies that started looking at other members of the network and how maybe dads could impact attachment patterns. The answer is absolutely. For sure, absolutely. Again, the original model was mom, but it definitely has been extended into other caregivers as well. Good question. The question is, if you intentionally make the effort, can you fake it, right? So obviously, according to the behaviorists, 100%, because it's all about behavior. Now, this is not a behavioristic theory. But yeah, can you in some way, and I'll answer that question in a moment. I have a piece that's gonna speak to that in a moment. All right, so we have these 3 patterns, and they continue into adulthood. The link is particularly salient in intimate relationships. Where do you see in adulthood this play out in the most intense and pure way? In intimate relationships, right? Because it's a very intimate pattern. And in intimate relationships, all these things are coming to play. So in intimate relationship, long-term relationships, spousal relationships, that's where you see this play out the most. All right? So you could have a client, currently I have a client, that plays this out with his wife in severe, severe ways. But with his buddies and with his other thing, he's like, oh, he's chilled out. And the wife feels that it's my fault somehow, right? But it's not. It's driven by these patterns, right? So it's much more intimate in that. Okay, now, let's start now looking at how that links with what we know today. All right, so first of all, in terms of adults, you have securely adults. These are the secure adults. These are the avoidant. And now, as adults, we refer to it as anxious. This insecure ambivalent is also known as the anxious type. All right, now, how do you measure it? What does it mean for us as adults? And what does this mean for psychotherapy? And what does this mean for core beliefs? Let's do that now. But let's start off with measuring your adult attachment type. Okay, just in case you don't know by now where you stand on attachment, let me draw your attention to the back of the book, to the adult attachment measure. And this is going to be a measure. It's on page 59. 59, page 8 of the measures, page 59 overall in the book. This is going to be a measure where you actually are going to fill it out. All right? So we're going to role play once again. You're going to fill this out. When I have a score, we'll explain what this means, and then we'll see how that plays out with you. So I'm going to ask you to read the instructions at the top of the page and answer the 18 items based on the instructions, and then pause for the scoring. We'll do the scoring together in a few moments. All right, so take a few minutes, fill out the adult attachment scale, and then we'll bring it back. Okay. The way we'll do it now is that before we do the scoring, let's go back to the presentation. Let me describe the 3 types. Then we'll go back and score you. All right, I wanted to give you the questions before you see the detailed adult description so it doesn't skew your answer. So now that we got you being honest, let's go back. Let's describe adults in the 3 phases or the 3 types. Then we'll go back and score you. Okay, so jump back to the presentation part, and we'll come back to your measure in a moment. What does it sound like? What does it sound like to be an adult in each of these 3 types? And as we're listening to this, this is driven, or it's modeled, or the description of it is based on the marital context or the long-term relationship context. But remember that these patterns play out in other relationships as well, right? So the type that you are, the style that you are, plays out in the sibling that you are, in the parent that you are, in the child you are, in the coworker that you are, in the friend that you are, in the client that you are. There are patterns of these 3 types that play out with you and your client. In therapy, you're also going to be like this. Keep that in mind. But let's now describe the adult in each of these categories, then we'll score you, and then we'll see, okay, how does this fit into the cognitive model? How does this fit into core beliefs? So if you're an adult who is securely attached, congratulations, you say, I find it relatively easy to get close to others, and I'm comfortable depending on them and having them depend on me. All right, so there's a comfort level. I could depend on you. You could depend on me. I'm comfortable with that, okay? I don't often worry about being abandoned or about someone getting too close to me. I'm not worried about it, right? You could be close to me. I'm okay with that. There's a security. There's a flow in the relationship. Beautiful. And again, it's linked with remember what mom did 25, 30, 40 years ago. That's security. Yes?
I would like to note that from what I remember about this, that one of the ways that attachment styles change is also through interpersonal trauma. So like you might be securely attached based on your primary relationship with a child, but if you have like domestic violence.
For sure. Well said. The comment over here is that patterns may change based on relationship features later on in life in terms of abuse, things like that, 100%. Studies indicate that about 70 to 80% of people retain their attachment type. Well, what about the other 20%? The other 20% is what you're talking about. You could have a security, but then if horrific things happen in your life, in your relationships with parents, that's definitely going to shift it. Well said. Well said. All right, so that's your secure type. Then your avoidant type says, I'm somewhat uncomfortable being close to others. I find it difficult to trust them, difficult to allow myself to depend on them. All right, there's a difficulty in relying on you, depending on you, closeness, right? You keep your distance. I'm nervous when anyone gets too close, and often love partners want me to be more intimate than I feel comfortable being. All right, you want more out of the relationship than I want. I need my distance. I want my, not that they can't be in a long-term relationship, they clearly could, but they need space, they need their distance. The third type, the resistant ambivalent, says, I find that others are reluctant to get as close as I would like. They want more, much more. I want much more from the relationship than the other person is willing to give me. I often worry that my partner doesn't really love me or won't want to stay with me. I'm worried that you're not going to be with me, that you don't love me, you're not going to stay with me. These are the significant others that need constant reassurance that you really love them. You really love me? You really love me? Right? They constantly need to be reassured. These are the spouses that check up on you to make sure that you really do love them. They check up on you by asking you for your Facebook password. You know, we're in a long-term relationship already. We've been dating for 4 days. And I think it's time for you to give me your Facebook password. But why? Are you hiding something from me? No, okay, so give me your Facebook password. Right? They want to check up. Or these are the spouses, the significant others, that check who you've been texting. They grab your phone when you're not looking. They scroll down to check who have you been texting. Right? They want to double check that you really do love them. I actually heard recently that there's a hidden app that you could download onto someone's phone. And every single text in WhatsApp that they send or receive, you on your phone have a record of it. Right? So you right now may have it on your phone. And if you're worried, that's something interesting, right? Right, so that's I want to check up on you, right? So that is your resistant ambivalent. That's your resistant ambivalent, right? I want to merge completely with another person. That's the sense. Meaning if I'm in a relationship now, I'm going to hold on to you for dear life. I want to merge completely. If you're ever dating someone and they tell you I want to merge completely with you, run away. Just pack your bags and run, okay? This desire sometimes scares people away, obviously, right? Obviously it's going to scare people away, all right? This is your resistant ambivalent, okay? Now, let me add one piece to this, and then we'll go back to your measure and finally see who you are, okay? There's an interesting sequence of research that takes these ideas into the following very fascinating direction, which is what happens when people of various styles get together for a long-term relationship. What happens if there's a marriage, a long-term commitment between various types of styles? And how does that play out in their relationship? It's a fascinating area of study. So imagine two securely attached people are married. Studies show that they have the highest marital satisfaction than other combinations. So the highest long-term relationship satisfaction is two securely attached people, right? They flow off each other, they trust each other, they aren't nervous, right? There's this easiness in the relationship. What happens if a securely attached person has a long-term relationship with an avoidant type? Someone who's secure, the other person needs space, all right? So full disclosure, that combination is me and my wife. My wife is securely attached, clearly. It's one good thing that my mother-in-law did. She's securely attached, okay? Me, on the other hand, I am avoidant. Now, why am I avoidant? Because my mother is avoidant. Why is my mother avoidant? Because my mother is a daughter of a Holocaust survivor. And there's an interesting literature about children of Holocaust survivors and how that impacts their attachment type. All right, so I'm avoidant because of Hitler. The more we can blame on him, the better. All right? So now, what happens when I come home? I come home after a long day at work. I come home and I need some space. My wife understands it. She doesn't question it. She's not worried about it. It's like, okay, she's secure about it. And I can have my time quiet. And then we'll sit and talk, right? So that's a flow that could work, right? At least on the avoidant type, all right? Imagine two avoidant people get together. They're very, very detached. There isn't much connection there, right? Imagine an avoidant with a resistant ambivalent. Imagine if I would have married a resistant ambivalent, right? I come home after a long day at work. I need my space. I need some time for myself at home. My spouse has been home all day waiting for me. My spouse has been home all day waiting to merge completely with me. I don't want to merge completely with you right now. I need some space. You could imagine the tension that the combination avoidant and anxious create. And then imagine two anxious ambivalent with a relationship, right? Imagine the intensity of the emotions of that relationship. Imagine the tension, right? It's that level of merging on both ends. You could imagine the tension that creates, all right? It's fascinating kind of. Now, to go back to your question in terms of faking it. Now, I know that I'm avoidant. I know that it's better for my kids to follow my wife's model. It is ultimately healthier to be securely attached. We can't take that away from Ainsworth's theory, right? If you're securely attached, your marital satisfaction is enhanced. You have closer relationships. Life is easier if you have a secure attachment. There's just no way around it, right? It's going to impact loneliness and depression, disturbed eating patterns. There's a lot of work now about attachment patterns and how they play out in various psychopathologies, right? We're going to talk in a little while about borderline personality. Borderline comes right out of this field over here, right? There's a very nice literature about linking borderline tendencies and attachment components. It's a wide area of research now. So I want to try to fake being secure for the sake of my kids. So thankfully, I'm married to a secure person and I follow her lead. So can you fake it in some way? Number one, you need awareness. you need to be aware of this is who we are, these are the patterns, these are the behaviors. Awareness is step one. So that speaks to a little bit in terms of the treatment, if you want to start infusing this into psychotherapy. An awareness of this is who you are. I give the adult attachment measure to my clients to help them first be aware of who am I, what does this mean for us, what's better and what not better, what's more adaptive. That's the better word, right? What's more adaptive, what's healthier. So yeah, I follow my wife's lead in terms of things that you say to your kids, in terms of, so yeah, there is definitely a way of playing it out or on a behavioral front, and that slowly starts shifting, all right? Let's go back to your measure, to your profile, and then we'll bring it back to the core belief concept, because there's some core beliefs going on here. So back up, go back to your measure, and now let me tell you how to score your measure, okay? What you're going to come up with is two numbers. You're going to have a secure number and an anxiety number, okay? How do you score them? So to derive your secure number, you're going to have to add up items 1, 2, 5, 6, 7, that whole list, but one condition, one caveat. You'll see that some of the numbers have right next to them an asterisk. You need to do something to those numbers before you add them up. What do I mean by that? The numbers that need to be reverse scored, aka 2, 7, 8, 13, 16, 17, 18, what do you do with those numbers? See what you wrote as an answer to question number 2. Whatever you wrote, you're going to have to change that number. What are you going to change it to? If you wrote a 1, you're going to change it to a 5. If you wrote a 5, you're going to change it to a 1. A 2 is a 4 is a 2. A 3 stays the same. You don't reverse a 3 because that's in the middle. So you look at the scale from 1 to 5, and the items that you need to reverse score, see what you wrote, cross it off, offer the reverse number, the reverse along the scale, and after the reversal, then add up your numbers, and then you're going to have 2 scores. Once you have the 2 scores, I'll tell you what those numbers mean. Okay, let me tell you what these numbers mean. Okay, I know when you signed up, you didn't sign up to do math, so I apologize. All right? Now let me tell you what these numbers mean. You're going to have 2 numbers, a secure number and an anxiety number. The secure number that you have is what you score on the continuum from secure to avoidant. Higher number means that you're closer to here. A lower number means that you're closer to here. The range for that first number is between a 12 and a 60. The range of that first secure number is 12, 60. The closer to 60, the more secure you are. The closer to 12, the more avoidant you are. So if you crossed a 40, if you crossed a 50, definitely, right? So the closer you get to 60, the more secure you are. If you have a low number, if you're below a 30, 20, definitely, right? that is more of an avoidant type. Now, the second number is how much of this do you have? How much resistant ambivalent do you have? That's what the second number is. A higher number means you have more of it. What's the range? The range is between 6 and 30. 6 and 30. So for the anxiety number, the range is 6 and 30. The higher the number, the more of that you have. So if you cross the 30, if you cross the 20, you're getting close to 30, that means you got some anxiety there. If you have a very low number on that, if you're single digit, definitely, well, that's not a feature of who you are. And then you look at the two numbers, and it gives you a little bit of an idea of a profile, right? Is anyone shocked with their numbers? Is anyone like, doctor, that can't be? Is no, everyone's secure, everyone makes sense based on what you knew about yourself, right? Very, very powerful. Let me add one more piece to the puzzle, and then let's connect it with the core belief model that we've been talking about, okay? Let me share with you, and this is going to speak to the emotional intensity of this thing and how ubiquitous this is when it comes to places and locations, right? How often you actually see this. This is one of my favorite studies in the world of psychology, where they basically, a group of researchers, brilliant concept, and again, it speaks to the applicability of this in terms of daily interactions. This group of researchers wanted to see something very simple. Do people of different attachment types say goodbye to each other at an airport differently based on attachment type? Because if attachment is this ingrained concept that permeates social interactions, particularly in emotional moments, in intimacy, so saying goodbye to a significant other at an airport is an emotionally charged moment, do you find patterns based on attachment type? So this group of researchers at the University of Denver went down to Denver International Airport, big, complicated, pain-in-the-neck airport. It's the east wing, the south wing. So they went down. This study was published before September 11th, so they went down to the gate, and they first of all observed couples saying goodbye to each other. Right? How do couples say goodbye? And they made a list of about 40 to 50 detailed behaviors that couples do when they say goodbye to each other. And then they observed couples, made notes about how they're saying goodbye. One of them left, one of them stayed. They caught up to the person who's still here and said, "Hi, we're a group of researchers from University of Denver. Can you please fill out an adult attachment measure similar to what you filled out?" And then they also asked them some demographic questions to find out who you're saying goodbye to. They wanted to make sure that you're saying goodbye to a spouse, long-term relationship. This is what they found. Securely attached people said goodbye by, number one, verbal I love yous. I love you. Verbal I love yous. Okay, and again, it makes sense, right? Number two, appropriate physical contact. Physical contact, appropriate. That's number two. Number three, they waited till the final boarding call. They waited till the final boarding call, right? And again, it fits the secure model. Avoidant type, number one, no physical contact. Number two, no verbal I love yous. No verbal I love you. And again, they found out later that they were saying goodbye to a wife, to a husband, to a fiancé, to a long-term relationship. No I love you, no physical contact, and many of them didn't even wait for the final boarding call. They helped them, goodbye, some of them shook hands, see you later, walked away. That is your avoidant type. Now, the resistant, ambivalent, anxious type. Number one, overflowing with emotional reaction. Crying, just an emotional scene. Your husband's going away to 2 days to Houston for a business trip. Do you, right? But there's just think about that tension, right? That anxiety, my husband's leaving, my spouse, my long-term relationship, they're leaving even for a short while. So on an emotional front, there was just an outpouring of emotions was one feature of the anxious type. That's number one. Number two, inappropriate physical contact. What does it mean, inappropriate physical contact? Inappropriate physical contact. That's what it means, all right? That's what it was, right? And again, it makes sense, right? There's that intensity. And number 3, and finally, not only did they wait for the final boarding call, but even once that other person was on the plane already, they stood by the window, looked as the plane pulled out, took off, and waved to the clouds as the plane disappeared, right? There's that level of intensity, that anxiety, right? So quite impressive study. This sounds like a kooky little study. It was published in a Tier 1 journal. Tier 1 journal. It was published in the Journal of Personality and Social Psychology. It's a top journal. I hate them. They reject my papers all the time. It's a top journal. All right? Let's now question, and then we'll plug it into the cognitive model.
Is it possible that secure doesn't mean huggy or kissing or any of that? Because for some of our cultures, that doesn't really...
Well said. The question is, can security mean not necessarily hugging and kissing? Because in some cultures that's inappropriate. That's a good question. A lot of this literature does come from Western samples. So like many limitations to research-based models, we have to think about, hang on, how does this play out in other cultures? How do attachment patterns play out in other cultures? And there's definitely is a growing literature about variations of attachment based on what cultures, because in some cultures it's inappropriate, period, in terms of...
What I mean is the mother and child. Like in some of our cultures, the mothers don't, I think my mom probably hugged me twice in my life.
Right.
Or high in attachment, we're very close.
That's interesting, right? So it's got to be a cultural thing. Well said. Well said. Right, for sure. Then there is, and there definitely is a trend. It's not overwhelming yet because it takes time to do research cross-culturally, and it's difficult to do cross-cultural research, but there definitely is trends to highlight the fact that we must, once again, take culture and see culture as a context behind these patterns. Well said, absolutely. All right, let's now plug this into the cognitive model. All right, let's take the model that we know, and let's now take what we've learned and just plug it right in, okay? Imagine my spouse rejects me, okay? My spouse rejects me. My situational reaction, my situation is spousal rejection. Now, if my core belief is nobody loves me, nobody loves me, how do I take my spouse's rejection? Oh, you see that? You see that? The rejection is because I'm no good. Here you go again. My wife is rejecting me, and what does that do for me in terms of a reaction? I'm sad, I'm withdrawn, right? Because there we go, my wife rejected me again. But what if our clients are educated in attachment theory? What if you teach your clients about attachment theory? What if you teach them about patterns and how ingrained they are? What if you give your clients the adult attachment measure like I gave you, and then you measure it and you have them give their long-term relationship, their spouse? Then, when a spouse rejects me and I have attachment knowledge, I'm able to reframe it as rejection because of his or her style. I understand where she's coming from now, right? Instead of exclusively going based on my core belief of nobody loves me, now I understand. I understand how powerful these patterns are. I know where I'm coming from in terms of these patterns. My wife, I can now slowly help shift the way I react because I'm much more knowledgeable about these patterns. So my reaction is going to be understanding. I'm going to give space. So by having attachment knowledge, we could assist our clients in shifting their thinking towards interpersonal interactions and how these patterns may be impacting the people that our clients are engaged with, and that may help them shift their thinking and shift their reactions. All right? Thoughts or questions before we add a final piece to the family component? All right, let me share with you one final piece of the puzzle in terms of the family component, and then we move on to trauma. All right? I want to share with you one final core belief concept linked with family, but this is particularly a core belief that is appropriate when working with siblings. When there's sibling discord, often sibling discord is perpetuated by a unique sibling-based core belief that's flawed. And our work is to try to help our clients understand that the core belief they have about siblings is flawed. Let me clarify what I mean by that. First of all, in terms of the importance of working on siblings, something that we may not think about, clients are coming in for depression. What do sibling dynamics have to do with it? So first of all, as we described, it informs your conceptualization of their core belief. But also, if you're looking for clients to generate or expand their support network, often siblings could be that network. Why is that? Because as we get older, and this is directly from the Wall Street Journal, the loneliest generation, Americans more than ever are aging alone. Loneliness undermines health and is linked to early mortality, and baby boomers are especially feeling the effect. And there's a whole article, and based on many, many changes that we're experiencing on a societal level, in terms of the fact that we're getting older, lonelier. Why? Several features of changes over the past 50 years are speaking to that. Number one, higher divorce rates. So we're getting older without a spouse. Lower birth rate. We're getting older without children. We're living longer. Take all these things together, and older adults are hitting older adulthood alone. Who could be that anchor of support for them? It could be a sibling. The sibling relationship is the longest relationship that we have. Think about all the relationships that you have. How many years do you have with your parents? If you're lucky, 50, 60 years. How many years do you have with your children? How many years do you have with a spouse, with friends? You could have a sibling relationship last for 80 to 90 years. On average, you're either born into a sibling or within a year and a half or two, you have a sibling. 80 to 90 years of a relationship. This could be the relationship anchor as we get older. This could be the relationship that we rely on. So enhancing the sibling bond during adulthood can serve as a relational anchor. So you have a client with depression, where is a relationship anchor for them? It could be the sibling relationship if it's done well. Focusing on siblings is also important considering the intergenerational transmission of sibling conflict. Another reason you want to focus on it, because guess what, if you're not getting along with your sibling, chances are your kids are not going to get along with each other. Studies do show that there's an intergenerational continuity of disturbed sibling patterns. You don't get along with your sister, what do you think your kids are going to do? Your kids are using you as a model. There's an intergenerational continuity here. An additional reason to focus on the issue now is that unresolved sibling problems often surface in very destructive ways after parental death. If you don't get along with your sibling now and you're not really dealing with the tension, you're not really dealing with the issue, and it's below the surface, guess what happens? One of the parents die, and now you have to deal with some hard issues, wills, money, finances, liquidating homes. And if you don't get along beforehand, now this tension comes and it explodes in such destructive ways. I can't tell you how many people have told me, I haven't spoken to my sibling in 20 years since dad passed away. So instead of using siblings as a powerful source of support during mourning period, it becomes much, much worse. A difficult situation of a mother or father passing becomes much worse because now the siblings are at it and they're fighting, right? It's an amazing, amazing thing where instead of it being used as a source of support, I had a lady come up to me recently who says that a few months ago, their mom passed away. It's her and a few sisters. And their mom passes away a few months ago. And she describes a beautiful relationship with siblings over the years. And now these four sisters had to liquidate mom's house, mom that they loved dearly. So every Wednesday night, they would get together in mom's house. They would sit and drink coffee and tea together and reminisce about mom and laugh and cry together. And then they would go room by room and slowly start emptying out the house. And she says it was the most supportive evenings that she could have ever imagined. Her with her sisters mourning together over the loss of mom. So it can be a very, very powerful source of support if we help our clients reach that. All right? Just to give you an example, I wrote an article recently, Till Death of Our Parents Do Us Part. And it was exactly about this topic. What happens to siblings after parents pass away? But how do we begin to repair sibling relationships now? We buried our father today. And throughout the week-long mourning process, our nieces and nephews behaved remarkably, working together, consoling one another while we, the adults, aged 48 through 57, did not fare as well. Is there any reading material you could recommend? So it's an issue. It happens. And we can help our clients avoid that. How do we breach the subject? So let me share with you. Number one, sibling relationship assessment. One of the things that you can do is to get a little bit of a picture of what's happening in your client's sibling life. And jump to the back of the book, the last of our measures, page 60. And these are just open-ended questions. You could use all of them. You could hand it to your client and have them fill out all of them. Or you could pick out individual questions that you may want to ask. So for example, you want to describe the relationship with each of your siblings. When was the last time you got together? How often do you get together? Number 7, any anticipatory stress. Are you stressed in the lead up to getting together with your siblings? All that is revealing for you as you're trying to assess the current state of your client's sibling dynamic. Conversations, pleasant, not. What do you talk about? Number 11, do you require contact recovery time? After you get together with them, do you need a weekend vacation to detox from your sister, right? That's revealing, all right? So this is a measure that you could use. Again, you could use all of it. They could fill it out as a post-test as well. But usually you pull out individual questions and get a little bit of a picture of where the relationship is now. Now, what if the relationship is not going well? Let me share with you a common, flawed core belief. A common, flawed core belief. And that core belief is linked with what is known as the parental context. Let me explain what this is. Let's describe the flawed core belief. And how do we help our clients shift away from that distorted core belief? The parental context basically speaks to what role did our parents have in creating the relationship that exists now between you and your siblings? What role did your parents play in this? Because we do know that ultimately, a big part of what created the relationship you have now with your siblings are past family dynamics, our parenting practices, our early childhood experiences. But if you don't have a good relationship with your sibling, and you say to yourself, I don't talk to my brother, I hate my brother because he did such and such, I blame my brother for XYZ. So yeah, if your core belief is that it's his fault, and it's your sister's responsibility, if that's your core belief, you're not going to reach out to them. But did you ever ask yourself, you tell your client, what role did your parents play in this? What's the parental context in that relationship you have with your sibling? Let me give you a couple examples of that, okay? Specific examples of using parental context. Now, as I'm going to describe these examples, you may be thinking, hang on, all I'm doing is, instead of hating my sibling now, I'm going to hate my parents. How does that help? We're going to answer that question. But let's first describe the honesty here. You've been blaming your sister all these years. Is it really her responsibility? I'll give you a couple examples based on my clients I've had over the years. Client that I had relatively recently, guilt about sibling inappropriate physical contact in childhood, leading to adulthood detachment. It's a fellow in his 20s, hasn't talked to his sister in 10 years, no relationship with his sister. Why? Because him and his sister had an inappropriate physical contact when they were teenagers. Inappropriate physical contact, he's guilty, it's her fault, she's guilty, it's his fault, they blame each other, no relationship. All right, so it's her fault that we did this, it's my fault that we did this. We start talking about, describe the home you grew up in. Turns out there was parental neglect, loneliness, a desire for affection. The family was cold, detached. There was no room for any emotion, no room for any physical comfort, zero. So is it any surprise that you reached out to your sister for some physical intimacy? You've been blaming your sister and yourself. What's the parental context in the story? Or another example, anger at sibling delinquency and depletion of early family resources. It's a fellow in his 40s complaining to me, telling me in session that because his younger brother had a drug addiction, the family needed to spend most of their money on treatment facilities for this brother. And because this younger, foolish brother had this addiction and spend all the family money on treatment, my client couldn't go to college. I couldn't go to college because of my brother. That's why I have nothing to do with him. So I start talking, he describe early childhood environment. Turns out that the person who introduced his younger brother to weed was his dad. Their parents were very permissive. They let everything go. They had openness when it comes to everything, drugs, and just completely. So this kid growing up in this highly permissive home, complete parental abdication of responsibilities. So for all these years, my client has been blaming his brother. Who is really responsible here? It's not about blame. It's about responsibility. Who's responsible here? I'll give you one more example. And what we're basically doing over here is we're helping our client shift core belief. My core belief is my sister's responsible. Is that accurate? And what happens when you shift it a little bit? You give your client permission to re-engage the sibling. And that's when you follow it up with observable, measurable social exchanges. But you have to have a shift of thinking before your client is even willing to reach out. I'll give you one more example. Anger over sister ruining my life by taking everything. It's a fellow, early 30s, client of mine many years ago, describes he was the second to last in the sib ship. And then the little sister is born, the princess. And when the princess is born, parents do nothing for everyone else except for the little princess. And the little princess gets everything and all the attention. And my client is neglected now because now there's the princess. And his parents basically do everything in the world for this princess and ignore everyone else, especially my client. My client describes further even. He says to me that when this little princess, not the way he referred to her, he said something else. When this little princess was born, he was about 6 or 7 years old. He had chicken pox. He had chicken pox. So they couldn't bring the baby home because he's got chicken pox. So what do? The parents send my client to live in another town by grandparents' house for a month so that the baby could come home. So he had to go for a month at smelly grandparents' house. He hated going there, but he had to be there for a month because the little princess is coming home. And then after a month, when he's healed, he comes back home. And he is excited to finally be back home. And he goes back into his room, and his room is pink. They converted his room into the nursery. And my client's room now is down in the basement. So my client says to me, you see, doctor, my sister ruined my life. So I say to him, hang on, let me understand something. Your sister is 3 days old. She climbs out of the bassinet, jumps into the pickup truck, drives to Sherman-Williams, picks up 2 buckets of pink paint, comes back home and paints the walls herself. And he got it. He got exactly what I was saying. For all these years, he's been blaming his sister. Who is really responsible over what happened? And I asked him, how's your sister doing, by the way? How's your sister's life? That sister that was completely given everything and was completely spoiled. How's her life? Dropped out of college, dropped out of high school, relationship issues, no job. So it didn't work out for her either. She also didn't get such a good deal out of this. So for all these years, you've been blaming her. Who's really responsible? That helps clients shift their thinking. Reframed as parental dysfunction and disharmony, highlighting sister's problems as a result of parental actions as well, it helps our clients reshift their thinking. One more piece. You may be thinking that loyalty to parents may hinder the ability to accept parental involvement. Wait a minute, so now you want me to hate my parents? That's not that. What kind of therapist are you? That doesn't help, right? And I'm loyal to my parents. I'm not going to take that from you. So what we need to do therapeutically often is clients may need to discuss how to exonerate parents before moving forward. Parents also are reacting to something. Think about, clients should encourage to consider parents in the context of parents' childhood and parents' hardship during the client's childhood. What were your parents, right? We need some time to exonerate parents. It's not blaming the parents. It's being honest about the responsibility. The parents were responsible, but they also are human. They also are responding to something. But the main objective here is to permit thinking differently about your siblings. No, it's not your siblings' responsibility. It's not your responsibility what happened. Because ultimately we want to try to reclaim the birthright of sibling closeness, how the natural, warm, and precious relationship failed to launch. This could have been an exceptional relationship for you, an amazingly supportive relationship for you. Unfortunately, it failed to launch. Let's rethink it and let's now try to engage siblings differently. Okay? Thoughts or questions before we do a case study that's going to wrap this up, and then we'll move on to trauma. All right, let me bring together this parental context, core belief shift, with a case study. This is a client that I had, and I'm bringing you this case study to highlight how sometimes it's not as clean and cut as I just described it, right? This parental loyalty piece, it's going to play a role, and we have to know how to navigate both the parental context, but also the parental loyalty. And I'll describe this case which exactly speaks to that. It's a lady that I saw many, many years ago. My client is right over here, a 38-year-old lady at the time. Parents, siblings, okay? So this 38-year-old comes in to see me, and she comes at intake and tells me, I'm here to repair my sibling relationship. And that was her goal. That was it, right? It was causing her also tension and some depression about it, right? So there are these other, but she understood that she needs to do something about her siblings. And she describes a very, very tense relationship with a 40-year-old brother and a 34-year-old sister, and a bit of a detachment with these two over here, okay? Client right here. So we start talking about the family. It turns out her parents are married, but not very happily married. That's what this line over here is. Dad is a workaholic. Dad, growing up to today, is a workaholic. Hours and hours and hours at work, business trips for weeks at a time. Mom was lonely. Mom was lonely. So what did mom have to do to deal with the loneliness? What mom did, sessions with clients uncovered family boundary issues. So the boundaries between the mom and the kids were broken because there was no boundary here, because dad was almost never there. So mom felt like she was one of the kids. And there was no boundaries there, the way she engaged her kids. With zero boundaries, she would tell them what to do, invade their privacy. There was no boundaries here, that's number one. But in addition, what happened was that because she was alone, she needed to take one of these kids and make one of these kids a spouse in a process known as parentification, right? There's a very well-known family dynamic breakdown of familial interactions where one of the children is made a parent. It's called parentification or spouseification. What is parentification? One of these kids is chosen, and now one of these kids needs to be very close with mom, and he gets to have extra privilege, and mom speaks to him about intimate things that the children shouldn't be known about. Right? Parentification, one of the children needs to take more responsibility. One of the children acts more like a parent than a child. Parentification, it can happen with a workaholic dad. Other family contexts also lend themselves well to parentification. For example, single parents. Single parents often have a parentified child. A child that feels, I'm with my mother, I'm with my dad, I'm like a spouse, and I'm gonna, right? So there's that extra responsibility. It's unhealthy for the person, for the parent, for the siblings. It's unhealthy for everyone, parentification. It could also happen with alcoholism. If one or two of the parents have a problem with alcohol, then one of the children needs to step up and say, I gotta take care of stuff. I gotta be the parent over here. Also parentification. It could happen when one of the children in the family has a disability and the parents are stretched. So one of the kids needs to step up and say, okay, I'll be a parent also. So parentification is common in various kinds of families. It's unhealthy for everyone. There are long-term studies on parentification. So here, mom chooses this one, and now growing up, he gets to stay up late. He gets to go out to the movies with mom. They go out to coffee. He gets to skip school and go to the mall together. They're a couple a little bit. Now what happens? They all become jealous. Parentification, another victim of parentification, is that siblings become jealous of that parentified sibling. Why does he get all that stuff? What about me? So there's jealousy going on there. Okay? This one grows up, goes to college. Mom now needs to find another victim, another parentification. So my client, temperament-wise, didn't fit the bill. So mom skips over, and now this one gets to stay up late and gets to go out to the mall with mom and gets to talk among coffee and skip school. And also another issue now, this kid comes back from college and she's still home. So now there's competition. Am I the parent or am I the parent? So you could see breakdown in sibling dynamics. So I explained this to my client. My client understands this process, where all these years, my client has been blaming this one and this one. How did it happen? It happened because of the actions of mom. Mom was alone. Mom needed to parentify. It created jealousy, tension. For all these years, you've been blaming your brother and sister. What was the parental context here? What did your mom do here? And that permitted my client to reach out to the siblings once she shifted her thinking in terms of, let's keep mom out of this. I encouraged her, first of all, to reach out to these two siblings first. And that is a well-known technique. If you're trying to repair a relationship across your siblings, start off with the easier ones. Start off repairing your relationship with the easier siblings. Which ones are less problematic? So over here, these were easier. Why? They weren't parentified. They didn't have that tension here of the jealousy, the skipping over. There was a detachment here, but it wasn't the tension of the two parentified ones. My client reaches out to these two. Hey, let's get together for coffee. We've never done that. Are you open to that? And she was very scared about doing that. We obviously did shaping towards the target, right? So there were other behavioral stuff that I threw in there also. Eventually, she was willing to shoot them an email. They haven't contacted for a while. They had very little contact, right? They're going to get together. And she was pleasantly surprised how beautiful and nice the coffee was. And they resolved to keep up and get together closer. We never get together for coffee like this. Why haven't we? This is what's happening with these. Now, when she tried reaching out to these two are the protectors of mom. They're not willing to have a relationship here without mom. They're the protectors of mom. So my client was having difficulties in reaching out to these because there's loyalty to mom. And exactly as this is going on, the following email exchange occurs between mom and the siblings. I'm going to share with you now an email. You don't have it in your book. It's an email between mom and siblings that is highlighting this issue and the loyalty and the parentification. Listen to this exchange, all right? The background to this exchange is the children forget Mother's Day. Right now, mom is in charge. Mom is the one who runs everything. So guess what's going to be forgotten? Mother's Day. So mom emails the following to 5 adult children. 5 adult children. I want to comment on your Mother's Day opinions, commercialize, need to spend day with family, friends. May I suggest another option for next year? What would make mom happy? Flowers, a card, a barbecue. I'm not interested in explanations. The only response that I would hear is next year we will do better. This is from mom to her adult children. Now, my client reads this and says, this is exactly what I've been talking to my therapist about in therapy. The mom, the way she treats us, the lack of boundary, this is exactly. So my client is all energized from success in therapy. She's going to open this wide open. She's going to blow this wide open. And she decides to email everyone back with an opening shot. What does my client write? My client writes to everyone, and she CCs dad also. Is this a general comment, request, demand, or a response to an ongoing discussion that I missed the beginning of? I'm not sure I understand where this is coming from. Right? Opening shot. Let's open this up. Let's talk. What's happening here? All right? Who immediately swoops in? The big brother, the big parentified brother. He swoops in and writes, I agree with mom on all her points. He's the protective parentified, right? Fellow in his 40s now. He's the protector of mom. He's the spouse. Most importantly, I agree that we should not discuss this as mom asked. We did wrong, and we have done wrong for the past few years. It is egregious, as we are lazy, busy, inconsiderate. It is even more egregious and stupid if someone neglects Mother's Day because of some opinion. As mom asked, the response should be, we are sorry, and we will do better in the future. I think this discussion should end. I respectfully request to be removed from this discussion. Not sure why everyone else, besides one person, recognized that the only appropriate response is mea culpa. Regardless, please remove me from further discussions on this topic. As mom said, she's not interested in excuses. A little respect is in order. This is a very loyal child who's not going to take parental context. My client reads her brother's response and says, this is exactly what I've been talking to my therapist in therapy about. This is exactly it. She's encouraged even further. And my client responds the following to the entire family. You are so right. Mother's Day is meaningful for mom, regardless of what it means for us. However, we all would have benefited from an email or phone call from mom a week ago, or even yesterday, saying that Mother's Day is very important to her, especially since grandma died. And a request to acknowledge Mother's Day now and in the future in some way. Instead, mom responded with an email to her naughty children requiring us to reform our ways without talking or communicating. It sounded like a mother scolding her toddlers for misbehaving. We are all adult children now, and our relationship with our parents need to reflect that. I think we can now show our love and support and appreciation for mom better if we can have some open communication. I would love to talk about plans for next year or sooner that we can acknowledge mom, but it should be done out of love and not fear that we are pissing mom off or that she is unhappy because of us. Very direct, very clear, attempting to start talking about the dynamics here. Who responds immediately? The older brother once again. Do you not know how to remove people from an email chain? I've removed mom and dad. Did you not realize that your previous emails included them? Please remove me as well from any further emails on this topic. You could hear this brother's panic in responding this way. There's a loyalty to mom. What are you doing to our family? This is not the way our family works. So there's this loyalty that these siblings have to mom that prevented them even entering the world of acknowledging the parental context. So it wasn't completely successful. It didn't go anywhere with those two other brothers, with the two other siblings. But my client was encouraged that she understood. And it did permit her thinking, the shifting the thought about responsibility did give her room and permission to reach out to her younger siblings, who for all these years, she blamed herself. But she understood where the responsibility lies. And it gave her permission to reach out to these siblings, the younger ones at least, and create a better relationship. All right? Thoughts or questions? What happened to the father? The father was always out of it, right? Didn't get involved, right? The father was a workaholic, completely detached, right? So very much didn't get involved, I don't know if he didn't care, but he was completely detached from it. Right, he definitely stood on the sideline, absolutely. All right? Any other thoughts? All right, this one we're just going to do as an open discussion right now for a few moments. I want you to think about this whole family-based core belief process. And I want you to, anyone have any thoughts about how this would play out, any specific clients that you thought about as we were describing this, any thoughts that you have. We'll do a collective think, pair, and share about all this concept. Yes, we have a thought over here.
So as you were talking about this family and parentification, I have a very specific client in mind who's the oldest daughter of 6, 7. Mom had her when she was 15 through an arranged marriage. So a lot of what we're working on right now is that she's in that phase of sort of accepting that mom was doing the best that she could as a 15-year-old. Same with dad, who I think was only maybe like 17 at the time. And that's been really interesting just to see sort of how that's been affecting her family dynamic as we talk about it. And she works on like assertiveness skills and building empathy for her mother and also her siblings, who of course have their own feelings about, because mom kind of turned them against her. So it's just been interesting to sort of see how this goes, even though I wasn't necessarily directly doing this because I hadn't learned it yet. That's kind of what we've been working on, is just sort of building that empathy for mom and for dad, and as they try to do better, acknowledging that they're doing better, while also kind of challenging the core beliefs that she created from that family situation.
That's great. That's a good example. That's great. If you're able to apply it, that's always a good objective. Thank you for sharing. Mm-hmm. Any other thought, comment right here?
He isn't my client anymore, but about 2 years ago, I had a gentleman who was in 3rd grade at the time, and mom and dad have 4 boys, and he's the second. And he especially disliked his 4th brother. They're twins, the last 2, but the younger one of the twins. And before I even met him, I met with mom, and mom was like, I'm going to tell you, every issue he has in life is because of his younger brother. He will mention that directly to you. She said he makes it clear, and he's gotten the older brother and the twin to hate younger brother. She said, so if he tells you I love younger brother more, it's not true. It's just everybody else dislikes him, so I feel like I have to align with him.
Wow.
So it was interesting just to see that. But when he came in, everything in his life sucked because of younger brother.
That's
what I gathered from. Sorry?
That's a powerful core belief, right? That's an amazing.
And they're pretty young. Younger brother, twin brothers were in KG at the time. But what I gathered from it is mom and dad had a really rough relationship. They ended up divorcing the next year anyway. But he was really close with mom, where the older son was closer with dad. Then the twins were born, and the younger one was more sick. Like, he would always get sick. He was the one in the NICU the longest. So mom spent a lot of time with him, which made this second son believe that he wasn't loved anymore, or this one took his place. And whenever they would fight, physically fight, he would tell me, she makes me go to my room while the twin younger brother gets to stay with her. I'd rather be punished by staying with her than going to my room. So everything stemmed from, and mom didn't see that because she was like, he's just doing this to be bad. He's just doing this to get on my nerves. But it was more so, I just want the same attention I used to get from you prior to this sick twin being born.
That's interesting. So, and that's interesting, meaning this, my sense is that this kind of sibling-based core belief is not just impacting their interpersonal relationships. It's got this core belief that's going to play out in other areas of their life as well.
And it's interesting. He really got the other two brothers to dislike this brother. And when you speak to them, they're like, oh, we don't have anything against him. Why don't you like him? Because he doesn't like him.
That's a great example.
He controls the family.
That's a great sibling-based core belief. That's a great example. Thank you for sharing. We have now two final topics. We have memory and trauma. And in a moment, we'll see why we're putting memory in there. And then we have borderline personality disorder as our final piece of the puzzle. So let me start off with trauma. Let's describe it a little bit in terms of what we know about it, in terms of what is our role in trauma as helping professionals. Our role is not just with the treatment long term. There are other pieces that we need to be aware of as well. So we'll intro trauma, and then we'll talk about the treatment of choice. So first of all, as we know, trauma is an emotional and physiological reaction to a life-threatening event. An event, life-threatening, emotional, physiological reaction. It can occur when experiencing, seeing, or being aware of a traumatic event, right? It could happen in various kinds of forms. Happening to me, or hearing about an event also, that speaks to secondary traumatization, right? A family reaction to secondary traumatization is being aware of. There's a whole growing area of research now about secondary trauma. What does that mean? A family member experiences trauma and other family members are having similar symptomology to the person who experienced the trauma, him or herself. That's secondary trauma, secondary traumatization. Also something for us to be aware of. When someone experiences trauma, we have to assess what's happening on the family front, because other family members may also be experiencing trauma symptoms, okay? There's a study that I'm doing now with some colleagues in Israel about secondary trauma. And one of the things and we're doing it specifically with siblings. So one of the things that we're finding is that the relationship quality may impact secondary trauma, meaning depending on how close you are to that family member, that may contribute to the experience of secondary trauma. So something for us to be aware of as well, all right? Helplessness, seeing the world as a dangerous place, right? Part of the experience is that the world now is a dangerous place. So naturally, as part of classical conditioning, this may take time, but trauma, one event, could create that sense, all right? It's a subjective emotional experience. What does that mean? Two people could have the same trauma occur to them. One person reacts with PTSD and the other doesn't, right? And that's one of the things that we're going to talk about in a moment. But it's a subjective experience. Two people, same trauma, different reactions, right? So various different people respond differently based on pre-trauma characteristics, which we'll talk about. And we also differentiate between trauma 1 and trauma 2. Trauma 1 is one event. Trauma 2 is a series of traumatic events. And in the treatment event, you're going to see it plays a role, right? So one event that happens to me, trauma 1, if someone unfortunately is exposed to a series growing up in an abusive home, It could be a series of several years of trauma as well. All right, now, how does PTSD play into this? PTSD occurs for a segment of people who experience trauma. Most people, the symptoms of trauma subside after time. Most people within 3 days. So they experience a traumatic event for definitely a few hours, maybe for a day or two. They're having flashbacks and they're having tough time recollection and they're having physiological reactions and there's a whole post-traumatic, but most people within a few days recover. Now, they don't get back to baseline. Obviously, it's a difficulty, but they come back to some kind of functioning baseline within a few hours, within a few days. If for 3 days the person is still experiencing it, and even after 3 days, that diagnosis is known as acute stress disorder, not PTSD. Number one is acute stress disorder. According to the DSM-5, acute stress disorder is if after 3 days you haven't gotten over it, at least with the initial shock, acute stress disorder. Then most people get out of it even after a few weeks, a few months. If after 6 months the person is still experiencing symptomology of the trauma, that is post-traumatic stress disorder. About 10% will continue to experience distress even after 6 months, and that is PTSD. All right, so even 6 months later, there's still flashbacks, difficulty sleeping, disassociating, physiological reactions, nightmares, all these kind of severe traumatic reactions 6 months later, that is post-traumatic stress disorder. Now, what do we do with it? What is our role? So we, as helping professionals, need to be aware of 3 stops along the way. There are 3 stops we need to be aware of and we need to respond to. There's stop number 1, 2, and 3. Number 1 is before the trauma, okay? Here's the traumatic event or the series of traumatic events. What does it mean before? There are characteristics that individuals have that either heighten the risk of post-trauma or are protective factors. What does that mean? As we said, 2 people experienced identical trauma. One person develops PTSD, the other one doesn't. Why? Because they were different before the trauma occurred. The differences can be represented by risk factors and protective factors that were different in both of these people. So what are the risk factors that we know pre-trauma may increase the likelihood of developing PTSD? What are the protective factors that may decrease the likelihood? Let me highlight a few of them. Gender, number 1. Studies do indicate that women are more susceptible to post-traumatic stress disorder. Personality. Studies indicate that individuals who score high on neuroticism, this is one of the big 5 personality factors. On one end is emotional stability. On the other end is neuroticism. So if you're the opposite of emotionally stable, what does that mean? People who are a little more anxious, people who ruminate. That's the neuroticism of the big 5 factor. People who do that pre-traumatic event are more likely to develop post-traumatic stress disorder. Intelligence. Interestingly, studies indicate people with higher IQ are less likely to develop post-trauma. People with higher IQ. Now, why is that? It's a good question. There's a lot of theories about it. But there's a relationship between higher IQ, less post-traumatic stress after a traumatic event. Interesting. Past history. Obviously, if you grew up in a harsh home environment, if you have a past history of abuse, you're more likely to now respond to a traumatic event with post-trauma. Low socioeconomic status. Also interesting. Studies indicate that individuals from lower socioeconomic statuses are more likely to experience post-trauma. Why? A lot of theories. Chances are lower SES means neighborhood risk, ecological risk, and it's the neighborhood risk that is ultimately linked with the past history, which may be correlated with the higher likelihood of developing post-trauma after a traumatic event. And finally, family support as a protective factor, right? Studies indicating what kind of family support did you have before the trauma? Parenting styles, communication styles, warmth at home. These kinds of things are protection if trauma occurs to not develop post-trauma 6 months later. All right? Now we have here the traumatic event. Question?
Is it
No, that's a good question. The question is the point over here is that if you have low SES, you're more likely to experience trauma? No. If you experience trauma and you have or low SES, you have more of a likely developing post-trauma because of a harsh neighborhood environment, right? We do know that in low socioeconomic environments, there's more violence in the neighborhoods. Even the air quality, there's interesting research now about air quality in the inner cities, right? Lead-based paint is more likely to occur in the inner cities. So little children are exposed to lead in paint because these are unfortunately neglected areas and the air quality is different. There's more violence. It's called ecological risk. Low socioeconomic status is an ecological risk, and that may be linked to why they are more likely to experience post-trauma after a traumatic event. So then we have the trauma. We also know that the way people, the therapeutic community, first responders, react right after the traumatic event, that's going to contribute to the possibility of developing post-trauma later on. Meaning what happened right after it happened and how we reacted right after it happened, if it's done correctly, well, in a healthy way, you're less likely to develop post-trauma. Whereas if the response was not appropriate, you're more likely to develop post-trauma. What are the immediate after reactions that we are looking for? So here's a series of them. I'm with you. If you're there as a first responder, holding them, I'm with you, I'm here with you. A sense of support right after the traumatic event. Being productive, having them being productive. Call a family member, do something about it. What can you do? Having them try to be productive in whatever physical capacity they're able to. Cognitive activation. Let them think. Ask them thinking questions. We want to activate their thinking patterns. There's an interesting research study that had survivors of car crashes. As soon as they got to the emergency room after the car crash, they had to fill out crossword puzzles. And then they compare them to a control group that didn't. Those who did crossword puzzles right after the crash were less likely to develop post-trauma than those who didn't. So there's something about thinking right afterwards. Activate the thinking process. Soon we'll understand why that is. When we talk about memory and trauma, I think that clarifies why we find that. Describing the sequence of events is connected to that, right? Describe for the victim what happened. Where are we? What happened before? What happened now? What happened? You tell me what happened before. What can you remember, right? You want to try to create that sequencing as part of the cognitive activation. No emotional flooding. Flooding them with emotional questions is not the thing to do. It used to be the thing to do, but then research caught up to it and said that was unhealthy. The model used to be in first response is, how do they refer to it? They refer to it as, there was a term that they would refer to it, like talking about the emotions immediately afterwards. Debriefing, I think it was known as, right? Emotional debriefing. So as soon as you get there, do the emotions. Studies show that that was ineffective. It was actually harmful. No emotional. Don't flood them now with the emotions. They have plenty to worry about. Don't now flood them even with that. But thinking, you want to trigger the thinking process. And mindfulness, interesting studies do show that if you do mindful exercises, right afterwards you have them put their hand on their stomach and feel the breathing or pay attention to something, right? So you have them do mindfulness right after it happens. These are the components that can make it less likely that they experience post-trauma down the road. Is that a question? Yeah.
So this really sounds a lot like getting them more in the neocortex and less in the amygdala.
Right. Try to get them more thinking cerebrally than amygdala, and we're going to see now why that is in a moment when we talk about memory and trauma. But yes, the comment was that we're trying to create more of the thinking process and less amygdala. Well said. And we're going to expand on that in a moment. All right? Let's now, and then, hang on, we forgot the last step. The last stop along the way is long-term, 6 months down the road. For the 10% or 20%, more or less between 10 and 20% of people who experience post-trauma, we now need to intervene, because if you have post-traumatic stress 6 months to a year later, it only is going to remit after treatment. It's not, if it hasn't happened by then, it requires treatment. And the treatment of choice within the world of cognitive behavior therapy is repeat exposure or prolonged exposure. That's the treatment of choice. Now let's talk about it. Exposure techniques is basically where we expose the client to the traumatic event in memory over and over and over again. So in session, you sit with your client and you talk about the trauma. And you have them go through the memory from beginning to end, repeatedly exposing themselves to the trauma. But there's obviously a way of doing it. That's the big picture. Let's get some of the details, okay? First of all, it's used with trauma 1 or trauma 2 involving a specific intrusion. Trauma 1 is one event. So it's easy to point to that one event, and let's now talk about and remember that event over and over and over again. One event. But if it's trauma 2, you may have to ask them to identify one event within the series. Or if there are specific memory intrusions, right, often part of the symptomology is that the memory is intruding. Memory intrusion. So as I'm going about my daily life today, that memory is intruding. Nightmares during the day, when I'm spacing out, memory intrusion. What's that memory intrusion? And focus on that as part of the repeat exposure. When they are telling you about the trauma, you want to attend to all features of the experience, including the emotional, physiological reactions. So when they're in your session, and in a moment I'll give you a case study that describes it more directly, but when they're in your session and they're telling you about the story, their eyes are closed and I went up and they came, right? Whatever that story, whatever the trauma is, they're telling you the story. As they're telling you the story, you want them to attend to all aspects of the memory, the emotional, the physiological. What are you seeing? What are you smelling? You want to create an integrated experience. That's the important part. You have to create an integrated, it's not just tell me the story. Okay, next, tell me it again. Every time they tell this story, they have to create an integrated experience. What are you feeling? What are you smelling? What are you hearing? Describe that smell, right? And they attend to new parts of it, right? They're going to notice new aspects of the memory. So as they're attending to all these features, I've had clients by the 20th recollection say, wait a minute, there's a rake over there. I never noticed that, right? So there's new features of the memory that they're slowly exposing themselves to and they're re-remembering in some way as they're integrating and having more of that full experience. Now, early anxiety may be triggered at start. The first time that you suggest to your client that we're going to go into that memory, obviously it's going to be an anxious time. So you got to, first of all, you're not doing this at intake, right? The example that I'm going to give you soon is that it took several months of trust work until this client was willing to tell me the story, right? So it's going to take time to build that up, and we do some relaxation techniques and the lead up, but it's common the first time that they're going to expose themselves to the story is going to be anxiety provoking, okay? Now, why does it help? Why does this work? In a moment, I'll give you a case study that describes it specifically, but first of all, why does it work? Telling me the story over, isn't that going to re-traumatize them, right? They're trying to forget this story, and you're trying to remember the story, and in session, they're going to tell you the story over and over and over and over again? Why? How does that work? Let me describe a few things that explain to us why it's very, very effective and very, very powerful. First of all, it assists in tolerating the distress, right? You're scared of a snake, expose yourself to the snake. You're scared of this memory, expose yourself to the memory. You could tolerate the distress of the memory, but much more is happening here. In addition to tolerance of distress, the process can trigger a restorage of traumatic memories in more adaptive ways. We are restoring this memory in healthier ways. And let me explain what that means. What happens is that traumatic memories are stored differently than regular memories. When you store a memory, you store it in one way, in a healthy way, and when you store a traumatic memory, you're storing it in an unhealthy way, a very different way. How do we store regular memories? How do we store regular explicit memories? So right now, all of you are developing a memory of what's happening now. Every one of you in here, except for those who are sleeping, are developing a memory. Now, how is that memory stored in your brain? Right now, what's happening in your brain? I'll tell you what's happening in your brain right now. Regular explicit memories are distributed from short term. First of all, the next 10 seconds of your memory of me standing here, The next 10 seconds is going into your frontal lobe. That's a short-term memory. So for about 10, 15 seconds, everything is in your short-term memory. Frontal lobe. But then what? Then there's the spatial part of the memory, right? This memory, what you're developing right now in your brain, there's a spatial. You're sitting in a room, right? You're sitting in a chair. There's space. Where does the space part of the memory go? Well, that goes in the parietal lobe, number 2, right? The area right under my yarmulke, the parietal lobe. That's where the spatial part is going. But we're not done. You're doing more now in your brain. There's also a visual part. You're seeing me. You're seeing the background, the mirror, the wall, the visual. There's a visual. Where's that going? Well, that's going right over here into your occipital lobe. The visual cortex is primarily what occupies the occipital lobe right over here. And the vision, the memory of the vision, that's where it's going. But we're not done. There's also a verbal part. You're hearing me talk. You're going to generate a memory of me talking. Where's that going to go? Well, that's going to go into your temporal lobe. Your temporal lobe, number 4, the area of your brain between your 2 ears is your temporal lobe. Your verbal, a lot of verbal processing occurs in the temporal lobe. The Wernicke, the Broca, they're in your temporal lobe. They're the verbal processing part. So the verbal memory of me talking now, that's going into your temporal lobe, but we're not done. There's also an emotional part of what you're experiencing now. Right? The emotion that you're having right now, complete boredom, whatever the emotion is, where's that going? That's going into your emotional part of your brain, the limbic system, right? We don't see it here because that is the midbrain, but the emotional part of what's happening here goes into your limbic system. Very nice. This is the way normal explicit memories are stored, happening now live in your brains. How do traumatic memories work? Not like this at all. Traumatic memories are low in processing, less contextual, disorganized, and fragmented. This process doesn't happen with traumatic memories. Traumatic memories are fragmented, they're not processed well, they're very limbic in nature, they're just like, it's a mess how you're storing the traumatic memory. It's disorganized, it's fragmented, you don't have the time to do this. Right? What I described here takes some time, right? You need to be organized. When you're having a traumatic event, you can't do that. So it's a mess the way it's stored. Traumatic memories are low in processing, less contextual, disorganized. Exposure triggers restorage of the memory. What do I try to do basically? What repeat exposure does is that we are going to take that crazy memory that's stored in a very disorganized way. We're going to bring it back out. We're going to talk about it. We're going to remember it over and over and over again with an integrated experience, and we're going to put it back into your brain. But this time, we're going to put it back into your brain in a much healthier way. We're going to make out of this crazy memory a memory that in some way is more similar to regular explicit memories, and you're going to store it now in healthier ways. So basically what happens is that if a traumatic memory happens, if a trauma happens right here, time 1. Time 1 is a trauma. Over here in therapy, you talk about it and you restore it in healthy ways with an integrated experience. Then over here at time 3, when you remember the trauma, what are you going to remember? You're going to remember time 2. You're going to remember what happened when you restored it in therapy. You're not going to be going back to what happened to the actual traumatic event. So that's the beauty of doing repeat exposure with the integrated experience. You're helping the client restore the memory in adaptive ways. When memories are retrieved and contextualized, future recollections are based on the restoration, not the original event. That's what's happening. It's not just comfort level with the memory. We're actually shifting the way the memory is stored. But it has to be done in the presence of a trusting therapist. And that's a crucial part. The therapeutic alliance is another part of the story. It's not just exclusively a memory technique. It's got to be done in a therapeutic alliance. Why? Therapist manner of healthier emotional regulation may be how clients use the experience as a model for their own emotional expression. Some studies tell us that basically the way you are engaged in emotional regulation, you're the therapist. You're hearing now a horrific trauma from your client. How are you reacting? You take a deep breath. You may even tear up, but you are controlled. You're engaged in emotional regulation. That may be a model for your client in terms of their own emotional regulation. That's one of the reasons why that therapeutic alliance is extremely important. But it's even more. Listen to this extra catch. Other researchers suggest that the process is driven by emotional mirror neuron activation. Let's explain what that means. There's this great theory developed about 15, 20 years ago known as emotional mirror neuron activation. We'll plug in the emotional in a second. Mirror neuron activation. What is that? It's a theory, and there's a lot of application now, a lot of research on that now, that when I observe you engage in a certain behavior, areas in my brain are activated as a mirror to what I'm looking at. So if I see you walking, if I see you playing the piano, if I see you doing something, I attend to what you're doing without moving, but I'm attending to you doing it, areas in my brain light up as if I'm doing what you're doing. So if you're walking, I'm looking close to you and I'm looking at you, but I'm not moving, my brain activates as a mirror to what I'm seeing. Mirror neuron activation. It's a brilliant, brilliant discovery in the world of neurology about 15, 20 years ago, and it has unlimited potential. What this means for us, it's quite exceptional. Let's go back to this. Other researchers suggest that the process is driven by emotional mirror neuron activation. When I am sitting with my client and I'm engaged in emotional regulation, the way my mind and the way I'm dealing with the client's trauma, I'm now able to activate in my client's process mirror neuron activation on the emotional front. I'm now emotional regulating and taking deep breaths and dealing with it in more healthy ways. By me doing it and the client being with me and we have a relationship now, I'm able to trigger in my client's mind emotional mirror neuron activation in a healthier manner. So in some way, therapists may take the experience, digest it, and transfer it back to the client. So that therapeutic alliance is creating this symbiotic relationship where now that we're together and now that I'm emotionally experiencing it in healthier ways, it's helping my client experience it in healthier emotional ways. It's really quite exceptional what's happening on the emotional process. The experience also provides emotional validation. There's a third and more simplistic, but also powerful. I'm validating the emotions of the client. All right, so it's emotional regulation, there's a mirror neuron activation, and there's also validation. So the work needs to be done in session. Primarily it's done in session. You don't do homework, although there's some features sometimes that's thrown in, but as a whole, the work is done together with you in a trusting therapeutic environment. Let me give you an example that bring this together, and then we'll throw one more piece onto the puzzle. This is a client that I had many years ago, trauma survivor, 25-year-old, comes to see me for depression and memory intrusions during sexual activity. Right? So depression, casual attitudes about sexuality. When he was having sex, he was having a disturbing thought process, which in the beginning he didn't reveal to me, but eventually comes out that he was sexually abused between the ages of 9 and 11 by 2 boys that were living in his house. He was an only child. His parents had a gigantic house. They invited a family who didn't have a house to come live by them in the basement. This family had 2 older boys, and these 2 older boys were sexually abusing my client from the age of 9 to 11 repeatedly. That was the trauma 2, but there was a clear intrusion. There was one intrusion, one horrific event that happened up in the attic. That was the emotional intrusion, the memory intrusion. Several months of trust work leading to willingness to review the memory. So in the beginning, he didn't reveal it. And when he revealed it, he wasn't willing to talk about it. So it was a lot of months of just trust work, how are things doing, some core belief stuff, some activation stuff, right? But it was primarily building trust in our relationship until he said to me, I'm ready to talk about what happened. And then we did repeat exposure. Every session, 3 or 4 times, he would just go through the memory again and again and again. I came home from school, I went upstairs, they were there, and walked through it. And as he's describing it, very, very tough in the beginning, as he's describing it, integrated experience. What are you feeling? Where are you feeling it? My stomach is hurting. What are you seeing? What are you smelling? There was a specific scent that always existed when this was happening. And he described the scent for me. And what is he seeing? What's happening, right? 3-4 times a session after session, he ended up 30-40 times telling me the story of what happened over and over, right? So repeat exposure of memory with integrative experience, that's the important part. Why integrative experience? We want to try to mimic the way regular memories are stored, where you actually are taking in all of it. So when you're telling me the memory now, let's take in all of it, just like regular explicit memories are done. Okay? After a year-long process, Matt reports less intrusions, a long-term relationship. He actually gets engaged in one of our latter sessions. He gets married, also to a musician. They both moved down to Nashville to further their career. He emails me 6 months later how great he's doing, and this was a very, very powerful process and was very, very helpful for him. Now, not all my clients end with a music career in Nashville. I obviously chose one that ended quite well. It's not always as direct, but this was a very, very powerful process of a willingness after trust building to be able to repeat the story, the integrated experience, intrusions went down, symptomology went down, very, very powerful. Let me add one more piece of the puzzle. Let me share with you a variation to what I'm describing that I don't do, but I draw a part of this for measurement purposes. There's a technique known as narrative exposure. This is not narrative therapy, completely different, it's narrative exposure. This is exactly what I described with one difference. It's everything that I described with one difference. The therapist writes down word for word the memory. So when the client tells you the memory the first time, you type it up. And then the second time, you type it up. The third time, you type it up. Word for word, word for word. So at the end, what do you have? About 40 files. Each file is the word-for-word recollection. Now, what does that give for us? All right, so therapist types it up. First of all, it helps slow the recollection process down. Okay, the clients need to slow down. If I can't write that quickly, hang on, slow down. What'd you say? It slows it down, okay? It creates an integration, just like other trauma work. In each session, the therapist reviews the story, fills in missing spots. You review the final version, and you give the text to the client. Now, what do you gain by doing this? Now, again, I don't do this, but I do take a part of this. What do you gain by having a word-for-word document of the way the client said the memory every single time? You have a way of seeing, are they changing the story towards a much healthier story? Because if I could compare the first time you told me the story and the 40th time, word for word, I want to see that certain linguistic features change over time. What linguistic features? There are 5 linguistic features that this method looks at to indicate to me that my client is getting healthier, that he's integrating the memory in healthier ways. What are the 5 linguistic features? Number 1, disorganized thought, organized thought, repetition, unfinished thought, and integrated thought. Let me describe each of these kinds of linguistic features. And then you'll know which one we want to see more of over time and which one we want to see less of over time. I'll give you an example of what each of these linguistic features sound like in a trauma story. And this is an actual true case. It's a case by one of the participants in a research study that's done using this model. This person that we're going to hear from here experienced a trauma. This is actually from a research team in Israel. And this is someone who survived a terrorist attack. It was an attack that happened about 15 years ago in a pizza store in Jerusalem. A Palestinian terrorist comes in there with a bomb, explodes himself, killing 15 people. Actually, one of my neighbors, their cousin died in that attack. And this is a survivor of that attack. Listen what it sounds like in each of these linguistic features. What is a disorganized thought? This is when the client says, I was lying, I was trying to move, I just came for lunch, oh, kind of wondering. That's labeled as a disorganized thought. What's an organized thought? I was put on a stretcher, taken to a back alley where an ambulance was waiting. That's an organized thought. What's repetition? It was smoke and darkness everywhere, smoke and darkness everywhere. That's repetition. What's unfinished thought? I was thinking about all these. It was just chaos. I couldn't. I'm not sure. That's unfinished thought. And what's an integrated thought? There were a lot of people helping. Part of me was thinking that it was good that it was during the lunch hour because there were so many people in the streets and everyone was there to help. That's clearly an integrated thought. Now, over time, when you compare the first time this client tells you the story and the 40th time, what do you want to see? You want to see less disorganized thought, more organized thought, less repetition, less unfinished thought, and more integrated thought. And the way this is actually done is that you could color coordinate it. What you could actually do is you could highlight in dark colors the unhealthy ones, and in lighter colors the healthy ones. And then you compare the first document and the 40th, and what do you want to see? More light colors, indicating that they are integrating the thought in much healthier ways. So in a brilliant, brilliant way. So pre and post changes in memory recollection. Narrative therapy leads to higher organized and integrative thought, and it leads to a reduction of intrusive symptomology. So by using this technique of narrative, it actually gives you a measure of memory integration. It is quite a powerful technique. All right, any thoughts or questions? Truly inspiring work. Well, there's some great work being done out there, but here you actually could hear, you're listening to the client, you have a record of the way they're talking about the memory, and over time, by telling you the story over and over again, they talk about the story differently. Why? Because they're integrating it. Truly brilliant way. Again, I don't do narrative analysis like this, but what I definitely do there is, as my clients are telling me the story, I take little notes, like I'm noticing more integrated thought. I'm noticing less repetition. And that's when you can know when, wow, look at that. They told you the story now 30 times, and it's a much more clear story. It's a much more direct story. It's a much more organized story. All right? Let's move on to the final topic, borderline personality disorder. All right? So criteria for borderline, you're all aware of. You've all, at some point in your life, experienced borderline. All right? So you have here the DSM-5 criteria for borderline. All right, so as you know, the highs and lows of borderline are both in mood and in relationships, right? So there's a frantic effort to avoid abandonment. So if I'm in a relationship right now, I'm going to hold on to you for dear life. It's got attachment tones, right? Unstable interpersonal relationships. I love you, I hate you, right? I love you, you're the greatest person ever. I hate you, I'm going to kill you, right? That high and low, both on the emotion, relationships. Unstable sense of self, self-damaging behavior, right? Very reckless in their behavior. Suicide behavior, we know that in BPD, we have to do a suicide assessment probably every session, because they're at high risk for suicide. Suicide behavior, okay? Feelings of emptiness, recurring bouts of intense anger. They go from charming to angry very quickly. They can be very charming, borderline. They compliment you, they're charming, and suddenly, boom, they just go off in anger. So their mood swings are quite drastic. During stress, tendency to experience transient paranoid thoughts and dissociative symptoms, right? Things that they say, people spoke to me, God spoke to me, right? They could have those kind of transient experiences also. Now, the etiology of BPD is both nature and nurture. There are genetic components. BPD is highly heritable. There's also literature that says that it's connected to increased activation in the amygdala. So difficulties with emotional regulation and highly active amygdala. So there's definitely some limbic system difficulty here. So that's the psychobiology of it, if you want, the neurobiology of it. But there's also social factors. We also do know, there's a growing literature on that as well, that early childhood environment is going to be connected to BPD. So if you grew up in a very harsh home environment, sexual abuse, emotional abuse, a home that doesn't permit emotional expressions. These are things that are linked with the development of borderline personality disorder. All right, so separation, verbal and emotional abuse, interaction between emotional reactivity and family invalidating emotion. Families where you cannot have emotions. No emotions in our family, not positive, not negative, stoic, growing up, not permitting that. I had a client with BPD who described for me this kind of home environment of complete ice-cold interactions, zero emotions. And he describes that he had a baby sister, and his baby sister was born, and mom brings the baby sister back home. My client then is around 7, 8 years old, growing up in a completely cold, detached, no emotion, robotic. And the baby he's in a room with a baby, and the baby looks at my client is 7 at the time, and the baby looks so pretty and so cute. And my client describes that he was overcome with some feeling that he had no idea what it was. It was called love. He had no idea what it was. And he bent over and he kissed his baby sister on the cheek. And he became so scared. What did I just do? What is this? And he ran out of the room. And then he didn't go next to his sister for weeks later. He had no idea what happened here. What is this weird feeling inside of me when I see my cute baby sister? And then I went and I kissed her on the cheek. What kind of pervert, what kind of crazy, what did I do? And he was embarrassed. So he describes for me now like how he ran out of the room and he didn't want to see his sister now for weeks because he had no idea, what is this thing? What is this weird feeling? What is love? What is that? Growing up in that kind of home, he just remembers the horror of experiencing love. The horror of love. That's the kind of home environment that we're talking about. Now, we know it's very, very difficult to treat borderline personality disorder, right? These interpersonal problems that our clients have across the board play out also in therapy, right? So they try to manipulate you. The highs and lows, they play out with you in therapy. I've had clients who, during intake, say to me, I can tell you are the best therapist from all the therapists that I had at intake, right? That kind of, or client that says to me, within a 5-minute span, I'm alive because of you, doctor. And within a few minutes, I hate you. I don't know why you're practicing. I shouldn't be paying you. Within a 2 to 3 minute span, that love and hate, right? Or the fear of abandonment. There was one fellow that I had to cancel a session on him because I was doing a PESI event. And he got so offended. How dare I cancel a session? Wednesdays at 2 is our time together. How do you cancel? It's our time. Sorry, I could reschedule next week. So upset. I come back next week, Wednesday at 2. He sits down. And the first thing he says to me is, so you were in St. Louis, Missouri for a lecture. Is that more important than me? What did he do? He went on Google, he tracked me down, figured out where I was going to be, and he's like, right, he was stalking me. The fellow was stalking me, right? That, you're mine. You're mine. They drag you into their life. Most gifts that I receive from clients are coming from individuals with borderline personality disorder. Most gifts. Sometimes they give me gifts for my children. Oh, you told me you have a 10-year-old. Yes, by mistake. Here is a child. Here's the gift. Here's a gift for your child, right? They want to drag me in, right? And do you take it? Do you not? That's a whole other great discussion, right? That should be part of the therapeutic process, right? One client made for me a special cherry sauce. She comes around the holiday season, give me a gift, right? Because we're friends. She's mine, right? I'm hers. I made you my grandmother's special cherry sauce. I put all my heart into it. It's for you. Now I'm thinking, I can't eat that. That's not kosher. I'm not going to. So do I tell her or not? And I decide, yes, therapeutically, I'm going to do it. So I say, it's so nice of you to do it. It's so nice to make it. But I can't accept it. It's not kosher. I won't be able to eat it. She got so offended. She grabs it, storms out. And the following week, she was there. And how dare I not accept her present that she put her whole heart into, right? So those kinds of, I love you, I hate you, those kinds of dragging. Now, I understand what BPD is. I'm with you an hour a week. Imagine a spouse of someone who acts that way. Imagine being a son to someone with BTD. Imagine the pain of being a family member of someone who does this to you. Your mother who loves you and hates you. So a lot of the work now, there's a lot of literature about working with family members to help them understand, create boundaries. So by now, most of my clients with BPD, I'm seeing their family members also to help them understand what it is, not to be reactive, all right? Medications, often you want to try to use that as well. Identifying maladaptive assumptions. Imagine the core beliefs about abandonment, right? There's some serious core belief work that needs to be done there. Emotional regulation, social skills training, right? Right, that whole concept of shaping towards the target and modeling relationships, right? You therapists may be the only healthy relationship that they have across their relationships. Because everyone else, when they play their games, everyone else either runs away or yells at them and hates them. So where are they going to have one healthy relationship? That's you. You therapist, maybe that one healthy relationship that talks to them in a healthy way, creates boundaries, apologizes, says when I get offended, how to have a healthy relationship. You may be that model. So modeling the healthy relationship with the clients it's a very, very healthy process. All right? Let me wrap it up with a quick case study. A business executive came to therapy, clearly with borderline personality features. He came and he told me, I'm here, that you should help me convince my wife that I'm okay. Because my wife is making me crazy, so he clearly didn't need therapy. Turns out he had intense borderline personality features, anger issues, very abusive father, right? So it was a multi-year process. A lot of boundary violations, a lot of boundary work, a lot of core belief work about being abandoned, right? This fellow, I was seeing him during a time where I was spending summers in Israel. I was practicing here, but I was doing summers in Israel. So the first time I left him for a summer, it was horrific. How dare you leave me? And then the following year, when he suspected I was going to do it again, May time, he says to me, this is not working. You're not a good therapist. I'm leaving. It was a preemptive breakup, that he shouldn't be the one to feel the sense of abandonment. And then in October, he comes right back into my office like nothing happened. He's on my list. I say, oh, he's back. I haven't seen him for 5 months. He comes and sits himself down. You're not going to believe the kind of week I had. Like nothing happened. You dumped me 5 months ago. You didn't say anything. You just walk in there like nothing. I called him on it. Because in other relationships, no one takes that from him. They run away. They yell at him. It's like, explain something to me. Last time you stormed out of here, said you're never going to see me again. And now you walk in here like nothing. You know, I kind of wonder, what is that? So honesty, modeling that relationship. All right, let's summarize today. Core belief work with depression, anxiety. The important component over here is that we're constantly balancing the cognitive and the behavioral. One reinforces the other. Trauma work is about the memory storage, but it's also about that emotional connection that helps our clients beyond just restoring the memory. But there's something that's happening in terms of emotional regulation and validation and emotional neuron activation that's playing a role as well. The cognitive model offers the most validated intervention method. Truly, truly, the amount of research that now supports the use of CBT across client difficulties is quite overwhelming. And there's constant updates about new techniques within this model that are very effective. The use of both cognitive and behavioral tools and strategies have been shown to be effective in treatment of mood disorders, trauma, family-based turmoil, and the list is growing. It is really, really becoming quite exceptional. How many areas do you find the use of CBT? All right, you have a couple pictures of some books that I've written. My most recent book is Sibling Issues in Therapy. Chapter 9 is CBT and work with siblings in therapy. There's chapters about helping parents create closer relationship between siblings. There's a chapter about well siblings of children with disabilities. Often families with disabilities, the well siblings are neglected. What do we do about that? How do we help clients work with the well siblings of children with disabilities? You have a piece of that as well, all right? You have my contact information, anything that I said, anything that you want more information on, feel free to email me. My email is right here. You have my website over here also. Any questions, anything that I said you want more of, measures, anything that you want more of, feel free to email me. It's been a pleasure having you here. Thank you very much. Thank you.